rehabilitative. We advocate the use of technology and digital platforms with health sector to ensure access to high quality and affordable health care. Recognizing the transformative power of digital solutions,
Namaste and a warm namaste.
we have rolled out Ayushman Bharat Digital Mission, ABDM, to unify India's healthcare ecosystem. ABDM provides a unique Ayushman Bharat Health Account, Aabhak number, which is a hassle-free method of accessing and sharing health records digitally, registry of health professionals and health facilities, and a unified health interface which enable a variety of digital health services between patients and health service providers, including appointments, booking, teleconsultation, service discovery. The same way, under the ABDM, Ayushman Bharat Digital Mission, over 750 million Aabha ID cards have been created, and about 500 million health records have been digitally linked with Aabha IDs for seamless access to the health data. 360,000 healthcare facilities and 570,000 healthcare professionals have been registered. I am confident that this mission will bring about a huge transformation in healthcare delivery. Under the visionary leadership of our Prime Minister Shri Narendra Modi ji, Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, ABPM-Jai, was launched in 2018 with an objective of achieving universal health coverage. It is the world's largest health coverage and health assurance scheme, offering comprehensive secondary and tertiary care hospitalization benefits up to 500,000 per family annually. Recently, the scheme has extended to include all senior citizens of 70 years and above, irrespective of socioeconomic status. More than 610 million beneficiaries, that is about 40% of India's population, are covered under the scheme. More than 86 million hospital admissions worth 1.19 trillion rupees have been authorized under the scheme. In addition to these initiatives, we are focusing on primary and preventive health care through a huge network of more than 175,000 primary health centers, which we call as Ayushman Arogya Mandirs, and which is health and wellness centers, under the National Health Mission also. The Pradhan Mantri Jan Arogya Yojana, along with the services provided under National Health Mission and other schemes of Government of India, have led to the decline of out-of-pocket expenditure in total health expenditure from 64.2% to 39.4% in the last 10 years. In alignment with these policies and programs of the Government of India, Apollo Hospital has been at the forefront of providing patient safety, clinical excellence, and healthcare innovation. From leveraging technology for better outcomes to ensure quality-driven patient care, Apollo is showcasing what future of healthcare looks like. India is fast emerging as the healthcare destination for the world through Heal in India. We envision a future where patients from across the globe choose India not just cost-effective treatment, but for world-class solutions. With our skilled professionals, robust digital infrastructure, and a culture of care, we are poised to lead the global healthcare transformation. Platforms like international health dialogues fuel this movement, driving conversations, innovations, and partnerships that will define the next era of patient safety and healthcare delivery. I thank Apollo Hospitals and the organizing team for bringing together such an esteemed gathering together. I also thank Dr. Preeta Reddy, I thank Sangeeta Reddy ji, and I pay my respects and regards to Dr. Reddy, who has been the pioneer in healthcare and patient care. Let us all together, let us build a future where every patient is assured safety, dignity, and world-class care. Thank you very much for giving me a patient hearing. Thank you.
Thank you, sir, for your enlightening address. I request all of you to please strain your eyes to the screen. We have a very special keynote address by Dr. Pratap C. Reddy, Founder Chairman, Apollo Hospital Group. I request all of you to please stay in your seats and please give a huge round of applause to our chief guest, Shri J.P. Nadda, the Honorable Minister of Health. I would request for the playout of the keynote address by Dr. Pratap C. Reddy, Founder Chairman, Apollo Hospital Group.
Namaste and a warm welcome. It's truly my pleasure to witness the 12th edition of the International Health Dialogue. Today, with all the distinguished leaders and change makers from across the world and India, I am honored to welcome our chief guest, Sri J.P. Nadda ji, Home Minister for Health, Family Welfare, Chemicals and Fertilizers. As an outstanding level, as an earlier health minister, the future of healthcare is truly collaborative, and the International Health Dialogue 2025 is a testimony to India's growing influence in healing not just India, but the world. Over the past 40 years, I've been personally working continuously to establish India as a global hub for healthcare, and I'm very grateful to our Prime Minister of India, Sri Narendra Modi ji, enabling India's bold vision for universal health access with Heal in India. The International Health Dialogue 2025 is a global movement where we will always come together to innovate, care for one another, and push the boundaries in showcasing our clinical and scientific excellence in healthcare. International Patient Safety Conference has grown to become Asia's largest platform dedicated to enhancing patient safety and quality standards. With this year's theme, a new era of patient safety, IPSC focuses on harnessing new technologies and global best practices to build a culture where safety is non-negotiable. I'm very happy to introduce HOPE, the Healthcare Operations and Patient Experience Conference this year, first of its kind initiative that will focus on how operation efficiency and patient experience must go hand in hand. With IPSC, TIT, and HOPE collectively representing the International Health Dialogue, we at Apollo are taking a strategic step towards integrated healthcare transformation. Patient safety cannot advance without digital innovation, and operational excellence cannot be achieved without embedding both safety and technology. This is what Apollo has followed from day one. I welcome you once again and will look forward to the engagement and deliberations over the next 2 days. Together, let us embrace our collective vision of Heal in India and Heal the World. I wish we all work together towards making the nation and the world a healthier, happier homes. God bless.
We have with us a remarkable leader whose contribution to global healthcare and patient safety are truly unparalleled. Please join me in welcoming Dr. Jonathan Perlin to this podium. I request him to please address the audience. Please give a round of applause to Dr. Jonathan Perlin.
Namaste and good morning. It's a privilege and an honor to be with you here today, and we're gathered together because we know that our goal is perfection and healthcare is imperfect. It's really in that spirit that I want to extend my gratitude to the organizers of this extraordinary conference, to Dr. Sangeeta Reddy, Dr. Preeta Reddy, Dr. Pratap Reddy, to the ministers, and to each of you for working to make health and healthcare more perfect. That's really the first of my 5 points this morning. And let me just summarize those, is that if healthcare is imperfect, it's also brutally complex, more so than ever before, clinically, operationally, financially, and in my country, politically. AI, point 3, artificial intelligence, is the defining technology of our century. It has the ability to create a step change, a quantum leap in performance. At the same time, AI, point 4, is not just one thing. AI is a set of activities that can really allow us to embrace that step change. And that leads me to point 5, is that as health leaders, as health policymakers, as regulators, we have both the responsibility to assure the appropriate guardrails for the best use of AI, as well as making sure that we, as those who care for patients, who work in healthcare directly, define the way in which regulation occurs so that we can really take advantage of the extraordinary innovation. Now, I do have a presentation. If the slides are available, we'll go to those. If not, I'll speak from it. But let me start by just defining that our Joint Commission International is really a very international organization with some degree of activity today in 86 countries. I'm proud of the new team that we've assembled. Dr. Neelam Dhingra is here with us. She is our Global Chief Patient Safety Officer. You likely know her from her role founding the Patient Safety Unit at the World Health Organization. Under her leadership, we're introducing new programs, not only the standard accreditation, but in lower resourced areas, a pathways program for capacity strengthening to learn from some of the extraordinary advances that are being made in countries like India. Our vision internationally is that all people always experience the safest, highest quality health care across all settings. It really alludes to both performance as well as inclusion. Our work focuses on safety and quality and health, but also on the tools of performance improvement and achieving excellence. Now, if healthcare is imperfect, let me share with you the magnitude of that imperfection. According to a study by Andrew Auerbach at the University of California at San Francisco, in the United States, 23% of patients who die or deteriorate in hospital where they're supposed to be safe, do so because of a missed or misdiagnosis. That's really extraordinary. That study is only a year old, and that's from an academic medical center. How complex then, point 3, is healthcare? Well, let me put this in perspective. When the telephone began to become popular in the United States in the 1900s, early 1920s, there was a study as to how many digits a phone number should be. And those people who were trying to advance this technology actually went to the psychological literature to look at the number of variables that we humans could manage simultaneously. Turns out that we can manage about 5 to 9 variables at the same time. So they chose the intermediate at 7. You probably know that to figure out the number of combinations of variables, you multiply the number of variables by every successive number before it. So for 7, it's 7 times 6 times 5 times 4. And I know that you've already figured out that's 5,040. Okay. According to Dr. Bill Stead at Vanderbilt, in the average ICU, there are 1,300 data points every hour. There are 1,000 new pieces of information based on the monitoring of a patient in an ITU, and there are about 300 orders in effect. How big, then, is 1,300 factorial? Is it a million? Is it a billion? Is it a trillion? Not even close. That number is the head-spinning number of 3.16 times 10 to the 3,485th power. How big is that number? I want you to imagine every grain of sand on a beach. Not even close. I want you to imagine every grain of sand on the planet. that created them. And this leads me to point 5 and my final point, which is that we as leaders have both the responsibility to assure the responsible use of health information, but even more, and Drs. Reddy, as is so apparent here in India, we need to be the agents of change because, as I said at the outset, and as you know, healthcare is imperfect, and even if we never reach the goal of perfection, the only right level of harm, avoidable harm, is 0, and we need to be those agents of innovation and change. And it's in that vein that it's such, again, a privilege to be with all of you, and thank you for your innovation, for your leadership, and your passion for our shared mission for improved healthcare. Thank you so very, very much.
Thank you for illustrating for us the astounding capabilities of AI in healthcare. We are honored to have with us a visionary whose expertise and dedication have made a profound impact on the advancement of healthcare standards worldwide. Dr. Carsten Engel, Chief Executive Officer, International Society for Quality in Healthcare, ISQUA. I request Dr. Engel to please address the audience with his keynote address. Please put your hands together for Dr. Engel.
Namaste. It is an honor and pleasure for me to be able to speak here to you today. Patient safety. We are still not there. We are not at a point where care is as safe as we would wish it to be, as it can be, but we are at the point where we are able to create a roadmap on how to make it happen. For what is the problem? Is the problem that we don't know how to improve safety? No, we know a lot actually. How do I change the slide? Okay, as a very high level roadmap, we have the WHO Global Patient Safety Action Plan 2021 to 2023. I think there has been a little bit confusion about the slides, so I'll talk a little bit more freely. A recent report from the WHO demonstrated the point I made at the beginning, that we are not there. It's still the case that 12% of patients experience harm across medical care settings. As much as 12% of adverse events cause permanent disability or patient death. Unsafe care causes more than 3 million deaths every year, and around 2/3 of them occur in low and middle-income countries. Is the problem that we can't afford patient safety? I would say the data say that we can't afford not to. I would have shown you a graph of the world gross product from 2000 to 2021, and you will see that the actual product is 15% less than it would have been expected to be if there had been no medical harm. From year to year, the loss may seem moderate, but it accumulates to a very large loss over a period of years. So, we have this high-level roadmap on how to achieve a more safe care, the WHO Global Patient Safety Action Plan. It's a set of 7 strategic objectives, each with 5 actions, which leads us to 35 strategies that we should improve, and there are actions described in the patient safety plan at all levels of healthcare, at national level, at facility level, for stakeholders and for the WHO Secretariat. So, how are we doing in relation to this excellent roadmap? Well, not too well. You can see it on the slides that's actually on the screen now. It's from the WHO report on the World Patient Safety Status 2024. Notice that the outer limit of this radar diagram is unfortunately not 100%, it's just 70%. So there is still a way to go. Actually, strategic objective number 3, safety of clinical processes, is performing best, but still far from perfect. In the report, you will see data for all 35 strategies, and it's summarized across each of the WHO regions. As expected, there are regional differences, but no region has met the targets, and even in wealthy regions, there are strategies where the score is only on a basic level, less than 4 out of 10. Now, I come from ISQA, and I would like to show to you some ways in which ISQA works to bridge the implementation gaps. One of the principal aims of ISQA is to support accreditation, a tool that we know is a very important and effective tool for safety management, but we have other offerings as well. We established a patient safety task force, a group of experts, in 2024 at the suggestion of the WHO Patient Safety Flagship. The task force establishes one-year actions plan and is now close to completing the first year. Uniting for Safety is a coalition of organizations who all work to promote and improve patient safety and realize that identifying and collaborating on some shared priorities, aligning without competing, would provide mutual support, increase advocacy, and accelerate global progress. The priority for the first year of this Uniting for Safety coalition is measurement of patient safety impact. We know too little about this, but as you can understand from the speech Dr. Jonathan Perlin held to you just a moment ago, AI offers us a very good opportunity to increase our knowledge significantly so that we really know where we are and how we progress. And finally, we have some education offerings as well. We have the ISQA Fellowship, and in India we are perhaps best known for the webinar series that we offer in cooperation with CAHO. Back to accreditation, we map the alignment between the 35 strategies of the Global Patient Safety Action Plans with the standards that follow the ISQA principles for accreditation standards, and for 21 of the 35 strategies, there was an alignment, and the remaining 41s are largely strategies that are not likely to be, where accreditation would not be the right tool to support them. So accreditation is one way you can locally use to help follow the global roadmap of the Global Patient Safety Plan. Accreditation supports prudent standardization and in addition guides the establishment of a framework for promoting safety, because safety promotion now is very much a question about leadership. We know what we should do, we need to know how we can make it happen actually. And this framework includes strong common aims, goals and values, clarity about responsibilities and accountabilities, and a strong framework to support team building, teamwork, and team training. You can't create a survival guide, a book that will tell you how to do everything. Prudent standardization, I like to compare to having a good toolbox. That it must allow you to be flexible and adaptable when needed. You can't capture safety into a rule book, but if you have a well-equipped toolbox, you will be able to pick the right tool for the right situation. You will be able to adapt and adjust as needed while understanding what you can and should adjust and what you should definitely not adjust. Accreditation has been around for a long time, and in ISQA we are aware that accreditation needs to develop and to have and we have initiated a process to allow our international accreditation program, which is a kind of umbrella program for healthcare accreditation, to support and guide the development towards accreditation 2030. Not to replace everything that has worked well until now with something else, but to use a spectrum of approaches for different purposes. Standards should not just be a compilation of criteria that characterize a well-performing organization, but they should also set an agenda to achieve a defined aim. If something is written in a standard that will become an assessor against, it will surely be on the agenda. Examination of processes for compliance with requirements will be played down, while processes will instead be examined to understand why outcomes are as they are. Judgment will be based less on process compliance and more on outcomes, and reporting will focus on mechanisms rather than on mere tick-box style compliance. Instead of telling you what you should do, standards and the entire accreditation process will help you achieve what you want to achieve. The classical survey methodology will continue to be used, but more data sources, including quantitative data from a broad range of sources, will contribute to assessment, and no doubt AI will revolutionize the way in which we perform accreditation. Now a little bit back to the Patient Safety Task Force. We will soon publish a white paper, and the lead author is, by the way, Dr. Anuradha Pichumani, who is with us today. It is intended as a guide on a facility level how you can translate the action plan into a roadmap for your own organization and facilitate what's happening at your own organizational level. Of course, there's no magic bullet that will achieve patient safety. You need a multi-pronged approach. You need prudent standardization, as I told you about, but as you need to leverage human factors, science to design safe processes, leverage the power of teamwork including teamwork with patients and families, build a culture of safety, build a resilient system. In complexity, you cannot have a pre-programmed, surely working system. You must build it up to be resilient, but of course with fail-safe components wherever needed. Co-produce safety with patients and families. Improve using principles of change management and implementation science. That's something you should really be concerned about, but because change is not just a technical intervention, it is about making people change their ways, their beliefs, their habits. And of course, you should leverage technology, including AI. You have heard a lot of this already. AI can, we know about a lot of AI-based tools that can improve clinical processes, but AI will improve risk management, quality management as well. We can identify errors and anomalies in real time. We can provide personalized and accurate predictions and preventions, early detection of adverse events, and we can improve, just a small but important thing, we can improve measures based on medical chart reviews. But of course, if we overly enthusiastically adopt AI-based applications that have not been sufficiently evaluated, there is a risk. We know that AI-based tools are prone to bias, hallucinations, and we need to ensure that the interfaces between the AI and the professionals and the patients will be using AI as well, is important. And of course, there are considerations of values and ethics. So we need good digital health governance. It's actually not different from clinical governance in other domains. We need direction with long-term goals, a framework of assessment, costing, implementation, monitoring and evaluation of use, involve staff and patients at all stages. Be sure to leave no one behind. Make sure that there's accountability. And while AI has a tremendous potential, it's not about automation, it's about collaboration between human and AI. And with this, I will conclude that a learning healthcare system is the road to safe care, and AI and a lot of tools will help us to become that. Thank you.
Thank you. Thank you for reinforcing the foundation pillars of patient safety. We are very honored to have with us Dr. Vinod Kumar Paul, Member Niti Aayog. I would request him to please come up on stage. Please give a round of applause and welcome on stage Dr. Vinod Kumar Paul, Member Niti Aayog. right. We are deeply honored to welcome an extraordinary leader whose vision and commitment have transformed healthcare worldwide. Dr. A. Mark Harrison, co-founder and CEO, Health Assurance Transformation. Please give a round of applause and welcome Dr. Harrison. I request him to please give the keynote address.
Good morning, everybody. I'd like to express my deep thanks and gratitude and admiration for the Reddy family and for what they've put together here today. I think the idea that we're combining IT and safety and quality is exactly the right thing for this world at this moment. I'd like to sort of make my remarks extremely conversational with you. And I'd like to tell you a story, and I'd like to tell you a story about how my career and journey have evolved. And I think that will help you understand exactly why all of you are in the right place at the right time. Our world is at an inflection point, healthcare is at an inflection point, and you are the key players in changing things for India, but for the rest of the world as well. So I'm a simple doctor. I am a pediatric ICU doctor who had the privilege of serving in some good systems and taking care of lots and lots of kids. And I'm a person who's impatient, and I'm a person who seeks goodness for the people I care for and the people I work with, and as such, have made change wherever I've gone. My path led from the bedside, hundreds and hundreds of nights sitting at the bedside of critically ill children, into executive leadership, not because I sought executive leadership, because I was impatient for change for the ones I could serve. And I could see the gaps that they experienced, and I could tell the pain that their families suffered when we didn't live up to the standards that they deserved and expected. That path led me from the bedside to an executive suite at the Cleveland Clinic, and from the executive suite at the Cleveland Clinic to Abu Dhabi, where I was privileged to be the founding CEO of Cleveland Clinic Abu Dhabi. There, I had an epiphany and an experience where I began to experience the diversity of the world in an incredibly powerful way. And I could see amongst the 70 different countries that our caregivers represented that the commonality for all of us was around our passion for healing our fellow human beings. From Abu Dhabi, I went to London and began to work on another project there and had exposure to the NHS in a very deep way and could see the desire and the power of the payer-provider model, yet all the imperfections associated with that great system. From London, I went to Intermountain Healthcare in the Western United States, famous for safety and quality, famous for operational excellence, but limited in terms of scope and geography. There, we went from a single state of care to 7 states, and we went from a revenue of about $5 billion to about $15 billion in a period of 6 years. More importantly, we went from average safety and quality to top decile safety and quality in just about an 18-month period of time, proving to me that it was possible, if we played as a team, to do extraordinary things for patients. We sought to make each person a story. When we reviewed safety and quality at Intermountain Healthcare, and we put graphs up, what I asked is that for the patients that we harmed and killed, we put little tiny figures of humans. I wanted each and every person to understand that when we made an error, it was a family that we impacted. It was a patient that we impacted. I became both inspired and frustrated by the application of technology at our system. I had the privilege of leading through the pandemic. I had the privilege of working as a large multi-state system to make sure that people had access to clinical trials, excellent clinical care, as well as an opportunity to take care of our own caregivers. What I found is amongst the 60,000 people who worked for me, we lost twice as many caregivers to suicide as we did to COVID. Why was that? People were exposed to death and destruction at an almost military scale. They were stuck in very difficult situations with angry patients and in some cases an angry society that didn't support them and led to their burnout. And we discovered that technology, although important, was imperfect. So coming out of the pandemic, I began to take stock of the headwinds that we faced, and I believe these are the same headwinds that you're facing right now. They're the fatigue of our healthcare workers. The system is brittle, and little bumps in the road, whether it's a supply chain problem, whether it's inflation, whether it's workforce shortages, all amplify to create a system that's very difficult to navigate for you and for me and for everyone we're meant to serve. That lack of coordination leads to some of the bad outcomes that Dr. Perlin discussed. Let me give you an example. I had a good friend, a gentleman who had a family history of pancreatic cancer and a known genetic predisposition for him to have it as well. He sought out the very best medical care that he could afford and that he could find, and he was told that he should have imaging of his belly every 6 months in addition to getting blood work drawn. He did exactly what he was told. He was at a great institution, a famous academic institution, and they said he was fine. One day, he developed jaundice and back pain and went in and discovered that he had massively metastatic pancreatic cancer. This is a gentleman who had 3 beautiful kids and a loving wife and a good career and was making a difference in the world. When we went back and had his studies looked at again, it was discovered that the radiologist had missed a small 1 centimeter mass in the tail of his pancreas that should have been completely resectable if, in fact, he had had an AI overread of the study. And his children, unfortunately, that did not happen. He rapidly decompensated, he died, and he left his family alone. What we know is that technology can make a big difference. But what we also know is that point solutions and single apps don't really help. They provide increasing discontinuity and expense in healthcare, which is exactly what we don't want. So, okay, here we are at this moment. We have all the headwinds that I described, expense, workforce shortages, et cetera. But we also have a moment in time where everything is coming together so that we can all make a difference. What do we have? We have massive computing power. We have huge amounts of data. We have algorithms that can allow us to make sense of data in a way that we've never had before. And we now, and I know you're going to hear about it over the next couple of days, the opportunity to create agents, nurses, doctors, other professionals, who can assist our human caregivers and provide that one-on-one care to make sure that things don't get missed. Let me give you an example. There's a company that I work with that we've helped create. It's called Hippocratic AI. It has ingested the data of 12 large health systems and created assistants who can actually care for chronic care patients. These people can explain, these entities can explain laboratories, they can explain care pathways, they can make appointments, they can provide next steps for patients, and instead of a human who would cost, in our world, about $90 or $100 an hour to hire and support, it can be done for 19 cents an hour. Every single one of us can and should have people, have entities, have tools that allow us to have really great coordinated health care. Why is now the moment? The moment is important because we recognize in very stark ways that our system is failing those that we're meant to serve. I don't believe that Dr. Perlin mentioned, but about 10 years ago when the American healthcare system looked at how many patients per year were killed from medical errors, it was around 100,000. Recent data suggests that despite all of our hard work, it's now 200,000 people a year die. I suspect many of the same issues plague Indian healthcare. Now is the moment for us to show the humility, to change our operations, to lead with heart for the people we serve, to incorporate technology fully into everything we do, and maintain our humanity in an effort to make healthcare accessible, affordable, equitable, and to provide hope for people. Let me speak to you very directly as leaders. It's absolutely 100% clear that organizations do what the CEO or the boss says to do. Where you spend your time, where you use your words, where you put the emphasis, that's where your organization will go. And I suspect in this large room, there are millions and millions of people who are following you. If you tolerate poor performance, inhumanity, lack of forward progress, your organizations will as well. On the contrary, if you lead with courage and you act with courage and you act with humanity, your organizations and those millions of people will follow. I'd like to finish with a very short Arabic proverb, and what it says is, he who has health has hope, and he who has hope has everything. The everything for the 1.3 billion people in India and the rest of their neighbors around the world are in your hands. And my call to action for you is to lead that change. I look forward to seeing you at the conference. Thank you very much.
To formally extend our vote of thanks, I now invite Mr. P. Shivakumar, MD, Indraprastha Medical Corporation. I request him to please address the audience. Please put your hands together for Mr. P. Shivakumar.
Honorable Health Ministers on the dais, Joint Managing Director, Apollo Hospitals Group, Ms. Sangeeta Reddy, Jonathan, Mark, and Karsten, and others on the dais as well as on the audience. It's my absolute delight to stand before you and propose this vote of thanks and heartfelt gratitude on behalf of Apollo Hospitals for the Honorable Union Minister's presence earlier in the meeting and for his inspiring words to all of us to make India a very, very strong, healthy nation. I'd also like to extend my sincere appreciation to all senior dignitaries, policymakers, esteemed representatives from various governments across the world, healthcare institutions and regulatory bodies. Your support, participation underscores the shared vision we share to place patient safety at the forefront of healthcare. A special note of gratitude to my senior leadership in Apollo Hospitals, our chairman, Dr. Reddy, and Ms. Sangeeta, Joint Managing Director, Vice Chairperson, Ms. Preeta, Ms. Sunita, the Managing Director, and Ms. Shobna, for their continued efforts for spearheading this crucial dialogue year after year. The unwavering commitment to advancing patient safety and fostering meaningful discussions has been instrumental in pushing the boundaries of healthcare excellence. I'm sure all of us will find implementable solutions from the conversations that we are going to have today and tomorrow, and making tangible improvements that benefit every patient we serve. Thank you very much. Jai Hind.
Thank you. Please give a huge round of applause to all our esteemed dignitaries on stage. Thank you so much for your enlightening words. They do set a perspective for the conference of the day. We will continue with our session on global perspectives on digital health in this hall. The delegates who are attending the Patient Safety Conference are requested to move to the hall next door where the conference continues there. And we are very delighted that we have with us our distinguished guests of honor, the health ministers from Maldives, from Guyana, from Eswatini, and from Fiji. We request you to please remain seated. And I would like to invite on stage Dr. Vinod Kumar Paul, member Niti Aayog, who is also going to be part of this keynote panel on global perspectives on digital health. I would request Dr. Sangeeta Reddy, Joint Managing Director, Apollo Hospitals Group, to please welcome Dr. Paul with a token of our appreciation and felicitate him.
Good morning, everyone. May I request delegates of International Patient Safety Conference as well as Hope Conference to please move to the plenary hall. Entrance is just the next door from either this level or you can also go from level 4. Thank you.
Right, we'll just give 1 minute for everybody to settle down. And we thank our distinguished guests who have addressed the audience. And if they wish, they can, of course, take their seats off the stage. But we request the Honorable Health Ministers from Maldives, Guyana, Eswatini, and Fiji to remain seated along with Dr. V.K. Paul. We are very privileged that we have global leaders in healthcare with us to discuss the evolving digital health landscape, where innovation is making a sustainable impact beyond the initial excitement and hype. Right. I would request Dr. Sangeeta Reddy to please felicitate Dr. Vinod Kumar Paul, member Niti Aayog. We are very grateful to Dr. Paul for coming here, and we look forward to hearing his views on the global perspectives on digital health moving beyond the hype. Thank you, ma'am. A relentless advocate for digital transformation in healthcare, Dr. Sangeeta Reddy has played an instrumental role in shaping policy, fostering innovation, and ensuring that healthcare solutions remain patient-centric and accessible. I would request Dr. Sangeeta Reddy, Joint Managing Director, Apollo Hospital Groups, to please steer this discussion forward.
Morning, ladies and gentlemen. Let me begin by thanking all of you. I know many of you were disrupted by traffic. We had a lot of VIP movement. It was an early start. You've traveled long distances. You have, really been a part of this movement. I want to begin by saying a big namaste and a thank you. It's also my pleasure and privilege to be able to share the dais with health ministers from our neighboring countries. Let's give them a big hand. This session is also a very special session made so by the presence of Dr. V.K. Paul, our member of Planning Commission specializing in health. His thoughtful nature, his deep insights, his passion for healthcare, and his ability to go straight to the point and call out what needs to change. Dr. Paul, we respect you. We thank you for your contribution, and we're very, very happy that you're here. I have the honor of calling upon ministers from various countries to request their insights, their thoughts. Your Excellencies, India looks to be a partner. India looks to share what we can in terms of knowledge. And we look to collectively come together for a safer, healthier world. We have gathered here experts from across the world because every single person here cares. I want to begin with a story. And this is a story many of you may have heard. And I think it's also coming so much to the forefront. Some of our guests are from Los Angeles, where there should not have been fires, but they were. So there was a large forest fire. And the bears started running, and the tigers ran, and the jaguar ran. And then the jaguar saw a hummingbird flying towards the fire and said, "What's happening?" But the jaguar kept running away from the fire. And then the hummingbird flew again away from the fire. And the jaguar saw the hummingbird fly back to the fire. He saw this 5 times, and then he said, "Hummingbird, what are you doing?" And the hummingbird said, "The forest has nurtured me. The forest has taken care of me. The forest helped me grow. How can I stay away when the forest is burning? I'm going to the lake and carrying water in my mouth and helping to put out the fires." Could the little hummingbird handle the enormity of the forest fire? Probably not. Can each one of us individually handle the enormity of global healthcare? Probably not. And you may think that we're saying at least, they helped a little. But actually some magic happened. Because the gods or the spirits or the forces that exist saw the effort of this tiny hummingbird, saying, "I must do my part." The gods sent torrential rain. The fire stopped. This is the power that when each one of us steps forward to do our part, we can create change, whether directly or indirectly. Magic will happen. So that is your collective power. Please, let's come together to make magic happen. That's what we're here for. Let each one of us do our part towards a safer, better, more evolved healthcare system. Let us use our data. Let us integrate our systems. Let us talk seamlessly. Let us focus on preventive, proactive healthcare. Collaborate with scientists. Push forward the path of new cures. Be empathetic and understanding of the pain of not just the patient, but the entire family. And change every pathway possible to not just cure and heal, but to prevent disease. There's a brave new world out there that all of us are creating together. That's what this conference is about. Thank you so much for being here. During the next 36 hours, you will hear about artificial intelligence. We will talk about ethics in its use. You will understand the pace of change and of evolution of artificial intelligence in clinical work, AI across the realm. But the fact that if the data is skewed, if the ethics are not appropriate, if the model is not explainable, if it is not sustainable, and we will find solutions. You will hear about science and technology and pathways and dashboards and analytics. You will understand that all of us together can make that change, and each one of us are a part of this collective future. We will focus on preventive healthcare in a way that we have never done before. But most importantly, we will understand global workforce shortages, new pathways, care enablement, operational efficiency, and methodologies to bring change. I want to take a minute to thank all the people who have helped put this together, all our sponsors and all our partners, and then call first to the dais to speak His Excellency Abdullah Nazim Ibrahim, the Honorable Minister of Health for Maldives. It's a beautiful country, and this minister has been instrumental in advancing Maldives' healthcare system. Born in Hinavaru, he pursued higher education in the University of Auckland. His career in public service began as the Deputy Minister of Education, and we know that education is so critical to healthcare. Thank you, sir, for being here. In recognition of his leadership and commitment, he was appointed the Minister of Health in 2016, a role he has held. And now, after serving as the Principal Secretary and the President on Public Policy, His Excellency Abdullah Nazim Ibrahim, may we please hear from you. Thank you, sir. Please come to the dais.
Bismillahir Rahmanir Rahim. Good morning, everyone. It's a privilege to address you today on a topic that is significantly influencing the future of healthcare, digital health. I'm grateful to Apollo Hospital Group for organizing this event. Such collaborations are essential as we navigate the challenges and opportunities of digital transformation in healthcare. We all know that global disease patterns are constantly evolving, with an increasing burden of non-communicable diseases posing significant challenges. The way forward to sustain quality healthcare will heavily depend on embracing technology right from preventive health to diagnosis to treatment. The COVID-19 pandemic underscores the importance of digital tools such as telemedicine, electronic health records, and AI-driven analytics in ensuring uninterrupted healthcare delivery. Today, digital health presents an unprecedented opportunity to create safer, more efficient healthcare system worldwide. Digital technology has always brought forward the opportunity to introduce higher reliability systems that help address human errors which are persistent in our health system. South Asia is also embracing the benefits of digital solutions with the increased adoption of telemedicine and virtual care. While the Maldives is a small island nation, our commitment to digital health is ambitious and forward-thinking. Under the esteemed leadership of His Excellency President Dr. Mohammad Moise, the government of the Maldives is fully committed to leveraging technology and enhance healthcare system and improve healthcare delivery. Today, I am proud to announce we are getting ready to unveil the Maldives Digital Health Blueprint, a visionary framework designed to leverage technology to bridge healthcare gaps, improve access, and enhance patient outcomes. This blueprint is more than a policy document. It is a comprehensive roadmap outlining the development of a federated digital health architecture, ensuring interoperability across public and private health facilities. It introduces person-controlled personal health records, empowering individuals to manage and securely share their health data. A national telemedicine initiative, set to be fully operational within months, will ensure equitable access to healthcare, especially to remote island communities. Meanwhile, we already introduced digital platforms for primary healthcare, vaccination, and electronic health records on a live course platform. With these initiatives, the Maldives is positioning itself as a regional leader in digital health among small island developing states. While digital health offers immense potential, we must also acknowledge its challenges. Data security and privacy remain paramount. Patients must have full confidence in the confidentiality of their medical records. This necessitates strong cybersecurity frameworks, continuous system monitoring, and regulatory oversight. Moreover, technological errors, software vulnerabilities, and algorithms biases must be rigorously tested, validated, and monitored. As policymakers and global health leaders, we must work collaboratively to ensure the digital transformation enhances rather than compromises patient safety. Another critical issue is the digital divide. We must ensure that no one is left behind in this transformation. Digital health solutions must be tailored to local contexts, ensuring they are affordable, user-friendly, and accessible to all, regardless of socio-economic status, geography, or technological literacy. Moving forward, we must embrace a proactive, collaborative approach. To maximize the potential of digital health, we need to develop robust regulatory frameworks that foster trust and accountability, invest in research, innovation, and capacity building to empower healthcare professionals with digital skills and promote global interoperability, ensuring seamless data exchange across borders while maintaining stringent data protection measures. We look forward to strengthening partnership with India and global stakeholders to accelerate progress and share best digital health practices. I would like to once again thank you for Apollo Group for providing this opportunity and taking this proactive initiative. Thank you very much. Have a pleasant day. Wassalamu alaikum wa rahmatullahi wa barakatuh.
I'm honored to call upon His Excellency Dr. Frank C.S. Anthony, Minister of Health, Guyana. Frank Christopher Stanislaus Anthony has been serving as Guyana's Minister of Health since August 2020. He earned his medical degree from the Russian People's Friendship University in Moscow and a master's in public health from the Hebrew University in Jerusalem. He has a distinguished career in public health. He has served as the Executive Director of the Health Sector Development Unit within the Ministry of Health, where he managed significant healthcare reform. His political career includes a tenure as the Minister of Culture, Sports, Youth, and he has been instrumental in advancing Guyana's healthcare system, particularly enhancing public health policy and administration. Your Excellency, we're honored to call you on stage.
Thank you very much for that warm introduction, Dr. Reddy. First of all, allow me to thank the Apollo Group for this invitation to be here and to thank all the other organizers who have helped us and keep the hospitality here has been fabulous. I want to first start by extending warm greetings from Guyana. For those of you here in India, you might know Guyana because of our cricketing heroes. You might know of Clive Lloyd, Rohan Kanai, Alvin Kalicharan, and more recently, Shivnarayan Chandrapal. They're all from Guyana, so if you didn't know where Guyana was, now you know. We share that passion of playing cricket, and I think that's one of the games that unify us all together. But I think in recent times, there are other new avenues in where we can get together. And that is, we share a passion for bringing our countries together. And more recently, we were extremely honored to host the Prime Minister of India in Guyana and the External Minister in Guyana. And with their visit, we have been able to sign a number of agreements in different sectors, but more importantly, we had several agreements that were signed in health. Guyana now recognizes India Pharmacopoeia, and we hope that with increasing collaboration, that we can look forward to collaborating in the area of digital health. Over the last 4 years or so, Guyana has been undergoing a massive transformation in its healthcare industry. We, as a country, as a small country, the government of Guyana provides approximately 90 to 95% of care for the population of Guyana. And we want to make sure that our population can have access to care across the country. It doesn't matter where you live. And we believe that digital health is one way in which we can improve that quality of care. We have started out over the last 3 years by improving digital health legislation. We have passed legislation dealing with data protection and protecting patients' information. And having passed that piece of legislation, we are now in the process of ensuring that we roll out a national electronic health record system. So by March of this year, we have a company that we have partnered with from the UK that would be assisting us in rolling out our electronic health records. We have also recognized that if we're going to do this, that every person in Guyana would need a unique identifier. And so that's a system that we have created. So with the new electronic health records, that we'll be able to roll this out seamlessly. Apart from that, one of the things that we've been working on is to extend care. And we started a project about 2.5 years ago of using telemedicine. Currently, we have 84 sites in and around Guyana, and already with those sites, we're seeing the benefits of having telemedicine because we can offer at these various sites teleconsultations, but apart from that, we can do various forms of diagnostics. So a village that is perhaps maybe 600 kilometers away can connect with one of our hospitals and get guidance from maybe a consultant or a doctor there so that they can help with the interpretation of ECGs or do an ultrasound and they can be guided. And if there's a need for us to do a med evac for that patient, then we are able to do that seamlessly. But telemedicine has helped us to improve care, especially in our rural communities. We're also using telemedicine in some very specific applications. So for example, last year we introduced telepathology, and one way in which that has helped to improve care, prior to introducing telepathology, it used to take us maybe about 3 to 4 months before we get the results from a biopsy sample. Now we have reduced that waiting time between 3 to 7 days. So this has improved care tremendously, and we are hoping that maybe we can partner with persons here who might be able to provide us with the analytics for telepathology. Right now we are using some providers in the US, but we are open to exploring other partnerships. We have also been digitalizing our imaging, and with the digitalization of imaging, we want to use AI to do the interpretation. We've heard a lot this morning about the use of AI and its applications, and we know that in India, you have several systems here that can at least help with the interpretation, or maybe in the first read, be able to take out those that are normal so that the radiologist can focus on those with pathology. And by doing that, we can improve the rapidity with which we can offer quality care. So teleradiology is something that we want to
at least once in their lifetime. Think about that for a minute. At the same time that we are dealing with issues with quality, access to healthcare remains one of the greatest challenges of our era. And this is not an issue with low-income and mid-income countries. Even the most advanced, economically advanced countries in the world have challenges with access to healthcare. These persist due to socioeconomic, geographic, and systemic barriers that prevent patients from getting the care that they need, and the means for livelihood at risk. If healthcare is to remain a fundamental right, we must find ways to ensure that it is not only accessible and safe, but is also financially sustainable. And as we speak today, war, mass migration, and climate change are further exacerbating these disparities in healthcare. Armed conflicts continue to devastate healthcare infrastructure, displacing millions and leaving entire populations without access to even the most basic care. Mass migration, which is often driven by violence, persecution, and economic instability, has created a global crisis. At the same time, climate change is intensifying the pressure on public health. It increases the prevalence of vector-borne diseases, heat-related illness, food and water insecurity. Healthcare systems must adapt to these realities, ensuring that resilience, equity, and patient safety remain at the core of our response. So it is in this context that we are holding this international health dialogue. It could not be more relevant to the pressing issues that healthcare faces today. The IPSC driving the next frontier in patient safety, transforming healthcare with technology which harnesses digital health and innovation to improve care, and the Healthcare Operations and Patient Experience Conference, which aims to optimize healthcare delivery and patient outcomes. So how do we get from where we are to where we need to be? Achieving true patient safety requires a fundamental shift in our approach. First, we must transition from reactive measures to proactive and system-driven interventions. Secondly, we must foster a culture where every individual, from the frontline clinicians to the highest level of leadership, shares accountability for patient safety. And lastly, we must harness technology, data, predictive analytics, and AI to anticipate and prevent harm and to improve access to care. So when we look at the future, we must recognize this power of technology. I'm convinced that this current generation of artificial intelligence and technology has the capability to uncouple the inputs from the outputs that health care needs. As Jonathan Perlin said earlier, this is a step function in how we deliver care. The integration of artificial intelligence, precision medicine, and advanced decision support tools holds potential to tackle some of healthcare's most persistent gaps and solve issues around diagnostic accuracy, treatment optimization, and safe care. By leveraging each one of these advances responsibly and effectively, we can build a healthcare system that is not only safer, but also smarter, more personalized, and more resilient. So let us all commit to this. Let us all commit to this vision, not just with words, but with action. Thank you all.
Thank you, Dr. Madhu, for your insightful and compelling address on setting the context of International Patient Safety Conference 2025. Your deep expertise and global perspectives have provided us with a strong foundation to navigate the complexities of patient safety in an interconnected world. A very important learning from this session: a small fatal error can lead to a disaster. Thank you so much again.
Right. As we move forward, let me introduce you to the next session, Ever-Evolving Care Continuum. To enlighten the rapid advancements in medical technology, digital health solutions, and patient-centric models, the care continuum is shifting towards greater accessibility, efficiency, and quality. Integrated healthcare systems, AI-driven diagnostics, remote monitoring, and value-based care is redefining patient safety and outcomes. To proceed this session, may I invite Dr. Preeta Reddy, Executive Vice Chairperson of Apollo Hospitals Limited. Please, ma'am. A pioneer in patient-centric care and a driving force behind the Apollo Hospitals' commitment to excellence. She has been an instrumental in shaping the future of healthcare innovation and safety. Welcome, ma'am.
Along with her, let us invite our esteemed speakers for the session. The first speaker, Mr. Manish Goyal, COO, Mayo Clinic. May I please request you to join the stage, sir? Chief Operating Officer of Mayo Clinic platform and drives its growth and financial performance. Mr. Goyal brings a cross-disciplinary background in finance, investing, product development, and engineering. He was most recently the Vice Chair of Corporate Development at Mayo Clinic.
With this, we have Dr. Atul Mohan Kochar, CEO, National Accreditation Board for Hospital and Healthcare Providers, NABH. May I please request you to please join the stage, sir?
He was awarded the University Gold Medal for excellence in the field of dermatology, venerology, and leprology. Over to you, ma'am, to proceed with the session.
Namaste, everyone. And it is an honor to chair a session like this, because I think responsibilities are there with healthcare providers, responsibilities to deliver the best-in-class healthcare in whichever situation we're in. And you heard Dr. Madhu earlier telling us as a clinician, as an administrator, how important that is. But I think the care continuum is evolving, and it's evolving dramatically. As we speak, there are new things happening, and with the touch, literally with your hand, with the touch of a button, you can control what happens in the most remotest of locations. So with that comes a responsibility, and I think resilient systems have to be able to anticipate, they have to be accurate, they have to adapt fast, and they have to be agile. So I think these 4 A's really control what we can do, how we can deliver healthcare, and the responsibility of healthcare providers on many fronts to be able to do this ethically, quickly, and with a sharp focus into what happens with the patient. And I think that is why we're all here in this session for patient safety, part of the Patient Safety Congress, to see how can we just be efficient, how can we be inclusive, but give equitable health care to people who deserve it. There are multiple platforms. You know, there's AI-powered diagnostics, there's digital health platforms, there are breakthrough therapies, and all that is happening as we speak on multiple fronts in global spaces all over the world. But I think when it comes together, and when there is a care continuum, which is a complete circle of care, whether a patient is in the hospital, whether they go home, whether they need to be monitored, and whether they have to come back for multiple, interventions, I think the care continuum has become very important, and today it is possible. It may not have been possible, even 5 years ago, but today with technology, today with commitment, today with the kind of training which is being provided, it is possible. And I think as healthcare providers, if we don't adapt to that quickly, I think we will be shedding a great responsibility. So we have 2 amazing gentlemen with us, and thank you so much. It's my pleasure to introduce Dr. Atul Mohan Kochar. He is the CEO of the NABH, the National Accreditation Board for Hospitals, which I think all of you know. Even if we wake you up in the middle of the night, you will know what NABH is all about. And he is a healthcare leader with extensive experience in hospital accreditation, quality improvement, and patient safety. And as the CEO, he's played a pivotal role in elevating healthcare standards across India. He's ensured that hospitals and healthcare institutions adhere to the highest quality benchmarks, and his leadership has been impeccable and has brought a great amount of trust and value and transparency to patient care. So thank you, Dr. Kochar, for being here with us. Our next panelist, who again has come all the way from the Mayo Clinic to be with us, he is a visionary leader, Dr. Manish Goyal, and is in the global healthcare landscape. And he has spearheaded digital transformation and innovation at the Mayo Clinic platform. His expertise lies in harnessing data-driven healthcare solutions, AI, and advanced analytics to improve patient outcomes. With a career spanning multiple leadership roles in healthcare technology and operations, he has been instrumental in shaping the future of precision medicine and integration of healthcare delivery. So we can't ask for better. And now that we have both these amazing speakers with us, I think we should just learn, absorb, and take the responsibility back to wherever we come from to see how can we deliver better to the highest standards. So I'd like to invite Dr. Atul Mohan Kochar to come and first speak to us, followed by, of course, Dr. Goyal. And after that, we will have a few questions among each other and then throw it open to the audience. So, Doctor, please come.
Namaskar, good morning. Thank you, Madam Chairperson. It's indeed a privilege for me to represent NABH, the body you know so well, the accreditation system you know so well, and today we feel extremely privileged to partner with 23,000 plus hospitals in 12 countries, all because of passionate, quality people, professionals, clinicians, nursing officers, administrators, all of you. It's indeed a great privilege for me to be here. And the topic, of course, something which all of you do it on a daily basis, ever-evolving care continuum, which is the patient's journey through a healthcare facility. That's what it is in simple language. But you may have noticed that as I walked to the podium or onto the stage, I had a near miss, you know. That was pure unintended harm. And that's what Dr. Madhu recently pointed out. 74,000 patients in the most developed country of the world, or of the globe, United States, he mentioned, they have medication errors, device failures. And that's what this entire ecosystem has come together to prevent. How, in best of our efforts, could we prevent unintended harm? That's what JCI has been doing for 72 years. That what NABH is attempting to do for past 19 years. And that's what every accreditation system in the country or in the world is attempting to do. How can we prevent unintended harm? So very quickly, I have few slides. Let me go through them. How do I move them? Yes, so this is the, very briefly, the care continuum of a patient is. All of you are passionate healthcare professionals. You know about, since historical ages, how we have progressed, reached where we are today. There are lots of cutting edge technologies. There's a conference happening on technologies. Thank you so much. Thank you. So there are lots of innovation care models which will be discussed over the next 2 days. And that's where in the front and center of it in the country, somewhere NABH and Quality Council of India have been attempting to make a slight difference. To understand the care continuum, it's nothing but the journey of a patient, curative, promotive, palliative, rehabilitative, of course therapeutic, all care in the journey from entry of a patient or rather pre-entry of a patient to acute care to post-acute care. Everything combined together is known, in other words, as a care continuum. The basic aim of evolving care continuum is to give you a seamless patient experience, improve the health outcomes, and enhance patient satisfaction and leading to a delight. So that's what it is. And in the recent times, it's all about everything coming together to create an integrated model where the patient benefits, the facility benefits, and the staff, of course, benefits. This is a very rough estimation of where we were, where we are, and where we hope to be. In the 90s, it was all about managed care. And I would like to congratulate the Apollo Group of Hospitals, which has truly been the cradle of quality in healthcare in India. That's what it is. They led to the genesis of a quality movement which flourished and triggered the government into promoting a body, creating a body, promoting a body called NABH under the Quality Council of India umbrella, and which has led to all the quality standards in a big and wide and diverse country today. The 90s led to the era of managed care, of a rise of patient-centered medical care, and today it is all about integrated care forums. What exactly we mean by integrated care is that it has to be patient. You keep the patient as a linchpin, as a central front and center, and create the entire ecosystem around that. That's what patient-centered care is. The core effort being that it has to be a team effort, and the teamwork and coordination along various healthcare professionals, the healthcare teams, all revolves around that to give us a core substance of patient safety, healthcare quality with a continuity. So continuity of care is another big area which is extremely important, whether it is communication, whether it is a handing off, whether it is a transitioning from one domain to another. Continuity of care is at the essence of any quality movement in the country. So this is where we step in, or rather we stepped in 2005 when Madam Chairperson, the Apollo Group brought in the first JCI as the Indraprasth Apollo that led to the Government of India triggering that why should India not have its own standards. And I would like to place before you one more fact, that of the 194, 195 countries in the world, only 37 countries have structured healthcare standards, and India occupies the place of pride. So, on that table, so amongst those 37 standards, 2005 NABH was nestled under the Quality Council of India, and 2006, the first standard all of you helped draft. Every 3 years, these standards have been revised, every 4 years now, as per ISQA norms. And 2006, the first standard, and starting from that first standard, today we have 29 different standards across programs. 2023, we released the first digital health standard, the only standard in the world today to have a structured digital health program in India. 2024, last year, every year on 17th of September, the Global World Patient Safety Day, we release new standards. And on just the 17th of September gone by, we released the first of its kind standard for HIS and EMR companies, with an idea that every healthcare software in the world, in India at least, should be certified compliant with NABH. So that's a first of its kind again. These are the core activities today. All of you are aware that we partner with 23,500 plus facilities in India and 12 more countries. So that's what your baby has grown into, and these are all standards, all of which are totally free of charge. So even all those passionate quality professionals, if you are keen on learning about quality, learning more about healthcare safety, please download these standards free of charge from the website. So what exactly is coming to the subject, what exactly is the role of NABH in the care continuum? Well, NABH, you are all aware, sets clear standards for hospitals which bring clarity, and ultimate aim being high quality care across all stages of a patient's journey. Accreditation focuses on improving patient safety protocol, minimizing errors as we have been speaking, and enhancing patient satisfaction. And ultimately, these standards prioritize patient-centered care, ensuring the needs. How have we grown? From that first standard, if we were to speak about, the 2005 was all about patient rights and basically safety. It was the beginning just to tackle the Consumer Protection Act, so to say, just to give something to the insurance companies. A little bit of quality management, hospital management leadership, patient education and communication, very, very basic, thin booklet. But after 2 years, this evolved. So that shows you the ever-evolving care continuum, because these standards have kept pace with the best in the world, what is happening. Just after 2 years, we brought in the patient-centered care, quality and risk management, which are a big subject now, but we have been having that since 2007. Accreditation of support services were recognized as early as 2007, and evidence-based practices were also brought in 2007. In the third edition, which came in 2011, we focused more on patient-centered care and rights, brought in infrastructure safety, support services, and a huge focus on leadership, staff competence, and continuous education. So now you recognize that all these basic tenets of an ever-evolving care continuum were slowly but steadily being reinforced, and more hospitals started to be in tandem and started to follow that. Our fourth edition was a very ambitious edition, and we have learned from all our colleagues from ACHS, from JCI, and the best of the world, and brought in the core components of infection control. Huge focus on infection control, which was there in 2015, and of course, staff competence and education. And of course, we reinforced our commitment to governance, best leadership, and everything. Fifth edition, cutting edge technology just before COVID, but again, massive focus on staff competence, continuous education, enhanced patient-centered right and responsibility. This is our latest edition. We released last year after 4 years gap, and sixth edition of NABH is absolutely in synergy with evolving care continuum. Hospital infection control has moved to infection prevention and control. So more focus on preventive care, more on therapeutic care, quality improvement projects, which are centered around all the core tenets of healthcare quality, which include patient safety, effectiveness, patient-centered timeliness, efficiency, as Madam pointed out. And we also have a renewed focus on appropriateness of clinical care, which is the first time. So this is a basic journey which we are extremely keen on building and extremely keen on delivering. The organization today make huge efforts to use digital health. And not only, we have not just let it out in the abstract, we have crafted a digital health standards which already 348 hospitals are today following. And Apollo Hospital, we are thankful to you, Madam, that the majority of Apollo group of hospitals today are digitally compliant again. Clinical department specific key performance indicators, inclusion of nuclear medicine and extension of patient care through domiciliary. So care from home, not only in vernacular, not only in English, but 14 Indian languages this standard is aware, so there is no excuse for any person in the hierarchy of a hospital not to understand patient safety and healthcare quality. That is also a big plus for all of us. Besides that, we have the digital health, of course, which is a big learning experience. We have standards for HIS and EMR. We have standards for green system, which is a self-certification scheme, which is an important clinical part and is ancillary part of a ever-evolving care continuum, because we have to be responsible by delivering best healthcare. We have a checklist for dementia-friendly hospitals. We have standards for stroke excellence and for care homes. We also have a variety of standards for the subunits of a healthcare system, the allopathic clinics, the stroke clinic, the dialysis clinic, the aesthetic clinic. So end to end, everything has been incorporated in the ever-evolving care continuum. Much has been spoken and much will be spoken over the next 2 days about technology integration. Of course, AI, ML, all have been incorporated, and we are working, investing in technology to create a portal where hospital can input the real-time raw data regarding the key performance indicators. Telehealth has already been integrated into every standard and every care, and health information exchange is going to make the third-party assurers' life easy. The patient's journey getting claims is going to become very, very easy with the national insurance exchanges. Wearable health device data, that's another frontier for the care continuum. And telemedicine and patient governing council, patient for patient safety, their demand for quality is increasing. I'll just take a few more minutes, Madam, to highlight that the summary of standards mimic the ever-growing care, ever-evolving care continuum in the ecosystem of healthcare in India. So this is a brief summary how NABH and Quality Council of India have helped integrate evolution of patient care, the cutting edge of patient care in the where it means. So looking ahead, I'm sure Dr. Manish is going to guide us about what the best in the best does it, but personalized medicine, advanced patient engagement, and increased use of AI is always, we are keenly looking forward to that. Telehealth, remote monitoring is all ultimately gearing to be an interoperable healthcare system where one record will flow seamlessly and patient care will become easy and delightful. Of course, AI in healthcare is operational in all domains, and not only it is leading to early detection, better diagnostics, as Dr. Madhu Sasidhar pointed out, that diagnostics still remain a challenge. We have to bring in the latest in technology to eliminate all the errors in the interest of personalizing patient care treatment plan. Technology integration, of course, has to be there, and I urge you to attend all the wonderful sessions over the next 2 days because there's so much depth in all these sessions. But while, and of course, data privacy, cyber security, all these are the next frontiers which India is in an evolving stage. And going forward with the government stepping in and a central role playing in its federal structure, I'm sure these things are going to become extremely important in the next few days. Automation and robotics are the next frontiers which are already there, but every day there is a huge improvement in all these domains, and ultimate beneficiary is the patient. I'll leave you with 2 questions and 2 thoughts in the end. What is more important than your patient's health? Any answers? Any one answer? Sorry? Excellent, excellent. So what is more important is than your employee health? We have been learning about AI, we have learning about technology, we have learning about ML. But please remember that a healthy staff will only give their best outcome. And you are the key components of the healthcare delivery system. You are not required to set yourself on fire to keep others warm, which is another thing, or rather better still, you cannot pour from an empty cup. So please do take care of yourself, as our standards also highlight. Our standards place a huge amount of emphasis on staff care also, facility care also, mental health also. And such conferences, IPSC 12th, I would like to congratulate you once again, ma'am, for this huge investment into the well-being of so many people. I understand there are 10,000 people who are likely to attend these sessions, but such sessions bring together not only networking opportunities, not only learning opportunities to learn from the best of the best, but also for your well-being. And so be your best and take care of yourself. That is one thing. And if you are a manager or a healthcare leader, do take care of your staff also. One final point which I wish to highlight is that over the next 2 days, we will be discussing a lot about AI, a lot about models, simulation models, robotics, automation, but all the technology in the world cannot replace that reassuring touch, right? And one final question is, what's common between this hospital's OPD waiting lineup and everyone in this room? Everyone, including madam, including you, including me. Well, all of us are fighting a battle no one knows about. And as healthcare professionals, I truly believe that we have been given an opportunity, all of you have been given an opportunity to be kind, be showing some empathy. So please be sincere, care some more, and grateful for the opportunity given to you. It's more on the spiritual side, but the final thing is that all the robotics, automations, AI, and the ML cannot replace that kind touch, the kind smile, that reassuring hand of a clinician or a healthcare provider. So let's believe in the adage of primum non nocere. Let's agree that first do no harm. That holds true today also. Thank you so much, Jai Hind.
Thank you so much, Dr. Kocha. You know, it is, you remind me so much of ourselves. It's almost like looking in the mirror. And your presentation really reinforced my 4 A's, which was how to anticipate, how to adapt, be accurate, and be agile. I think, you know, you covered it all. And the evolution of what NABH has been doing over the years has been amazing. You know, I was one of the when it was in its startup phase, we sat and wrote the standards in our boardroom. So I think we've learned a lot. And I think we're great partners in this journey. So thank you for doing it. There are just 2 points I wanted to make. And I love the fact that you spoke about employee health. Our chairman, Dr. Reddy, has almost mandated that our employees go through their health check. And so much so sometimes we took it so far that we said that they can't get their increments unless we have a note that they've gone through their checkups, so that if we detect either cancer or hypertension or cardiac disease early, we can at least work with them. So, you know, when they're your employees, they become, their whole family is your responsibility. And if you don't look at the earning family member and do something for them, we are not responsible employers. So thank you for flagging that. The second thing you spoke about was kindness. Many years ago when we started, you know, when I was literally on the floors, we picked up this term because I learned it from my mom. And everyone at Apollo smiles because they know about it. It's this whole thing about TLC. And, you know, my mother would always say, put TLC into everything which you do and you'll be happy and you'll do it well. And it so happened that we actually institutionalized it. And I would take TLC classes, Sangeeta would take it, chairman would come and take TLC classes, and now the whole nursing team is sitting here. It's part of their genes, you know, it's become genetic at Apollo. So we do this only because I think we have to be kind to our patients. More than anything else, you can't replace that. You can't replace a heart. You need the brain and the heart to work together. So when we talk about the brain and heart working together, you also spoke about so much about technology. Many times we are asked this question, so much of technology, and it can overpower. So I always answer saying that the brain and the heart, you can't do without each other. You know, the brain has to function, the heart has to feel, and both are part of this whole, you know, human body and ecosystem. Similarly, there is high tech, which is the brain, and high touch, which is the heart. You can't replace high touch, that human touch, with high tech. You can't replace it. So it has to go hand in hand. And I think this was a great learning from your talk. Thank you so much, Dr. Kocha. And our next speaker, Mr. Goyal, thank you so much for flying all the way here to be with us. Because I think, in a way, I'm seeing the brain and the heart, you know, sitting on either side sometimes, but I think you have the heart also. So you kind of intermingle beautifully. And please tell us about your digital journey. How can we make the world a better place just adopting to all the fantastic things you do? Thank you. All yours. You have to tell us about timing. Girls, give me a slip.
Can we pull up the slides? Yeah. So while our slides are coming up, first of all, I want to thank everybody. I want to thank Dr. Reddy and the Apollo family for hosting this incredible conference. And I want to thank the audience for listening and hopefully participating. What I will start with is where Dr. Kuchar left off with, which is a sense of humility and a sense of taking every opportunity and making the best of it. You're looking at somebody born in Ajmer, Rajasthan a little over 50 years ago, now working at one of the more preeminent hospital systems in the world, talking about healthcare transformation. You can't script that, right? How do you script that? So I saw a lot of young people in the audience and coming in, take every opportunity that you're given, make the most of it, and have fun. So I greatly appreciate what you said earlier. So I want to accomplish 3 things in terms of my portion of this, is to share a little bit about what Mayo Clinic is and who we are, talk a little bit about platform thinking, and then put it into practice and tie it back to care quality. For me, care quality, technology, innovation, and patient safety, they're all tied together because it only works if you're focused on quality. So I happen to work with an institution that has been delivering high quality care for 160 years. Mayo Clinic was founded in Rochester, Minnesota, and we practice this particular kind of healthcare called integrated medicine. Integrated in the sense that we have research and practice integrated, and that's the secret sauce at Mayo Clinic. Our researchers are constantly pushing the envelope on what our practice is implemented. So for us, the latest, greatest medical technology, the latest, greatest AI technology is a matter of course because everybody's geared towards innovation. Second, it's integrated because when you come to Mayo Clinic, we're a tertiary quaternary center. We wrap around your particular needs with all the specialties to make a complete diagnosis. Because at the end of the day, it's the integrated diagnosis that we come to the optimal answer. So those are important concepts that I want you to keep in mind as we're talking about platform thinking and innovation to improve care quality. Let's keep going. So a couple of other facts about Mayo Clinic. Every position, every senior position is tenured, not tenured, sorry, termed for 8 years. So the CEO, CAO, chairs, every position is termed for 8 years. That means you can start out in the practice, become a chair for a particular department, but you will end up back in practice. And that model, what it does is creates a sense of community because you're never going to keep going up. You're going to eventually end up doing what you do on a day-to-day. Second, we have dyads. So every physician has an administrative partner, and they operate in unison. That ensures that you're thinking about quality and patient safety and the long-term viability of what you're doing. Next, 100% of our staff is salaried. So there are no variable compensation. Nobody gets stock options. Nobody gets paid more or less based on how we're doing. Everybody gets the same salary adjustment every year. Everybody's salaried. And all of that instills this foundational culture of what we call the needs of the patient come first. So if you ever have an opportunity to go to one of our sites, engage with anyone. Engage with the coffee barista. Engage with the janitor. Engage with the physician. You will hear this theme. We actually believe down to our core that the needs of the patient come first. And that hypothesis is that's what made Mayo Clinic what I think is doing something really special. So our current CEO, who he's in year 4 of his term, had the hypothesis of how do we make integrated medicine deliverable across the planet? One can argue that you can get high quality care at Apollo, you can get high quality care at Mayo. So high quality care is available, but it's just unevenly distributed. You go outside of a major city and then your care quality drops. What I love about the point in time that we're in is we have an opportunity to change that. And that's the notion of Mayo Clinic platform. The thing that we're focused on is how do we partner with other academic medical centers, other community hospitals, other large hospitals, other community health workers to make sure that we all deliver better care. And it started with the notion of data. So Mayo, over its 160 years, has seen about 10 million patients. Not a huge number by the standards of Apollo, but it's a unique data set because it's highly rare, highly complex patients. So 5 years ago, we made a bold move. It doesn't seem so bold today, but we put 100% of our clinical knowledge in the cloud. So today, that's about 50 petabytes. So for you technologists, that's a ton of data. That consists of structured data, unstructured clinical notes. And by the way, the unstructured clinical notes are how physicians and nurses think. All of the imaging data, all of the genomics, proteomics, etc. We then did something even bolder. We de-identified it and made it available to partners across the globe. So today we have over 84 companies that are innovating on top, because we recognize that we don't have a monopoly on innovation. No organization has a monopoly on innovation. It is only when we share and learn together that we actually get better. That's a principle of platform thinking. But we said, okay, great, that's Mayo Clinic. So we get a lot of people from Minnesota, Florida, and Jacksonville. Not going to make a major impact under that strategy. So we went around the planet and identified high-quality institutions in each geography. So what you see as those green dots on the page are 50% of the top 11 institutions in the world based on some global standard of care quality. And we agreed with them to share all of our data. All of these organizations have said, we're going to share data. And now you're starting to see a bit of complete humanity, right? Koreans, Singaporeans, Africans, Middle Easterns. Certainly not complete, hence why we're spending fair time with in India. And so the notion is now sharing data, sharing knowledge, and then enabling an ecosystem of solution developers that are developing incredible solutions. Some of the things you see here: asymptomatic diagnosis of cardiovascular condition, early detection of epilepsy, precision medicine, so those 7 different chemotherapeutics that are approved for breast cancer can be targeted to the genotype and phenotype, not just pick one randomly. That's going to improve care quality. And the last piece of the puzzle we realize is if we do this with other academic medical centers, all these institutions get better, but we don't improve care quality across the board. So then we went around the planet and identified healthcare organizations that are the community hospitals, the district hospitals, the public hospitals, the community health workers where there's no hospital in the region, and said, we'll provide you these tools. And that collective ecosystem is what Mayo Clinic is endeavoring to do. So last year, Mayo Clinic saw 1.3 million patients across our sites. With our ecosystem, we impacted 45 million lives, and we're just getting started. So I'm going to go fast because I've got a little time clock here. So an example of this, right, this is about care continuum. An example of this is 5 years ago, before COVID, our CEO said, I would like to move 15 to 25% of hospital volume into the home. So these are patients that would otherwise be reimbursed, cared for, get care delivered in the hospital. But I want to do it in the home. So if you think about what that means, this isn't telemedicine. This isn't non-urgent care. These are patients that would otherwise have all the services in a hospital. And what we did, is wrapped around 18 different services for these patients. And you see them on the screen. These represent all the services that you would get in a hospital: PT, OT, nursing, phlebotomy, diagnostics. And we said, we're going to make it available within our geography. So when the patient is needing to be transferred into a general ward or a recovery, we can send them home. But these services are going to be sent to them with the supplier network that we assemble. So I want to pause here and say, that's platform thinking. You guys use platforms every day. Zomato, Uber, that's the concept of platform thinking, but we're doing it in patient care. And it's all orchestrated from a command center. Not too novel, except I'll give you some facts. The average severity of illness in this particular model is higher than inpatient at Mayo Clinic. We've basically extended Mayo Clinic's virtual capacity to deliver care from our standard beds by a variable capacity. So we can expand this or shrink it based on demand and volume. But more importantly, those hospital beds with real patients in them those are patients that are complex patients. They're the ones that actually need to be in the hospital. So the things that we learned along this journey, you see a graph on this, is that it's not easy to assemble an ecosystem rapidly so that you get high quality care in the home. You need several things. You need a paramedic available 24/7, so if that patient decompensates, you bring them back into the hospital. You need all the services to have primary, secondary, tertiary availability, because otherwise, patient's waiting there for something, then the doctor's waiting for a result. So we've thought through all of these things and hit walls along the journey, but what we did was made sure that we had care quality built in from the foundation. So we've seen about 36,000 patients in 5 years under this model. So think about that. That average is about 600 beds, 600 patients a day. Those beds didn't exist. The average cost of building a bed in the United States is $10 million, and now we're operating, and we're operating this at a fraction of the cost. I'm going to skip this and say, what could we do with this? So what we've learned across that history is we can actually evolve the very notion of a hospital. Instead of the patient coming in, we keep them home. We send the services so they don't need to come to ED. We know somewhere between 15 to 18% of patient volume that comes into the emergency room does not need to come there. They're clogging up our emergency room, so we can manage them in the home better. Certain patients want to stay in a hotel next to the main hospital facility. We can do that. We can wrap around services. We can actually start to deliver complex and serious medicine in the home. Right now we're running what we think is the world's first clinical trial where we're delivering chemotherapeutic in the home. So think about that. Something as complex and serious as chemo, instead of eating up a hospital bed, deliver it in the home. So we're starting to see that we can actually take somewhere between 7 and 8% of our patient volume and start to push it in the home. And that expands capacity and focuses us on delivering high quality care no matter where the patient is. So I'll end with this, and I'm just going to skip this given time. We have an opportunity with technology, with changing models, with the needs of an ever-aging patient population and limited resources to change how we think. And it's only through partnership that we're going to be able to deliver high-quality care. And I do look forward to the conversation, and again, thank you for having me.
Thank you so much, Manish. That was truly outstanding. And what it did is it kind of broadened our horizons from being just hospital providers to really taking the care beyond our boundaries and doing it responsibility using the power of technology. I'm looking forward to a time where the Mayo Clinic and India, Heal in India, will all come together to get data, to get the continuum of care, give people the kind of reach with, all the geographical boundaries can be overcome. And then that data can be used for research for the betterment of mankind. So I don't think it's too far away. And with the kind of focus and the speed which you have done at me, and all this I think has happened over the past decade, I guess.
No, the idea was formed in late 2019, and so 5 years.
Amazing. So if you can do this much in 5 years, could you just quickly tell us, what do you think, what's your vision for just our 1.4 billion population? What do you think we should do?
So what's interesting is over the last month, I've had an opportunity to experience and visit with some of the best institutions in India. So what I will say is this. India has an opportunity. So actually, let me pick an analogy, right? So as I mentioned, I was born in India. And in the 80s, the primary form of communication was a letter or a landline. And in order to get a landline in India, and you guys know this, it was a year waiting list, at least it was in Ajmer. And fast forward into the late 90s, along come cell phones. And now everybody up and down the socioeconomic chain have cell phones. And what you saw was India was rapid adopter of cell phones versus the developed world or the Western world. And I think what's going to happen in healthcare is that healthcare innovation in countries like India is going to innovate much faster because the regulatory environment, the infrastructure, the constraints of the market are just not there. And every time I come here, I marvel at the fact that every 6 months, it's a quantum leap. So I'm excited.
We owe it to the future generations, that quantum leap. Dr. Kocha, just one question, because I know we're running out of time, no time for the audience. But, you know, you've crossed so many frontiers with the NAPH. What do the next, just 3 years, you know, what would you like to achieve so that the network is larger, stronger, deeper? What are the 3 things you would like to do?
I truly believe that we are as strong as the weakest link in the chain. So while today India has the best of the best, the cutting edge technology, the best of the healthcare facilities, but till we empower the last in the line, till we reach out and give the very basics of patient safety standard, you know, even hand hygiene, the right site, right surgery, the communication safety to the tier 2, tier 3, tier 4 cities, only then we'll be calling themselves. Of course, technology has to come, and I think there's such a huge movement which is there, and we must at one end adopt the latest, the very best, and I'm very proud to inform that even the Mayo engine is being run by Indians and on Indian software, CTS Tech, right? So even that, I think, as Mr. Manish has very rightly pointed out, that we have to work on all frontiers, the complete spectrum end to end. At one end, empowering the last in the line, tier 2, 4, 5, 6 cities, and the other, keep building to the moon on a very strong foundation of ethics, morality, patient care, and TLC, as Madam said.
You know, the vision is huge, time is short, and whatever we've learned now, we must really thank both these gentlemen that we actually have all the answers are out there. And we, as responsible healthcare providers, each one of you has a responsibility. So please go out there, achieve and win, because heal in India, heal by India, heal for India. Everything is our responsibility. So thank you all so much. And I can't thank both these gentlemen enough for what they have shared with us. So thank you and God bless.
Thank you so much, ma'am. Thank you, sir. May I request you to please step forward for a photograph? Thank you, ma'am. Thank you, Mr. Goyal. Thank you, Mr. Kocha, Dr. Kocha.
I would request the dignitaries to please watch your steps while you're walking down the stage. Coming up next, a very, very insightful topic, rather a game-changing topic, real-world impact of AI in healthcare. From predictive analytics to early warning systems, AI is helping healthcare facilitator to make faster, more accurate decisions and ultimately saving lives. But how does AI truly impact patient safety in the real world? It's the true question. Let's hear out from our speakers.
So we do have our speaker, for the first speaker for us. It is our pleasure to welcome Mr. Gaurav Parchani, co-founder and CTO of DOSI. Welcome, sir. A trailblazer in healthcare technology, Mr. Parchani has been instrumental in leveraging AI-driven innovation to enhance patient safety, care, and outcomes. And along with him, please welcome Dr. Anirudh Kohli, CEO of Breach Candy Hospital. Welcome, sir. A visionary healthcare leader, Dr. Kohli has been at the forefront of driving innovations, excellence in patient care. I welcome both of you. May I request you to please continue the session.
Good morning, everyone. What an energy, like it's almost palpable. This is, I think, the 4th time I'm speaking at IPSC. It's always a pleasure to be at the IPSC and amongst you all discussing new advancements in healthcare and healthcare technology as well. Can we have the slides, please? Thank you. So, every year, as I said, this is almost my, I think, 4th time. Every time we come here, I talk about new technologies. In fact, sometimes we launch new technologies as well. This year, it's slightly going to be a different message because instead of talking about what technology can do, we're going to talk a little bit about what technology has done in the past few years, right? And it's always a good idea to kind of look back and see where we have come and where we are going. But before we do that, let's essentially look at why this is necessary right now, why we must take a brief stop here and look at how technology is basically impacting healthcare and healthcare delivery, because technology itself is evolving very, very fast. The development speed is going from fast to almost insane. If you essentially look at a few AI technologies that started developing almost a decade ago, crossed human performance only after a decade of development, training, and things like that. But in the last couple of years, with all the new AI models coming up, the new methods of collecting data coming up, within 2 years now, handwriting recognition, cognition, thought processes, those are crossing human barriers or human performance levels as well. So this is a very, very important time in junction to basically kind of take a look on how basically we involve technology into healthcare. But before we go there, we must ask a question. Can technology alone create this sort of a difference? Obviously, I think most of you would agree the answer is no, but this is exactly what provokes a thought that what is the right model? At DOSI, what we've essentially done is we've focused and we've kept our 3 pillars very constant. Our strategic model for healthcare innovation is obviously focus on the clinical need. That is, every solution has to be grounded in a need. Obviously, innovation and technology is at our core, and execution excellence. Now, if you essentially combine 2 of them and leave the 3rd, so if you leave, let's say, execution excellence, you are left with solutions that are grounded in clinical need, but they don't scale so much, right? Because they're not grounded in how operationally they would be relevant. If you leave clinical need aside, you are left with over-engineered solutions with nobody to use them for because there was no need for them. And if you essentially leave technology aside, we're left with processes today which are very good, which are safe, and which essentially are effective, but you cannot scale them because they're limited by human capabilities. So you cannot really scale them at all. But if you have 3 of them, that's where the magic happens, and that's where real-world impact comes. And if you essentially look at how a healthcare solution develops or how technology develops, there are 10 key milestones that essentially everybody goes through. Now, I'm not going to say each one of them out loud. A lot of people know about it. But the discrepancy in all of this is 9 of them happen in a lab, or 9 of them happen with the technology providers while developing this technology. Involves ideation, involves proof of concept, involves validation, clinical trials, and so on and so forth. But the last one, standard of care, a technology, when does it become standard of care? Once it's crossed all of those 9 hurdles and finally is able to generate real-world evidence in the real world. And that's exactly where it becomes standard of care. Now it's 1 out of 9. So from a technologist perspective, 90% of my attention is outside that and only 10% is. But that's not the reality. It's essentially 50-50%. The last bucket is the biggest bucket that we have. Now, And that's exactly, but how do you evaluate, right? How do you evaluate that somebody is, or some technology is ready to be standard of care? Right? We have many technologies that have come up. Robotics is coming up in surgery. Remote patient monitoring and early warning systems are making waves. But are they really standard of care today? And that's the slow journey of collecting a lot of evidence day after day, week after week, hospital after hospital, patients after patients. And that's when you can essentially say that something has already become real-world evidence. So what comes from the lab, clinical efficacy, till your regulatory approvals, till your FDA has approved it, till your CDSCO has approved it, and any other regulatory body, after that is where the real journey begins. How does the technology integrate into your operation seamlessly? What is the acceptance from the stakeholders? Do they really believe in it? How do they really use it? And at the end of the day, can it scale to become standard of care or not? Apart from all of that as well. So today, we want to look at remote patient monitoring and early warning systems on how they've developed so far. There have been decades and decades of data that has been available that says that if you put remote patient monitoring or continuous monitoring in a facility or for patients that require care, you're definitely going to improve patient outcomes, you're definitely going to reduce costs, and care is definitely going to improve. Dr. Madhu spoke about in his session, for example, moving from reactive care to proactive care. Continuous monitoring is exactly that. It exemplifies giving care at the time that's required rather than waiting for something to develop and then reacting to it. So multiple studies essentially have spoken about all of these benefits of remote patient monitoring, right? And this is exactly where we started looking at how DOSI creates that sort of a difference. Can we look at the real world data that is available to us? So what we essentially did, we helped 3 major studies. We helped them provide all of the data that we had on our platform. We waited for them to analyze all of this data and in fact publish it in peer-reviewed journals as well, journals and international conferences as well. So what I'm going to quickly talk about in the next couple of minutes is the 3 major studies in 3 different care ecosystems, very, very different care ecosystems. The first one is a major study at King George Medical University, a public tertiary care system in a tier 2 city. Over 1 million patient footfall every year. We heard about Mayo looking at over 1 million patients in 1 year last year. One single facility does that here in India, right? We monitored over 700 patients, 84,000 hours of data was collected for that sort of an analysis to be done. So a big study in itself. It was published in one of the leading journals as well. The second study was at MS Ramaiah Hospital from Bangalore. And this is a super specialty hospital in a tier 1 city, right? But a standalone super specialty hospital. Similar number of hours, over 900 patients, different care settings. So the first study focused on internal medicine, but here we looked at multi-specialty, cardiology, oncology, and so on and so forth as well. And then the third study focused on the largest integrated care provider in the country, probably the world as well. So how does a group essentially look about it? In a very, very large setting, multiple hospitals, through a command center, over 1,000 beds being monitored at a single time. What were the findings? The findings, we couldn't be humbled much by the findings. 80% reduction in adverse events over the last month. Imagine that. 8 out of 10 patients that would have had to go through adverse patients did not go through because there was data available, because an alert was generated, because a care was given at the right time. Imagine the impact of that. And while doing all of that, saving costs by saving our most precious resources, which are the ICU and the CCU beds. So can we enable or can we move the patients out faster? Can we make sure that the patients don't even go there? And can we make sure that readmissions to ICU do not happen? This is major, major impact, improving patient outcomes at that scale while saving costs and while actually saving nursing time as well. The other clinical outcomes essentially involve having alerts for at least 97% of the patients 19 hours before any sort of an event happened, with controlling alarm fatigue as well. And not just doing this from a technology evaluation perspective, but also from a perspective of whether this was used properly or not, whether the acceptance or whether the integration into the hospital's ecosystem or the protocols were done properly or not. 90% of healthcare professionals, when they were surveyed pre and post, agreed that this was really useful in improving patient outcomes. Not only that, but they use the data in their clinical decision support system. So in their decision making, they're actively using this information, and patients and their family felt safer while saving nursing costs as well. Now, all of this is amazing, right? And I know I'm towards the end of my talk. all of this is amazing, like hearing it from a technology perspective, hearing it from a study perspective, but nothing beats hearing it from the front lines itself. So it's my pleasure to invite Dr. Kohli, who's, I think, has already introduced the CEO of Breach Candy Hospitals. It's been my pleasure to work closely with him and his team over the last couple of years to actually make changes in patient safety and protocols at his hospital. Inviting him to say a bit more about that.
Good morning. Thank you very much. This may be your fourth version of the IPSC, but this is my first, and I'm really impressed, very more impressed by this venue, which is absolutely fabulous. So I'll dive into it, and can I have the first slide? My first slide? It's there? Okay. I'll go back. Yeah. So basically, I'd start off with the basic clinical issue. The real nightmare for any hospital anywhere on the planet is code blue events. It's a nightmare for the patient. It's a nightmare for the hospital staff. Your rapid response teams have to be alert all the time and have had to move fast, quick, and as everyone is now talking, it's reactive. And what really would happen and what would benefit if we could be proactive? Just stepping back, code blue events are very common. 1 to 5 events per 1,000 hospital patients, but could be even more in certain settings, depending upon where you are, the facilities, and also the type of patients. If they're more sicker, you could have more code blue events. What is disappointing is survival rates across are just 15 to 20% of patients who have a code blue event. And even those who do survive and end up in the ICU with good care, nearly 14% are left with a neurological disability which could be close to a vegetative state. So it's very, very important for us to recognize code blue events, have appropriate management to improve the survival outcome, and most important, minimize neurological damage. The key to this is monitoring. It's the opportunity to identify critical alerts, maybe code blue event, maybe even to identify changes happening, adverse happening with the patient, whether it be the clinical condition or even just before clinical condition deteriorates, changes in the vitals. And that would really help us if we have monitoring to reduce code blues, of course. And an important statistic which has already been mentioned is that when we do manual spot checks, they do not identify future adverse events, to the extent that it was found that when code blue events happen, within 10 minutes of a nursing assessment, 21% of hypotensive episodes occurred, 18% of desaturation episodes occurs. Also, if we have to keep doing manual checks and we can replace it with monitoring, we can reduce nursing time for repeatedly checking, measuring vitals, and actually concentrate on the core practice of nursing. We are a 275 tertiary bed hospital in South Mumbai, quite well known, and we really wanted to look at how we could monitor patients, inpatients within rooms, and that's when we looked at DOSI. I must tell you that when the people from DOSI came across and talked to us, I was totally skeptic, because they talked about putting a sensor below the patient's bed, which would be contactless. The patient would not know that there is a sensor there. And that sensor would give us blood pressure, respiratory rate, and heart rate without the patient knowing, without contact, without monitoring leads, which was really the cumbersome thing of continuous monitoring. Of course, you can get SpO2 and temperature with a contact probe, but the key is the contactless remote monitoring system. Further, the data could be seen on a monitor, maybe in the room, a monitor which may be a central monitor at the ward, maybe a remote monitoring system, and in fact, in a command center, which may be in Bangalore or anywhere else on the planet. The whole point being that they should get customized alerts. So we can customize the alerts based on the patient or have a generalized customized alerts. And these alerts can go to the central station or being in the form of alarms. They could go to the ICU. They could be remote to a command center where there's no alarm fatigue and somebody is sitting there and you get a call in coming either to the ICU or back to the central station that there's a change in the vitals and you need to look at things. We implemented it, but as I told you, when they came and described it to me, I was very skeptical that this can occur. It sounded like from a Bollywood movie where somebody takes a pulse and says somebody's pregnant. So I said, how can this happen? You know, that it is so. And we tried it out. And when we went through a 6-month trial period with it, it was quite amazing that we had an 80% reduction in code blue events. In fact, in the 6-month period, we just had 3 code blue events, which was fabulous. This means great impact not only for the patient, but as I said, for your rapid response team, which is always on tenterhooks and waiting to run like firefighters in to save the patient. It reduced nursing time for vitals check by 83%. And brought down from 60 minutes to 10 minutes, so they had 50 minutes more for core delivery time. So very, very important. A spin-off that came off in this 6 months was that as an administrator, I could know in an extremely busy hospital, which runs nearly at 100% occupancy, that if there was a bed which was empty, because very simple, if the patient was not on the bed, there was no remote monitoring happening. So if the bed was empty, immediately I'd find, is the bed empty? Is the patient in the room, outside the room? What's happening? So it gave me empty bed sensors. Very good to get bed utilization and turnaround time. But then that brought in a new concept, and something which really bothered us always is fall prevention. And this is something that happens. 2.3 to 7%, 7 per 1,000 patient days. And these falls which happen in every hospital anywhere in the world, maybe because patient is weak, the poor cognitive state, medications, finishing, performing activities unassisted on a new, unfamiliar environment. And most hospitals use fall prediction tools to identify the risk of falls, and falls happen, as I said. So we use this, that loss of contact with DOSI would trigger a fall risk alarm, especially in high risk for fall patients. And this has been dramatic. We've been able to save patients even at 3 and 4 a.m. who have just tried to get out of the bed unassisted and prevent them from having a fall. So in conclusion, DOSI and AI-powered contactless remote monitoring system. And every word of this is so important because this is proactive. It's not reactive. And that is what is changing things. It reduces code blue events. It's advanced warning of impending critical events, reduces ICU admissions, enhances patient safety. Very important, it's improving nursing efficiency, allowing them to do the core aspects of nursing rather than wasting time on measuring vitals, and fall prevention, a great new boon that we have. So it's really become a necessity for all hospitals. Thank you very much.
May I please request you for a picture, sir, at the center of the stage? Thank you. Thank you for your contribution to remote monitoring and early intervention, which are shaping a more efficient and proactive healthcare system. We truly appreciate your presence today.
And we do apologize the speakers for fastening and hassling up the speech.
Ladies and gentlemen, as we continue the session, we have an insightful journey at the International Patient Safety Conference 2025. It's time to shift our focus to one of the most exciting segments, our spotlight sessions. These sessions are designed to shine a light on the groundbreaking ideas, pioneering research, and transformative solutions that are reshaping the future of patient safety. We start with the first launch.
The first launch with accreditation model of AHLL. Celebrating a decade of commitment, transformation, and innovation with the Q4E, Quality for Excellence program, an initiative that has set new benchmarks in patient safety, quality, and healthcare delivery. Apollo Health and Lifestyle Limited is setting a special milestone. As we commemorate this journey, let's have a look at the AV capturing this remarkable decade of progress. Can we have the AV?
Quality is the heartbeat of every healthcare organization. At Apollo Health and Lifestyle Limited, it ensures safety, fosters trust, and unites diverse business verticals. Quality forms the foundation of care, delivering patient experiences that are safe, seamless, and transformative. The Quality for Excellence program, or Q4E, was launched with a vision to not just meet standards, but exceed them. Celebrating a decade of transformative impact, Q4E marks 10 years of relentless commitment to elevating healthcare standards. Starting with audits in Apollo Clinic and Sugar Clinics, Q4E expanded to improving outcomes and standardizing protocols in Apollo Cradle and Apollo Spectra hospitals. Today it spans diagnostics, dental, dialysis, and fertility, ensuring excellence across specialties. Now encompassing over 2,500 centers across India, Q4E reflects our dedication to quality care. With a decade of impact, the program's reach, rigor, and effectiveness can be gauged by over 7.5 lakh hours of training, nearly 15,000 sessions and reviews, more than 4,500 external audits covering 5 lakh parameters, surpassing 1 crore internal checkpoints, more than 150 clinical and non-clinical outcomes tracked, and countless quality improvement projects, emergency mock drills, and awareness activities. Over 50 centers accredited by leading national and international authorities reinforce our commitment to exceptional care. Global accolades from the International Hospitals Federation, ISQA, and Hospital Management Asia recognize Q4E as a benchmark for excellence worldwide. This success is powered by our teams, the true champions and flag bearers of quality and patient safety. As we embark on the next phase, the Q4E 2.0, we aim to empower teams, exceed expectations, and revolutionize healthcare delivery. The new Apollo Q4E app will transform quality management with advanced analytics and intuitive tools for seamless compliance and efficiency. Using smart tools and easy-to-understand dashboards, the app will help teams track progress, fix issues quickly, and keep patients safe. Alongside, the new and one-of-its-kind internally developed Apollo Q4E accreditation program will drive customized standards, self-improvement, and sustainable excellence in patient care and operations. This program sets dynamic benchmarks for various care settings, aligning with international best practices and fostering continuous learning. With objective 3-tier evaluations and recognition, it will spark healthy competition that drives units to excel and ultimately achieve the gold seal. This will also help our internal teams to identify focus units that need improvement. Reflecting on Q4E's journey, including a remarkable decade of innovation and growth, we celebrate milestones, lives touched, and global recognition. Together, we embrace innovation, shaping a future where excellence in healthcare is our enduring promise. We deeply appreciate our patients, teams, and leadership for their unwavering trust in us. Thank you for being part of this transformative journey.
Wonderful. Now we would like to call upon the whole AHLL team to unveil the book. Mr. Sriram Iyer, CEO of AHLL, Mr. Gaurav Loria, Senior Vice President, Operations, Apollo Hospitals. Dr. Vijay Agarwal, Director of Medical Services, AHLL. Dr. Sagar, Business Quality Lead, Apollo Specialty Hospitals. Mr. Narendra, Business Quality Lead, Apollo Diagnostics. Ladies and gentlemen, can we give a warm round of applause to them as we unveil the book here?
A big round of applause for the Q4E, Quality for Excellence.
Now we may request Mr. Sriram Iyer to share a few words, please.
Yeah, good afternoon everyone. Namaste. So Apollo Health and Lifestyle is the retail healthcare wing of Apollo Hospitals. A quick summary, right? We have multiple business units: primary care, diagnostics, and the single specialty formats of mother and child, spectra, fertility, and even dialysis. We have more than about close to 10 million walk-ins in a year, footfalls, and continuously growing. As seen in the video, right, quality is not just a formality, but it is core to our DNA. We have to, we have a lot of respect, trust, and we really recognize the confidence and the trust of all our patients who come into all our centers. So Q4E 2.0 aims to take quality to the next level. And we want to keep reinforcing, keep benchmarking, continuing to give the best in clinical processes, protocols, and outcomes to all our patients. So I'm confident with this initiative, we are setting the bar high. We'll continue to listen more, empathize more, give extended care, and really build the next level of care and comfort for all our patients who walk across, as I said, more than 10 million footfalls, comes into more than 5,000 centers across all formats of Apollo Health and Lifestyle. Thank you, everyone.
Thank you so much. Moving on to the next spotlight, that is the Patient Safety Commandments launch. At Apollo Hospital, patient safety is not just a priority, it is a promise to the patient. A promise built on trust, excellence, and an unwavering commitment to delivering highest standards of care. As a testament to commitment, Apollo Hospital is proud to introduce the Patient Safety Commandments, 12 guiding principles that define our pledge to patient safety, quality, and compassion care. Now, let's take a moment to witness a vision to come to life through a special audio-visual representation. And I also may request Dr. Rohini Sridhar, Chief of Medical Services, to please take this forward. Welcome, ma'am.
Thank you. It's an absolute pleasure to be here. And as you can see that patient safety or lack of it will crop up in the most unexpected way. Who would have thought just climbing onto the stage and reaching the podium would require effort on my part? This is our effort on part of Apollo Hospitals to enhance patient engagement and bring them on board as partners in safe healthcare. We all recognize that patients are critical in participating with us and partnering with us, sometimes in following instructions that we give them, sometimes in sharing feedback that may be critical to ensuring that no harm and zero harm happens in their journey through the hospital. So this is our effort to make our patients partners in safe healthcare. I would like to recognize and get my team on board. Can I have Balaji, Mumtaz? It's very slippery. Juliet. So we represent the entire facet of the team that's looking after patient journey, and I'm happy to unveil the video.
Can we have the video, please?
Welcome to Apollo Hospitals, where your health, safety, and comfort are our top priorities. We are dedicated to providing you with the highest quality care and ensuring that you feel safe, informed, and supported throughout your journey with us. This short video will introduce you to our patient safety commandments, our promises to ensure your experience is smooth, safe, and comfortable. Please watch this video carefully to understand how we are committed to your safety and care every step of the way. Before giving you any treatment or tests, such as medication administration or blood transfusion, your identity will be verified. Our staff will check the ID band for your full name and unique hospital identification number on your wrist to make sure you get the right care every time. Your treating doctor or care team will discuss your diagnosis, test results, care plan, and ongoing treatment with you. If you have any questions, don't hesitate to ask. You'll be informed about the medications you're taking, why they are being prescribed, when to take them, and what potential side effects to look out for. Knowing your medications helps you stay safe and recover better. Your care team is always here to answer your questions. Our staff will always clean their hands before they examine or treat you to ensure that you are protected from any possible infections. Upon your arrival at the hospital, whether as an outpatient or inpatient, your fall risk will be assessed. When you're being transported on a wheelchair or stretcher, safety belts will always be fastened. When you're in your bed, the side rails will be up, and the bed height will be adjusted for your safety. If you need help moving around, just ask to avoid any falls. If you have any procedures or surgery planned, you and your family will be actively involved. Your doctor will mark the surgery site on your body before the procedure to ensure everything is accurate. Your doctor will explain all the risks, benefits, and alternatives to any procedure or surgery in a language you can understand. You'll be asked to provide written consent before proceeding. You will be oriented to your room, including where the call bell, washroom facilities, and emergency exits are located. We will also show you what to do in case of an emergency. Whenever you press the call bell, our staff will respond promptly to assist you with your needs. Your medical details and treatment will always be kept private and secure. We are committed to ensuring that your health information is managed securely, both during your stay and after discharge. We will provide you with the necessary information about your health, including pain management, medication, diet, and recovery. We want you to be fully informed every step of the way. Feel free to ask questions, share your thoughts, and offer suggestions regarding your treatment and care. Your input is always welcome and valued. Thank you for trusting us with your care. We're here to support you, and together, we'll ensure your journey with us is not only safe but also as comfortable and positive as possible. If you have any questions or concerns, always feel free to ask. We're here to listen, help, and guide you. Your health is in good hands at Apollo Hospitals, and we look forward to providing you with the highest level of care.
Thank you so much. We request the delegates and the speakers, in case of getting onto the stage, please mind your step.
May we request the healthcare leaders to please come on the stage and take a group picture here. On the stage, please, quickly we'll take a group picture. Thank you so much. Ladies and gentlemen, now we move to the next launch, Alpha Droid.
Alpha Droid is transforming industries with AI-powered robotic solutions that think, navigate, and work seamlessly. From hospitality to healthcare, retails to logistics. Let us hear more about the topic from Mr. Sanjeev Kumar, the founder and CEO. And along with him, Mr. Pragati Tripathi, Chief of Strategy and Business. Over to you, sir and ma'am.
Thank you, everyone. It's really a privilege to be here in IPSC 2025. I'm proud to be here, and still I'm thinking about the session which we heard from Dr. Reddy and other speakers about how important it is to make sure that there is better experience for the patients, and there is also care about the staff and their well-being as well. I'm really privileged to share what Alpha Droid is doing for healthcare, but let me start something and get some of the things ready for myself. What we have is Hey Alpha, and I don't have a call button to call for any assistance. So what I will do, I will speak with my Hey Alpha. Hi, can you send me 2 cups of coffee, please? Hello? Sorry, she's not happy. Maybe this is network jammer which is not allowing today. If we move to the next. This is the one? Myself, Sanjeev Kumar, and I'm the founder of Alpha Droid. After being in technology and business for more than 20 years, building EV cars for some of the prestigious company, moved to India 5 years back and started building robots. These are the autonomous robots, what we build completely in India, which works in India and ready for the globe. These are the AI-powered autonomous robots. Along with my colleague, Pragati Tripathi, who heads the business, and she's also the head of strategy. We will take you through what we do as part of Alpha Droid for healthcare sector. There are 3 key elements which I'm going to really pick today. One is all about the waiting time. And waiting time for the patients is not only about medicines or about the health, but also about knowing something, basic information. We are working to see how we can bring AI to empower those patients to get the information quickly and in a right way. The second critical element is about patient experience. How do we enable the front office to have a smarter and a better services via robots, and via smart robots which is going to empower human. And the third critical element, which now everybody is talking about, is how do we enable our healthcare staff? And we are working in that direction through some of these smart machines to enable healthcare staff as well. If I move to the next slide, and Pragati is going to join me talking about it, but this is what we do as part of Alpha Droid. We have these robots. We started first bringing these robots in the front office for hospitality, and now we have brought it today in healthcare sector. These robots can deliver medicine, these robots can deliver food, these robots are very much capable to interact with the patients and answer and solve some of the basic needs which patients are looking for. Pragati, if you want to add more.
Hi everyone, good afternoon. So I'm Pragati, I am the Chief of Business and Strategy at Alpha Droid, and what we want to do here is enable our wonderful healthcare staff so that all the understaffing that is a very important and a very critical problem that our healthcare system is facing all across the globe, in fact, more so in India. We just want to complement that staff in a way that a lot of the non-critical work can be taken up by technology, where, technology perfectly marries the human staff in terms of creating a wonderful experience and also giving the utmost level of healthcare that needs to be given through our institutions. So we have our autonomous service robots as well as our conversational 3D avatars. Now these are peas in the same pod. The overall aim remains the same. What we want to do is we want to transform the entire patient journey, where from the time a patient enters the hospital, instead of standing in long queues, which is a very prevalent problem that is faced by people today in India, they can just simply go and talk to a virtual concierge who can help them book appointments, who can tell them if they already have a pre-scheduled room, how to go there, where to go, which doctor to meet, what all prescriptions, how to send them to the pharmacy and all of that. And as the patient moves across different stages of their healthcare journey within the hospital, every place, one way or the other, Alpha Droid is present, either through delivering food through robots, delivering medicines, which automatically come from the pharmacy to the OTs, to the rooms, to the waiting areas, to the emergency rooms. And all of this is enabled by our virtual concierge, which is Hey Alpha. So I'll just show you how it works. So here, this is a video. Can we just see? Okay. All right, so let me just, this is actually speaking. Okay, let me just try and explain what's happening here. So this is just one of the use cases where we have a huge facility, a huge hospital, where a patient enters and doesn't know where to go for a particular appointment that the patient already has. Now here, they can simply go to Hey Alpha and talk in any language that they're comfortable in, Hindi, English, or one of the many hundreds of languages that are there in India, and of course across the globe. They can just simply ask that I want to go to a particular place. Hey Alpha will just, through AI, just tell them take this route and navigate it. Similarly, they can also book an appointment. Just go and say that, hey, I want to go to the cardiology department and meet Dr. Brown's, for example. And they will automatically check the calendar of Dr. Brown and book an appointment whenever it's available and is feasible for the patient. So these are things where, as one of the speakers actually said, that nothing can replace the smile and the warmth that a human gives, a human staff gives. But we also need to understand that where that smile and that warmth really matters, and ensure that we do it in the best way and give all the other complementary work to technology. And that essentially is what we're trying to do at Alpha Droid. That's all from me. Thank you.
Sorry, we couldn't show you how Hey Alpha work because of the network, but we would love to have you in the smart hospital section, and we'll show you how Hey Alpha interacts with these robots and makes the life better. Our entire mantra is to make human life better with the brighter and the new age technology. Thank you so much.
Thank you so much for those transformations, innovation that helps fraternity, every fraternity. Thank you so much. Moving on to the next spotlight, it is the NABH Next Generation, elevating accreditation with digital excellence. May I invite Mr. Avinash Pandey, a member of NABH of Digital Lead, to please have a word on this.
Hi, good afternoon, and really glad to be here talking about the digital health standards of NABH. Can we have these slides, please? Okay, by the time the deck comes up, so what we have done in NABH, what I want to take you through is, so So you all know what NABH does. Our CEO has also taken you through what we are doing in NABH, much beyond the accreditation and the certifications that we do. We felt a need that digital is obviously now a very intrinsic part of doing any kind of a workflow, completing any workflow across any function in a hospital. You cannot now segregate digital out of the core activities that happens in different functions of a hospital. And that is where we felt a need that, to be able to complete a workflow, digital standards also need to evolve apart from the quality standards. And then only we can say that we have an accreditation for health standards in a hospital. And that is how the need was felt that we should come up with the digital health standards. Now, the approach which NABH has taken for the digital health standards is, I believe, a very unique approach. We believe that, we are the first country globally who has taken a very integrated approach to managing digital health in the country. So what we have done is, we have taken our quality standards as a baseline and then mapped each objective element to a digital health standard. So in September 2023 is when our digital health standards was launched for hospitals and healthcare providers. And we have then not stopped at that. We have even gone a step forward. What we have done is we have recently launched standards for HIS and EMR vendors as well. So it is, three separate set of standards. One is the quality standards, which is the core standards for hospitals. That we have aligned to the digital health standards for hospitals, and the digital health standards for hospitals have been aligned with the standards for HIS and EMR solutions. So in a way now, if a hospital implements NABH certified HIS and EMR, they are in turn assured that the digital health standards of the hospitals could be met. And if the digital health standards have been implemented in a hospital, then the quality standards becomes easy to implement. So this integrated approach, I'm very proud to say that we are the first body across the globe who has taken this integrated approach to digital health. What we are doing further to take digital health to the last mile, so the objective is very clear. Unless digital health standards do not reach each postcode of India, we cannot really say that, we have met our final goal. So what we are doing is, and that is where you all come in, and we need all your support and collaboration. We are coming up with a buddy program wherein we are going to invite our platinum and gold accredited DHS standard hospitals to be a buddy for aspiring hospitals who want to start on the digital journey. So we would be reaching out through our various yatras across the country, where we would invite these buddies to come in, handhold the hospitals who are starting on the digital journey. And this is the way we can bring in a revolution, a change in terms of adoption of digital health standards across the country. Because we all know that the bedrock, when we talk about interoperability in healthcare, the bedrock of that is finally the base application, which is the HIS and EMR. So once we have done that, that is when the data would start coming in, and that is when interoperability and the actual adoption of ABDM would happen. So just wanted to share these few things of what we are doing in NABH. We are really looking forward to your collaboration in taking this journey forward. Thank you and Jai Hind.
Thank you so much. Good evening, good afternoon, all of you. Just a few important announcements. First of all, we would really like to apologize for any of the inconveniences that you may have had since morning. Please understand that, we had PM's visit at the same venue as well as Vice President of India's visit at the same venue. And hence there were umpteen number of security restrictions, including a lot of material that had to come in for the conference. So we really apologize for any of these inconveniences that it may have caused any one of you. We have the last session before the lunch on future of health systems. That's happening in the parallel hall, which is going to start now. Honorable Minister Dr. Jitendra Singh is going to be presiding over the event. We also have Mr. Puneet Chandok, Mr. Harold Wolf, from HIMSS who are going to be a part of this session. So I may request you to join for the session there. Post that from 1 o'clock to 3 o'clock onwards, we do have lunch organized at Exhibition Hall number 14. So you just have to walk down, move towards the exhibition hall, and while coming up, you don't have to go through all the steps again because hopefully PM would have left the building by then. So there are many exciting activities also that we have planned for you. There is lunch there at Hall 14, Exhibition Hall. Please also collect your registration kits from the registration space, which is also in Hall number 14, just behind the lunch counters. And we'll see you back at 3 p.m. 3 p.m. Parallel sessions will happen. So one session will happen in plenary hall, and the other parallel sessions will happen in level 1. So you may, based on the agenda that you have, you just need to refer to the hall numbers, and all the other halls are there in level 1, while this is the plenary hall where all the parallel sessions would happen. Thank you so much. Request you to join the next hall for Dr. Jitendra Reddy's session on future of health systems. Thank you.
Everyone deserves safe, reliable, and high-quality healthcare. ACHS International Accreditation recognises commitment to world-leading healthcare standards and continuous quality improvement, building trust with your patients and partners. The Australian Council on Healthcare Standards, ACHS, is Australia's largest, most trusted and experienced hospital and healthcare accreditation provider. At ACHS International, we're proud to share the standards of one of the world's best healthcare systems. Our services extend beyond accreditation. We're your trusted quality improvement partner. Gain unique access to ongoing support from top industry experts to stay at the forefront of innovation and deliver sustainable, quality, patient-centred care with confidence. Our distinctive partnership approach includes bespoke quality improvement programs, connection and shared insights with a global network, unparalleled benchmarking of performance and outcomes globally, increased staff competencies through exceptional education and training, and international recognition for dedication to excellence. We are committed to identifying and implementing continuous quality improvement, tailored to your needs. Join our global network and showcase your commitment to excellence in healthcare. Partner with ACHS International.
The Apollo Enhanced Connected Care project has redefined patient care by leveraging AI-enabled remote monitoring to save lives at scale. The impact of this project has been remarkable.
The ECC project has led to an 80% reduction in code blue incidents and actually about 23% fewer ICU transfers, ensuring better patient outcomes. We looked at how can we reduce the nursing times, and Dozy came in as like a savior at that point of time. So with this particular project, we could bridge the gap between non-ICU and ICU level monitoring. We do have centralized command centers in Chennai and Hyderabad. Our medical teams can monitor patients across multiple hospitals.
Patients in high dependency area and patients who are in intensive care, they get monitored 24 hours, 24/7. Same thinking has not been applied to the patients in the ward who might be vulnerable. Hence, we thought that if they were to be monitored continuously, we would be able to pick up deterioration much earlier.
We started with a single hospital pilot and the results were clear. Early detection led to significantly better clinical outcomes and reduced the workload for nurses. Within months, the project expanded rapidly. Today, ECC is operational across 31 Apollo hospitals, covering 1,800 non-critical care beds, making it India's largest remote monitoring initiative. Dozy, as a key partner, played a pivotal role in helping implement this initiative at scale.
We also conducted a study and mapped to some extent some of the parameters. We actually presented the same study at ISQA conference last year. This project has resulted in about 80% lesser code blue incidents, obviously fewer ICU admissions, and improved patient survival rates. About 1949 life-saving alerts for the timeline that we looked at this project for, enabling timely interventions. About 70% reduction in nurse workload. It did help in 26% cost reduction in hospital ward operations, optimizing how do we utilize our resources effectively. Our vision is to expand this model across all of our units, driving into a new era of AI-enabled, proactive healthcare that saves lives at scale.
We found that we were not only picking up deterioration much early, but also our code blue calls, which is the emergency calls in some of the hospitals, came down to 0. But also we found that our readmission rate, so patients who left ICU went back to ward, many of them come back to ICU because things get deteriorate in the wards. That rate of readmission reduced significantly. So that gave us the confidence that this is the right way to go. We started this as a pilot. We have implemented it in our system, and we made our safe care even safer.
Of our minds, fears lurk. For some, it's the fear of closed spaces. What if there is a solution? Introducing Fujifilm's Open MRI, breaking the chains of claustrophobia. open design accommodates everyone, from the littlest to the strongest, because everyone deserves care without compromise. Inclusive healthcare that knows no bounds.
Values are what define you. Give you the motivation to go further. The motivation to help those beyond the horizon. And extend a hand to those who need it most. Values will help you help others and make some friends along the way. Friends that will always be grateful for the values you possess, because these values aren't just words. They are the core of who you are. Fujifilm has been living up to its value for innovation by using the ultra-modern handheld X-ray device to fight TB in India. The CSR activity of Fujifilm India is taking the portable X-ray device to the doorstep of the population that is vulnerable to support India become TB-free. The ultra-low-dose DR technology produces high-quality image that is transforming the landscape of TB detection in India. Fujifilm India has screened over 34,000 symptomatic people till now. And promises to support the mission of a TB-free India. Because healthcare isn't a luxury. It's a basic human right.
One, mic check, test, hey, mic check, test, one, hey, test. Hey, one, hey, check, test. Hey, check, test, one, mic check, test, one, hey, 6, 1, 6, check, mic check, 1, hey, check, hey, 6, 1, 6, check, 1, hey. Hey, hey, 1. Mic check, test. Hello. Hey, 6. Hey, check. Mic check, test. Hello. Hey, check. Hey, 6. 1, 6. Check. Hey, 6. 1, 6. Hey, 6. Check. 1. 1. Mic check, test. Test. Hey, check. 1, 1. Mic check, test.
The ultra-low-dose DR technology produces high-quality image that is transforming the landscape of TB detection in India. Fujifilm India has screened over 34,000 symptomatic people till now. And promises to support the mission of a TB-free India. Because healthcare isn't a luxury. It's a basic human right.
It's been ages since I've seen Ma smile like that. Thanks to these two incredible women, Parodi and Ipshitadi. They rise every morning, embarking on a mission that brings smiles to countless faces. They go door to door, spreading awareness. Setting up camps and educating about breast cancer. It was then we understood the root of mass pain. Didi advised us to visit a diagnostic center for a mammography. We met Polumidi, the compassionate soul who supports the mission with technology. The process was comfortable thanks to Fujifilm's mammography equipment. The mammogram revealed a lump. Dr. Sholkar assured us that there's no need to fear and advised us for treatment. Thanks to Fujifilm's outreach campaign, early detection led to early treatment. Inspired by Fujifilm's initiative, we also joined their mission to bring hope and smiles.
For 175 years, Pfizer has been discovering, developing, and delivering breakthroughs that change patients' lives. Our first breakthrough in 1849 was a groundbreaking way to treat parasites. Years later, we delivered life-saving supplies to the Union Army. We continued on to become the world's largest producer of the miracle drug penicillin during World War II.
We're entering a new era of medicine in which the natural lifespan may be greatly expanded.
We fought polio with an oral vaccine and invented a needle that would be a key tool in eradicating smallpox.
The disease has been wiped off the face of the earth.
From discovering innovative therapies to treat heart disease and breast cancer, to delivering the first mRNA vaccine against COVID-19, Pfizer has changed the course of history. The world has changed a lot over the last 175 years, but one thing that has not changed is our commitment to our patients, the center of everything we do. To date, we've reached billions of patients with our medicines and vaccines, and we're just getting started. Expanding the limits of science, harnessing unprecedented technologies and groundbreaking therapies. And through our heightened focus on oncology, Pfizer is driven to become a world leader in the fight against cancer. And together with our patients, advocates, partners, and colleagues, we are determined to outdo yesterday.
There's a world of innovation in every medication from Pfizer. For more than 170 years, Pfizer has demonstrated its high standards for clinical and manufacturing excellence in a wide range of therapeutic categories. We currently offer patients one of the industry's largest and most diverse portfolios of anti-infectives, more than 80 medicines, including therapies that help address areas of greatest unmet medical need, such as the treatment of gram-negative bacterial and invasive fungal infections. In 2022, Pfizer manufactured more than 150 million doses of antibacterial and antifungal medications. Driven by a passion for safety and quality, Pfizer adheres to rigorous manufacturing practices for all products, including IV anti-infectives. High-quality IV anti-infectives begin with high-quality raw materials. Our dedicated team ensures our suppliers meet Pfizer's highest standards. Every Pfizer product is thoroughly tested and analyzed to meet or exceed local requirements during manufacturing. During the manufacturing process of IV anti-infectives, key control points are continuously monitored, including air and water supplies, ensuring that every step of the production process is tightly controlled. Pfizer expert teams continuously work to ensure the safety of our products. Our sterile injectable products, including IV anti-infectives, have been produced under these high standards. Pfizer is committed to responsible manufacturing practices that minimize impact to human health and the environment. We are driven to achieving the voluntary net zero standard for greenhouse gas emissions by 2040. We also significantly reduce hazardous waste generation in some of our largest manufacturing facilities through efforts such as decreasing water withdrawal. We are proud to celebrate a decade of green chemistry leadership. Why do we hold ourselves to such high standards? Because we know that people around the world rely on Pfizer medications no matter where they live. For more than 170 years, many things have changed, but one thing remains the same. You can always trust Pfizer to provide patients with the quality medications they deserve. Thank you for watching this video.
Portso plays a huge role in determining the ease of operations within any hospital.
I'm Dr. Tausif Tanglwadi, Vice President of Operations and Medical Director at Red Health, and I'm proud to be a part of the International Patient Safety Conference this year. As an emergency physician, I know firsthand how critical timely and effective interventions are in saving lives. Patient safety isn't just about protocols. It is about rapid response, seamless coordination, and leveraging technology to ensure that every second counts in an emergency. At the IPSC, I look forward to discussing how innovation in emergency medical services can bridge critical gaps, enhance clinical outcomes, and ultimately build a more resilient healthcare ecosystem. I look forward to meeting global experts, exchanging insights, and working together towards a more safer and effective solution to emergency care. See you at the IPSC.
Let's talk nanotechnology, the heart of Thermaisan's fabric. At its core, Thermaisan's fabric is powered by nanotechnology. By engineering materials at the atomic and molecular levels, we've developed a textile that's not only stronger, but smarter. Nanomaterials are embedded directly into its fibers, giving us an unmatched degree of control over the fabric's performance, durability, and adaptability. This is a textile that has been optimized at the molecular level to resist wear and tear, to stay light yet incredibly strong, and to respond to changes in its environment. 3 ways nanotech enhances our fabric. Antimicrobial protection. Our fabric also integrates advanced antimicrobial properties that actively protect the wearer by disrupting pathogens on contact, with effectiveness lasting through over 100 laundering cycles. Smart response to temperature and moisture. What truly sets this fabric apart is its dynamic behavior. Nanotechnology allows it to respond to its environment, whether it's regulating temperature, managing moisture, or adjusting to changes in humidity. It's a fabric that doesn't just sit there. It interacts with the wearer, working to maintain their comfort at all times. Durability. With nanomaterials embedded into the textile, we've enhanced the tensile strength of each fiber without adding unnecessary weight. This gives us a fabric that's incredibly resilient, holding up through countless uses without compromising on comfort or flexibility. Field testing and real-world performance. Thermaisan's fabrics have undergone rigorous testing in diverse environmental conditions. They consistently perform, maintaining antimicrobial and thermoregulation efficacy in extreme environments, making them ideal for high-demand industries.
Everyone deserves safe, reliable, and high-quality healthcare. ACHS International Accreditation recognizes commitment to world-leading healthcare standards and continuous quality improvement, building trust with your patients and partners. The Australian Council on Healthcare Standards, ACHS, is Australia's largest, most trusted and experienced hospital and healthcare accreditation provider. At ACHS International, we're proud to share the standards of one of the world's best healthcare systems. Our services extend beyond accreditation. We're your trusted quality improvement partner. Gain unique access to ongoing support from top industry experts to stay at the forefront of innovation and deliver sustainable, quality, patient-centered care with confidence. Our distinctive partnership approach includes bespoke quality improvement programs, connection and shared insights with a global network, unparalleled benchmarking of performance and outcomes globally, increased staff competencies through exceptional education and training, and international recognition for dedication to excellence. We are committed to identifying and implementing continuous quality improvement, tailored to your needs. Join our global network and showcase your commitment to excellence in healthcare. Partner with ACHS International.
The Apollo Enhanced Connected Care project has redefined patient care by leveraging AI-enabled remote monitoring to save lives at scale. The impact of this project has been remarkable.
The ECC project has led to an 80% reduction in code blue incidents and actually about 23% fewer ICU transfers, ensuring better patient outcomes. We looked at how can we reduce the nursing times, and Dozy came in as like a savior at that point of time. So with this particular project, we could, bridge the gap between non-ICU and ICU level monitoring. We do have centralized command centers in Chennai and Hyderabad. Our medical teams can monitor patients across multiple hospitals.
Patients in high dependency area and patients who are in intensive care, they get monitored 24 hours, 24/7. Same thinking has not been applied to the patients in the ward who might be vulnerable. Hence, we thought that if they were to be monitored continuously, we would be able to pick up deterioration much earlier.
We started with a single hospital pilot and the results were clear. Early detection led to significantly better clinical outcomes and reduced the workload for nurses. Within months, the project expanded rapidly. Today, ECC is operational across 31 Apollo hospitals, covering 1,800 non-critical care beds, making it India's largest remote monitoring initiative. Dozy, as a key partner, played a pivotal role in helping implement this initiative at scale.
We also conducted a study and mapped to some extent some of the parameters. We actually presented the same study at ISQA conference last year. This project has resulted in about 80% lesser code blue incidents, obviously fewer ICU admissions, and improved patient survival rates. About 1949 life-saving alerts for the timeline that we looked at this project for, enabling timely interventions. About 70% reduction in nurse workload. It did help in 26% cost reduction in hospital ward operations, optimizing how do we utilize our resources effectively. Our vision is to expand this model across all of our units, driving into a new era of AI-enabled, proactive healthcare that saves lives at scale.
We found that we were not only picking up deterioration much early, but also our code blue calls, which is the emergency calls in some of the hospitals, came down to zero. But also we found that our readmission rate, so patients who left ICU went back to ward, many of them come back to ICU because things get deteriorate in the wards. That rate of readmission reduced significantly. So that gave us the confidence that this is the right way to go. We started this as a pilot. We have implemented it in our system, and we made our safe care even safer.
In the quiet corners of our minds, fears lurk. For some, it's the fear of closed spaces. But what if there is a solution? Introducing Fujifilm's Open MRI, breaking the chains of claustrophobia. design accommodates everyone, from the littlest to the strongest, because everyone deserves care without compromise. Inclusive healthcare that knows no bounds.
Values are what define you. Give you the motivation to go further. The motivation to help those beyond the horizon. And extend a hand to those who need it most. Values will help you help others and make some friends along the way. Friends that will always be grateful for the values you possess, because these values aren't just words. They are the core of who you are. Fujifilm has been living up to its value for innovation by using the ultra-modern handheld X-ray device to fight TB in India. The CSR activity of Fujifilm India is taking the portable X-ray device to the doorstep of the population that is vulnerable to support India become TB-free. The ultra-low-dose DR technology produces high-quality image that is transforming the landscape of TB detection in India. Fujifilm India has screened over 34,000 symptomatic people till now. And promises to support the mission of a TB-free India. Because healthcare isn't a luxury. It's a basic human right.
Hear the warm melodies of family gathered around. Baby's very first word, making mama proud. All the things that seem to make us grow, and all the time we spent together makes the future shine brighter. Moments like these feel so fine. Open up our eyes and see the sunrise. Give us moments like these till the end of time. 'Cause it's been so great, but the best is yet to come. Winter makes the summer shine brighter. Spring and the fall make the colors lighter. Looking forward to whatever may come, knowing full well that all the time we spent together makes the future shine brighter. Moments like these feel so fine. Open up our eyes and see the sunrise. Give us moments like these till the end of time. 'Cause it's been so great, but the best is yet to come.
are what define you. Give you the motivation to go further. The motivation to help those beyond the horizon. And extend a hand to those who need it most. Values will help you help others and make some friends along the way. Friends that will always be grateful for the values you possess, because these values aren't just words. They are the core of who you are. Fujifilm has been living up to its value for innovation by using the ultra-modern handheld X-ray device to fight TB in India. The CSR activity of Fujifilm India is taking the portable X-ray device to the doorstep of the population that is vulnerable to support India become TB-free. The ultra-low-dose DR technology produces high-quality image that is transforming the landscape of TB detection in India. Fujifilm India has screened over 34,000 symptomatic people till now. And promises to support the mission of a TB-free India. Because healthcare isn't a luxury. It's a basic human right.
It's been ages since I've seen Ma smile like that. Thanks to these two incredible women, Parvati and Ipshitadi. They rise every morning, embarking on a mission that brings smiles to countless faces. They go door to door, spreading awareness. Setting up camps and educating about breast cancer. It was then we understood the root of mass pain. Didi advised us to visit a diagnostic center for a mammography. We met Polumidi, the compassionate soul who supports the mission with technology. The process was comfortable thanks to Fujifilm's mammography equipment. The mammogram revealed a lump. Dr. Sholkar assured us that there's no need to fear and advised us for treatment. Thanks to Fujifilm's outreach campaign, early detection led to early treatment. Inspired by Fujifilm's initiative, we also joined their mission to bring hope and smiles.
For 175 years, Pfizer has been discovering, developing, and delivering breakthroughs that change patients' lives. Our first breakthrough in 1849 was a groundbreaking way to treat parasites. Years later, we delivered life-saving supplies to the Union Army. We continued on to become the world's largest producer of the miracle drug penicillin during World War II.
We're entering a new era of medicine in which the natural lifespan may be greatly expanded.
We fought polio with an oral vaccine and invented a needle that would be a key tool in eradicating smallpox.
The disease has been wiped off the face of the earth.
From discovering innovative therapies to treat heart disease and breast cancer, to delivering the first mRNA vaccine against COVID-19, Pfizer has changed the course of history. The world has changed a lot over the last 175 years, but one thing that has not changed is our commitment to our patients, the center of everything we do. To date, we've reached billions of patients with our medicines and vaccines, and we're just getting started. Expanding the limits of science, harnessing unprecedented technologies and groundbreaking therapies. And through our heightened focus on oncology, Pfizer is driven to become a world leader in the fight against cancer. And together with our patients, advocates, partners, and colleagues, we are determined to outdo yesterday.
There's a world of innovation in every medication from Pfizer. For more than 170 years, Pfizer has demonstrated its high standards for clinical and manufacturing excellence in a wide range of therapeutic categories. We currently offer patients one of the industry's largest and most diverse portfolios of anti-infectives, more than 80 medicines, including therapies that help address areas of greatest unmet medical need, such as the treatment of gram-negative bacterial and invasive fungal infections. In 2022, Pfizer manufactured more than 150 million doses of antibacterial and antifungal medications. Driven by a passion for safety and quality, Pfizer adheres to rigorous manufacturing practices for all products, including IV anti-infectives. High-quality IV anti-infectives begin with high-quality raw materials. Our dedicated team ensures our suppliers meet Pfizer's highest standards. Every Pfizer product is thoroughly tested and analyzed to meet or exceed local requirements during manufacturing. During the manufacturing process of IV anti-infectives, key control points are continuously monitored, including air and water supplies, ensuring that every step of the production process is tightly controlled. Pfizer expert teams continuously work to ensure the safety of our products. Our sterile injectable products, including IV anti-infectives, have been produced under these high standards. Pfizer is committed to responsible manufacturing practices that minimize impact to human health and the environment. We are driven to achieving the voluntary net zero standard for greenhouse gas emissions by 2040. We also significantly reduce hazardous waste generation in some of our largest manufacturing facilities through efforts such as decreasing water withdrawal. We are proud to celebrate a decade of green chemistry leadership. Why do we hold ourselves to such high standards? Because we know that people around the world rely on Pfizer medications no matter where they live. For more than 170 years, many things have changed, but one thing remains the same. You can always trust Pfizer to provide patients with the quality medications they deserve. Thank you for watching this video.
Porto plays a huge role in determining the ease of operations within any hospital.
Hello everyone, I'm Dr. Tausif Tangalwadi, Vice President of Operations and Medical Director at Red Health, and I'm proud to be a part of the International Patient Safety Conference this year. As an emergency physician, I know firsthand how critical, timely and effective interventions are in saving lives. Patient safety isn't just about protocols. It is about rapid response, seamless coordination and leveraging technology to ensure that every second counts in an emergency. At the IPSC, I look forward to discussing how innovation in emergency medical services can bridge critical gaps, enhance clinical outcomes, and ultimately build a more resilient healthcare ecosystem. I look forward to meeting global experts, exchanging insights, and working together towards a more safer and effective solution to emergency care. See you at the IPSC.
Let's talk nanotechnology, the heart of Thermaisen's fabric. At its core, Thermaisen's fabric is powered by nanotechnology. By engineering materials at the atomic and molecular levels, we've developed a textile that's not only stronger, but smarter. Nanomaterials are embedded directly into its fibers, giving us an unmatched degree of control over the fabric's performance, durability, and adaptability. This is a textile that has been optimized at the molecular level to resist wear and tear, to stay light yet incredibly strong, and to respond to changes in its environment. 3 ways nanotech enhances our fabric. Antimicrobial protection. Our fabric also integrates advanced antimicrobial properties that actively protect the wearer by disrupting pathogens on contact, with effectiveness lasting through over 100 laundering cycles. Smart response to temperature and moisture. What truly sets this fabric apart is its dynamic behavior. Nanotechnology allows it to respond to its environment, whether it's regulating temperature, managing moisture, or adjusting to changes in humidity. It's a fabric that doesn't just sit there. It interacts with the wearer, working to maintain their comfort at all times. Durability. With nanomaterials embedded into the textile, we've enhanced the tensile strength of each fiber without adding unnecessary weight. This gives us a fabric that's incredibly resilient, holding up through countless uses without compromising on comfort or flexibility. Field testing and real-world performance. Thermaisen's fabrics have undergone rigorous testing in diverse environmental conditions. They consistently perform, maintaining antimicrobial and thermoregulation efficacy in extreme environments, making them ideal for high-demand industries.
Everyone deserves safe, reliable, and high-quality healthcare. ACHS International Accreditation recognizes commitment to world-leading healthcare standards and continuous quality improvement, building trust with your patients and partners. The Australian Council on Healthcare Standards, ACHS, is Australia's largest, most trusted and experienced hospital and healthcare accreditation provider. At ACHS International, we're proud to share the standards of one of the world's best healthcare systems. Our services extend beyond accreditation. We're your trusted quality improvement partner. Gain unique access to ongoing support from top industry experts to stay at the forefront of innovation and deliver sustainable, quality, patient-centered care with confidence. Our distinctive partnership approach includes bespoke quality improvement programs, connection and shared insights with a global network, unparalleled benchmarking of performance and outcomes globally, increased staff competencies through exceptional education and training, and international recognition for dedication to excellence. We are committed to identifying and implementing continuous quality improvement, tailored to your needs. Join our global network and showcase your commitment to excellence in healthcare. Partner with ACHS International.
The Apollo Enhanced Connected Care project has redefined patient care by leveraging AI-enabled remote monitoring to save lives at scale. The impact of this project has been remarkable.
The ECC project has led to an 80% reduction in code blue incidents and actually about 23% fewer ICU transfers, ensuring better patient outcomes. We looked at how can we reduce the nursing times, and Dozy came in as like a savior at that point of time. So with this particular project, we could bridge the gap between non-ICU and ICU level monitoring. We do have centralized command centers in Chennai and Hyderabad. Our medical teams can monitor patients across multiple hospitals.
Patients in high dependency area and patients who are in intensive care, they get monitored 24 hours, 24/7. Same thinking has not been applied to the patients in the ward who might be vulnerable. Hence, we thought that if they were to be monitored continuously, we would be able to pick up deterioration much earlier.
We started with a single hospital pilot and the results were clear. Early detection led to significantly better clinical outcomes and reduced the workload for nurses. Within months, the project expanded rapidly. Today, ECC is operational across 31 Apollo hospitals, covering 1,800 non-critical care beds, making it India's largest remote monitoring initiative. Dozy, as a key partner, played a pivotal role in helping implement this initiative at scale.
We also conducted a study and mapped to some extent some of the parameters. We actually presented the same study at ISQA conference last year. This project has resulted in about 80% lesser code blue incidents, obviously fewer ICU admissions, and improved patient survival rates. About 1949 life-saving alerts for the timeline that we looked at this project for, enabling timely interventions. About 70% reduction in nurse workload. It did help in 26% cost reduction in hospital ward operations, optimizing how do we utilize our resources effectively. Our vision is to expand this model across all of our units, driving into a new era of AI-enabled, proactive healthcare that saves lives at scale.
We found that we were not only picking up deterioration much early, but also our code blue calls, which is the emergency calls in some of the hospitals, came down to 0. But also we found that our readmission rate, so patients who left ICU went back to ward, many of them come back to ICU because things get deteriorate in the wards. That rate of readmission reduced significantly. So that gave us the confidence that this is the right way to go. We started this as a pilot. We have implemented it in our system, and we made our safe care even safer.
Of our minds, fears lurk. For some, it's the fear of closed spaces. What if there is a solution? Introducing Fujifilm's Open MRI, breaking the chains of claustrophobia. The open design accommodates everyone, from the littlest to the strongest, because everyone deserves care without compromise. Inclusive healthcare that knows no bounds.
Values are what define you. Give you the motivation to go further. The motivation to help those beyond the horizon. And extend a hand to those who need it most. Values will help you help others and make some friends along the way. Friends that will always be grateful for the values you possess, because these values aren't just words. They are the core of who you are. Fujifilm has been living up to its value for innovation by using the ultra-modern handheld X-ray device to fight TB in India. The CSR activity of Fujifilm India is taking the portable X-ray device to the doorstep of the population that is vulnerable to support India become TB-free. The ultra-low-dose DR technology produces high-quality image that is transforming the landscape of TB detection in India. Fujifilm India has screened over 34,000 symptomatic people till now. And promises to support the mission of a TB-free India. Because healthcare isn't a luxury. It's a basic human right.
Hear the warm melodies of family gathered around. Baby's very first word, making
exhibit area.
Get ready to connect. Get ready to connect, play, and win exciting prizes at the conference. Introducing the Play and Win contest, where you can earn points through fun activities and compete for fantastic rewards. Throughout the conference, you'll collect points by completing different activities. The more you play, the more you win. But it's not just about points. There are amazing prizes up for grabs. Visit the conference stalls and collect scratch coupons. Scratch them to reveal your code, then upload it on the app to rack up points. Listen closely during each session as words will be announced. Match them on your bingo card and complete a box to score points and increase your chances of winning. Check out the clues on the IHD app and visit the stalls to scan QR codes. Each scan brings you more points and more chances to win. Joining is easy. Simply visit the IHD app, Play and Win section. Start collecting points and keep track of your progress. Don't miss out on the fun and the chance to win amazing prizes. Start collecting points today and be a part of the Play and Win contest. Let's play, win, and make lasting memories together.
Everyone deserves safe, reliable, and high-quality healthcare. ACHS International Accreditation recognizes commitment to world-leading healthcare standards. And
Hello everyone, I'm Dr. Tausif Tangalwadi, Vice President of Operations and Medical Director at Red Health, and I'm proud to be a part of the International Patient Safety Conference this year. As an emergency physician, I know firsthand how critical, timely and effective interventions are in saving lives. Patient safety isn't just about protocols. It is about rapid response, seamless coordination and leveraging technology to ensure that every second counts in an emergency. At the IPSC, I look forward to discussing how innovation in emergency medical services can bridge critical gaps, enhance clinical outcomes, and ultimately build a more resilient healthcare ecosystem. I look forward to meeting global experts, exchanging insights, and working together towards a more safer and effective solution to emergency care. See you at the IPSC.
Let's talk nanotechnology, the heart of Thermisans fabric. At its core, Thermisans fabric is powered by nanotechnology. By engineering materials at the atomic and molecular levels, we've developed a textile that's not only stronger but smarter. Nanomaterials are embedded directly into its fibers, giving us an unmatched degree of control over the fabric's performance, durability, and adaptability. This is a textile that has been optimized at the molecular level to resist wear and tear, to stay light yet incredibly strong, and to respond to changes in its environment. 3 ways nanotech enhances our fabric. Antimicrobial protection. Our fabric also integrates advanced antimicrobial properties that actively protect the wearer by disrupting pathogens on contact, with effectiveness lasting through over 100 laundering cycles. Smart response to temperature and moisture. What truly sets this fabric apart is its dynamic behavior. Nanotechnology allows it to respond to its environment, whether it's regulating temperature, managing moisture, or adjusting to changes in humidity. It's a fabric that doesn't just sit there. It interacts with the wearer, working to maintain their comfort at all times. Durability. With nanomaterials embedded into the textile, we've enhanced the tensile strength of each fiber without adding unnecessary weight. This gives us a fabric that's incredibly resilient, holding up through countless uses without compromising on comfort or flexibility. Field testing and real-world performance. Thermisans fabrics have undergone rigorous testing in diverse environmental conditions. They consistently perform, maintaining antimicrobial and thermoregulation efficacy in extreme environments, making them ideal for high-demand industries.
May I have your attention, please? Explore a wide range of resources and insightful information available in the exhibit area. Engage with cutting-edge research through the poster displays. Take a moment to review and gain valuable insights. To ensure a comfortable and distraction-free environment, please refrain from eating inside the session halls. Participate in our activities and contests throughout the conference for a chance to win exciting prizes. Don't miss out on the fun. Stay with us until the valedictory session. Prizes will be awarded, and we have special surprises in store for you. Engage with fellow attendees, share your insights, and be part of meaningful discussions. Let's make this conference interactive and memorable. May I have your attention, please? Welcome to the 12th International Patient Safety Conference. Please pay attention to these important instructions. Plan your agenda in advance to ensure you don't miss key sessions. All sessions will begin on time. Please be seated before the session starts. As a courtesy to our speakers and fellow delegates, keep your devices on silent and avoid any distractions. To participate in Q&A sessions and access exclusive content, download the conference app. Let's make this a valuable and enriching experience for all.
Get ready to connect, play, and win exciting prizes at the conference. Introducing the Play and Win contest, where you can earn points through fun activities and compete for fantastic rewards. Throughout the conference, you'll collect points by completing different activities. The more you play, the more you win. But it's not just about points. There are amazing prizes up for grabs. Visit the conference stalls and collect scratch coupons. Scratch them to reveal your code, then upload it on the app to rack up points. Listen closely during each session, as words will be announced. Match them on your bingo card and complete a box to score points and increase your chances of winning. Check out the clues on the IHD app and visit the stalls to scan QR codes. Each scan brings you more points and more chances to win. Joining is easy. Simply visit the IHD app, Play and Win section. Start collecting points and keep track of your progress. Don't miss out on the fun and the chance to win amazing prizes. Start collecting points today and be a part of the Play and Win contest. Let's play, win, and make lasting memories together.
Good afternoon and welcome back to the International. Good afternoon. Okay. Can we request all the delegates who are seated at the back to please occupy the rows in the front? Can we request all the delegates who are seated at the back of the row to please occupy the seats at the front row? It's a humble, kind request. Please occupy the front rows and we can kickstart the sessions. We have plenty of seats in the front. Please occupy the front rows.
Get ready to connect, play, and win exciting prizes at the conference. Introducing the Play and Win contest, where you can earn points through fun activities and compete for fantastic rewards. Throughout the conference, you'll collect points by completing different activities. The more you play, the more you win. But it's not just about points. There are amazing prizes up for grabs. Visit the conference stalls and collect scratch coupons. Scratch them to reveal your code, then upload it on the app to rack up points. Listen closely during each session, as words will be announced. Match them on your bingo card and complete a box to score points and increase your chances of winning. Check out the clues on the IHD app and visit the stalls to scan QR codes. Each scan brings you more points and more chances to win. Joining is easy. Simply visit the IHD app, Play and Win section. Start collecting points and keep track of your progress. Don't miss out on the fun and the chance to win amazing prizes. Start collecting points.
Good afternoon and welcome back to the International Safety Conference 2025. I hope all of the delegates and speakers are interested to win a lot of prizes when you go on the second day out of here. So as the AV said about the bingo, we are going to announce the first set of words for your bingo card. The words are audits. The first word is audits. Second word is workplace safety. Second word is workplace safety. And the third word is incident reporting. I repeat the words again. It's audits, workplace safety, and incident reporting. And all the best to all the delegates.
All right, so I hope everybody has marked those words on their bingo card. Bingo cards you would find in your registration kit if people are still trying to identify where you would get that. It is available with your registration kit. Take out those cards and mark the words which are just announced. If in case you want me to repeat the words, do let me know.
I would repeat it again. I hope everyone has taken their bingo cards out of their registration kit. And the words are audits, workplace safety, and incident reporting.
Moving now to our next session before lunch. The next session post lunch. And the topic now we are going to discuss on is a very interesting topic, accreditation, the catalyst. Accreditations are more than just certifications, they are benchmarks of excellence, inspiring organizations to push boundaries and elevate standards. And that's exactly what we are here to explore today. Each one of us, whether a healthcare professional, administrator, policymaker, or advocate, plays a vital role in ensuring that our patients, they receive the safest care possible. But achieve excellence in patient safety is not just about preventing errors, it is about building a culture of safety. Throughout the session, we'll be exploring on the impact of accreditations across various sectors, hear success stories, and engage in thought-provoking discussions. I would now like to invite our esteemed session chair to the stage, Dr. Giridhar Gyani, Director General, AHPI. Please welcome him on the stage with a warm round of applause, please. Dr. Gyani holds doctorate degree in quality. He held the assignment as Secretary General, Quality Council of India, 2013 to 12, served as elected director on board of International Accreditation Forum, IAF, during 2004 to 2010, and International Society for Quality in Healthcare, ISQA, for 2009 to 14, a recipient of 16th Lal C. Varman Award in year 2002. SME World Magazine, in its cover story of June 2012, described Dr. Gyani as Quality Man of India. I take the opportunity to invite the esteemed speakers now on the stage. I hand over the forum to you now, Sulakshana.
Right. We have the speakers, starting with Mr. Som Mittal, Patients of Patient Safety Foundation. May I please request you to join on the dais, sir? Mr. Mittal is into advising companies, CEOs, trade bodies, and senior business leaders on business, management, government, and global policies, working with government worldwide to formulate trade, taxation, and immigration policies that balances business, national, and social interest. Welcome, sir. He's been followed by with Dr. Neelam Dhingra, Vice President, Chief Patient Safety Officer, Joint Commission International. Welcome, ma'am. Dr. Dhingra is a renowned expert in patient safety with a distinguished career dedicated to improving healthcare outcomes and ensuring a safety of patients worldwide.
Our next speaker, we have Brigadier Dr. Rakesh Datta. May I please request you to join the stage, sir? Dr. Datta is a seasoned ENT specialist with 24 years of experience, a postgraduate teacher, an examiner for 19 years, and a leader in medical education and research. He holds an MBBS and MS ENT from AFMC Pune, along with a fellowship in lasers, Belgium, and certification in health and medication law, with 44 indexed publications and 7 research projects as PI. I welcome you on stage, sir. Our next speaker, Dr. Rohini Sridhar, Chief of Medical Services, Apollo Hospitals. May I please request you to join the stage, ma'am? Dr. Rohini Sridhar trained as a pathologist from AIIMS, New Delhi, and subsequently completed her fellowship in hematology from Melbourne, Australia. She helped set up the bone marrow transplant service at Apollo Cancer Hospital, Chennai, spearheaded the clinical protocols and processes at Apollo Hospitals, Madurai, making it the first hospital in the Apollo group to complete NABH accreditation. I welcome you all to the stage. With this, I would hand over the forum to our session chair, Dr. Gyani. I would please request you to lead the session.
I will use the slides. I will only. Okay, good afternoon, as this is the first session after lunch. Normally they say after lunch, people are still awake. It takes 1 hour before you start browsing. So I think this session, I am sure all of us are going to be awake. And we have got excellent speaker, list down the line here. 4 of them are going to share their insight on subject of accreditation. Now, all of us are aware that accreditation in India, it came in 2006. While in the USA, the accreditation came in 1951. So we are almost, you can say, 60 years later on, we came into India. But overall, the accreditation has made a huge impact in our country. Because to youngsters, I want to tell you that in one line, if you want to describe accreditation, it means framework for quality governance. That means when you are accrediting a entity or a hospital, we are helping hospital to establish a framework. Now, once you have built a framework, then it is easy to build quality on that framework. I think going by that, if you see, today almost 20,000 hospitals in India have either accreditation or certification or empanelment. So that means, I think we have made a huge journey or big journey starting from 2006 to this place. Accrediting or certifying 20,000 hospitals is a big number, I will say. Now, what it has really made an impact, I can tell you here is, one, there is a governance model established. There is no firefighting, minimum of the firefighting. People take ownership of their own processes. Patients have more confidence because they know that this is a hospital which is system-based and whose systems are evaluated regularly by a national accreditation body, we call it NABH here. So I think that is one big thing. In fact, the history of NABH in India starts from the question raised in Parliament in year 2005, which wanted how the foreigners should select a hospital. That means the starting of NABH accreditation came from building the hospital system so as to attract the medical tourist. So right from word go, we established NABH based on the global benchmark, what we call ISQA. That means our standard was submitted to ISQA and we got the accreditation in year 2008. So I think today all the hospitals which are accredited, they meet the global benchmark on patient safety and quality of health care. And so I think in short, and finally, this has become a very easy and convenient tool for impaneling agency like insurance company, Government of India insurance scheme including CGHS or let us say Ayushman Bharat, that they can rely if the hospital is accredited, they can straightway impanel. In fact, they give little more reimbursement rate as an incentive. So all these things are happening. So I think with this, I will first invite Brigadier Datta and to share his idea or his impression and his experience rather, how accreditation is being catalyst. So we give, let us say, 10 minutes for you to make a point. Over to you. Thank you.
Thank you, sir, for this invitation. May I have my presentation on, please? First of all, I'd like to thank the organizers for giving this platform. It's indeed been a bit overwhelming to speak in this hall. It's been the largest hall I've ever spoken. I've been speaking for now 20 years or so, taking classes, but this is quite big. Can we have the presentation? Yeah, if you can have the slide deck. No, but the slide deck has to be there. Yeah. So I'll just introduce myself till the time they put up the slide deck. I am an ENT surgeon whose actually journey is, yeah, so here we go. So we are going to talk about some emerging healthcare models and how they relate to patient safety. So that is the brief given to me today. And in the context, of course, of accreditation, as well as, so the first disclaimer, these are my views. I represent my organization, that is the Armed Forces Medical Services. The views given here are very personal and there is no conflict of interest to declare. So my journey here is important to understand, briefly to understand my perspective. I'm a doctor, so I'll have a very clinical view of things, an ENT surgeon, following which I became a medical teacher, following which I entered into this realm of hospital administration where I've got exposed to some of these things. I had a couple of year exposures in managing medical logistics for a particular zone of the country. And finally, right now, I'm in a leadership position looking after implementation of digital health in the armed forces. So this is my background. I belong to the army. And therefore, I might have slightly different views. I'll try to take it a bit more basic. I'll try to make it a bit more applied and ask some questions more than try to really give you some great solutions. So the mixing pot actually is of these three particular terms. We are in a conference which is of patient safety. We're talking about patient safety. The brief is on emerging healthcare models in a session which is talking about accreditation as well as standards. So where do these all three get together? And if you see and mix all these three together, there's the intersection which we need to talk about. Yeah, slides. Yeah, so the first thing when we start is about patient safety, and the patient safety we've been hearing since morning, and this slide has come up. First, do no harm. And that's something which we all agree, and as we join the profession, is to do no harm. With that background, I've just made some 7 red flags. And these are 7 red flags which often are the places where we do maximum harm. And why this is very important is because based on this, we will judge each and every new technology which we are going to discuss. The communication errors, the medication errors, errors of identity, errors of nursing, procedural, of course, nosocomial hospital-acquired infections. And to add to the list, finally, is something which is coming more and more important, is the errors of privacy. And this, as more and more technology becomes more digital. Then we have the other melting pot, the other thing is the accretion which we've just talked about, and that is so important to measure anything which we want to improve. And that measurement is so important, whether it's subjective or objective. But till the time we measure things, we probably don't improve whatever the final product is. So that is something which we need to keep in mind when we are talking about these new technologies of healthcare. And of course, we do have certain guidelines when we are talking about these accretions, especially in terms of AI. And there are something which WHO has laid out recently which say that AI to be really implementable in healthcare should be transparent, explainability, trustworthy, should have ethics and privacy. We very well know that AI, especially with the ML models, are many times a black box. It's very difficult to explain to ourselves, leave aside to our patients. Of course, there's a huge role of these bodies, and these bodies are the one which have to evolve continuously to develop models or develop standards so that the patients who are exposed to these newer emerging technologies are safe. So that's a fundamental thing. Within our own country, we are moving towards a more legislated environment where the DPDP Act and very recently the rules have been enacted, and it remains to be seen how they get enforced to the extent that we can then look at how we should handle healthcare data and how sensitively and how we should build in consent managers and so on. And this is something which we need to keep in mind. So I have chosen 5 emerging healthcare models, and we've been talking about some of these models, and I'll just talk about a slide each on this model, the pros, the cons, and that's about it. So let's start off with the first model, which I think there might be other emerging healthcare models as well, which might come out. So let's talk about personalized medicine. And in personal medicine, what we are referring to is using genetic sort of targeting our medicines to the extent that they cause less side effects. So there are a lot of huge advantages when it comes to patient safety. Now remember, these pros and cons are not medical pros and cons. These are patient safety pros and cons. So in terms of patient safety in precision medicine, we are actually increasing diagnostic accuracy. We are making the right diagnosis much more faster, much more precise. We are having much more effective treatments, thereby reducing the side effects. So to that extent, it's actually helping in patient safety. There's an improved patient engagement. If you're dealing with this genetic material and all, they tend to be a bit more involved, and compliance as well. But we need to just know these cons and not get worried about them, but we need to know that with new technologies, new challenges emerge. And in this case, we are looking at, it's a complex and poorly understood field, precision medicine as of date. What about the misuse of genetic data? I give a data to a particular person to find out about a particular targeted therapy, but there's a potential for misuse. In fact, there's a very interesting term which has come up when we are talking. I was reading about this topic, and that was about genetic discrimination. That will this eventually also lead to a bit of genetic discrimination? Cost and accessibility are more of ethical issues rather than patient safety issues, but they definitely do play a role. And definitely for patient safety concerns, we need to just mention them. The next example is using robots in healthcare. Again, something which is getting more and more popular. And the pros are the amount of precision. I know in ENT there are certain areas which I can't access with my hands. Even curved instruments and endoscopes make it difficult for me to operate on the base of tongue, but my robo can. And sitting can do this. It reduces the risk of infection. Again, I'm just talking about patient safety issues. It increases my efficiency because I can do more. I get tired less. My robot takes over certain procedure steps. The patient morbidity is better. There's improved medication management. And when I talk about that, it's not surgical robot, even administration of medicines. The cons are, what about technical malfunction? If there's a technical malfunction, the patient is at risk. There's an algorithmic bias. And this is something which will happen in more and more digitally enabled healthcare modalities about this bias. Cybersecurity risks, a lack of human interaction, and as was being said earlier today in the morning as well, that the human touch is so important and should remain and always remains. But again, in one of the very recent, in fact, around an hour back, we heard the CEO of Microsoft say that even empathy is something which AI will do probably better. So that's something which you need to just keep in mind. Patient autonomy, privacy, and cost and accessibility are again something which place patients slightly at risk and have patient safety concerns when it comes to using robots. We need to know this so that we have safeguards for this. This is the burning topic. A lot has been said since the morning. It was quite, even I am learning as I hear many things. But what's important is that yes, using data, we can have a better diagnostic accuracy, personalized treatment plans, faster. predictive analysis, we can predict who's more at risk, less at risk, and of course the clinical decision support systems which have really changed the way we practice medicine and reduced drug reactions and errors. But again, there's an algorithmic bias, and in the morning keynote there was again an example of this particular bias which was being discussed, because data in, data out, garbage in, garbage out. There's a lack of transparency, because many times these AI models, it's very difficult to even really know what exactly is going on in that black box. What if AI goes wrong? That's another thing which we need to look at, think about. Next emerging technology we talk about is remote healthcare. Similarly, what's more important is that though it helps a lot, because the patient is at home, the chances of hospital-acquired infections are less. The patient is safe. There's a better monitoring, follow-up, and the patient engagement is much more. But there are a lot of problems as well. One of them, which is unique here, is delay in seeking care. Does it cause the patient to suffer because the patient seeks care a bit later? Something which what we need to see. Similar or very parallel to this is the hospital at home concept. So what I'll do is I'll just talk about 3 case studies. I don't want to give answers. I just want to show you 3 stories which are very likely, and they do happen, will happen if they're not already happening. Gentleman operated for tympanoplasty. He is counseled by an ENT surgeon, including a self-care and a virtual follow-up by a virtual AI agent called Jasmine. Now, these virtual AI agents are already available on the net, Hippocratic AI. So, these virtual agents can counsel your patients. They are generative AI agents, which are video-based and supported by NVIDIA now. So, this is something. Suppose this is a scenario, and the virtual post-op interaction goes off pretty well. He develops a cold, and he comes back. And during the follow-up visit, he is told that this cold has caused, because upper respiratory tract infection during post-ear surgery is a very, very serious problem. And of course, now whom do we blame? So he blames the virtual agent for the bad outcome and files a complaint. I'm just giving you certain cases, some situations, just a couple more. Mr. Jain is diagnosed with a rare kidney tumor. He's advised a genetic panel to decide which chemotherapy drug will work best. He does that. He responds very well. What happens? The insurance company also has access to this genetic report. They refuse to renew his policy, and unless he pays for an increased premium, because the genetic report also shows that he's got a predisposition to a clotting disorder. What do we do? Are we placing the patient at risk at this place? So we need to have our safeguards and standards to look at these issues. The last one is again a person who's staying at home alone, and he's got a chronic heart failure. This is a new model of care which we often will do. The treating telehealth clinic calls him and monitors him and says, okay, this is a continuous glucose monitor, and there is a change in his glucose. They send him across from the telepharmacy a particular dosage which is pre-made and send it to him. And what happens? He applies that, he loads it onto his insulin pump, which is again automated, and soon after he suffers a fall and he's shown to have hypoglycemia. He's luckily attended and he's saved. There's no major harm done, but then the doctor realizes the wrong dosage had been loaded by Mr. Kapoor erroneously. So these particular 3 examples should make us think that emerging technologies are leading us to emerging challenges when it comes to patient safety. And our standards are the ones which need to really look at addressing these particular things. And I'm so glad that many standards, including NABH, has recently evolved and got their digital health standards as well. Errors will occur. Technology has a propensity to address them, reduce them, control them. But definitely, as was said in the morning for the chairman JCI, when he read, health is imperfect. And that's so true. Before I just wind out, one story, or this is a picture, if anyone can recognize, called An Unrestrained Demon. This is a picture or a painting which is made in the late 1889. It's there in 1889 in a magazine called Judge. And what you are seeing is that people are dying on the road, and people are running away afraid. There's a horse carriage with the horse is dead. And what's happening, and what are they trying to say? That when electricity will come into our lives, we will get ruined. This is what is being conveyed in this painting. And this painting says that electricity is going to really change the way we live forever. Having said that, we wouldn't be having this conference today had we did not got electricity. So technology, like anything else.
Brigadier, your time.
Yeah, we're done, sir. Yeah, this is the last one, sir. So we have to face the future when we come to emerging challenges. We need to, first of all, very important to understand, measure the problems, monitor them, manage them, manipulate, and then only we can master them. And that's the key of what accreditation does. I'm finished, sir. Any questions, comments you would want now or later? I leave it to you. Fair enough. Thank you so much, sir.
Thank you so much. Fantastic. So now I think if you see the earlier version of the accreditation standards, they only used to talk about patients' rights and patient responsibilities. They never thought of that patients can also play the role in patient safety. Now this is recently now we have started talking about the patient's role. And in India, I think I only know one of the NGO which has established itself, Patient for Patient Safety, is working on this very topic. So I invite Som Mittalji to tell us what is the Patient for Patient Safety doing in India and how our friends can help in that. Thank you. Yeah, well, our time is limited to 8 minutes. Thank you.
Good afternoon. I hope you can all hear me. So thank you for this opportunity to address this gathering here. I'm the only one among the 5 here who doesn't have a doctor in front. I'm a patient, and thank you for giving a patient the space to speak today. What I'm going to be talking about at this forum is really about what patients can do. And by the way, as I'm not sure how many of you are actually healthcare providers, raise of hands, are all of you from healthcare? There are a large number, but there's another one that you all are. You all are caregivers and hopefully not patients. And if you are caregivers, it's the same difference between a patient and caregiver. You also have a role. So please listen to what I have to say as a caregiver as well. We have the father of accreditation in India, Dr. Gyani here. He mentioned about having started it in 2006. I think they've made great progress over this part. It's extremely important. And as he said, it's a framework to provide quality, standardized processes, bringing in discipline, repeatability. And who's the beneficiary of all this? It's not the hospitals, it's us. It's us patients that it is all aimed at. We are the beneficiaries on this. But I would say, Dr. Gyani, 19 years, and you spoke about US being in 1951. 19 years is not a very long time, but I still think it's a long time because we're talking about patient safety. And I think there is a need to accelerate this process of accreditation in India. I don't know the statistics because data is not available, but I understand that there are more than 45,000 hospitals with over 50 beds, and I believe that there are less than 5% hospitals that are accredited. If it's only 5%, that doesn't make the universe. You make a big difference, you become the role model. But if every other hospital did not become, because I might land up in a tertiary hospital after I've been through a primary and a secondary one. And if harm has already been done, it doesn't become the responsibility of an accredited hospital to take care of me. So I think there is a need for rapidly doing this. A recent survey done by QCI, which also had been chaired by Dr. Gyani here, did a survey on how do patients decide on a hospital. Lo and behold, there was doctor recommendation, there was issues of word of mouth, family, but the word accreditation did not appear. So, if you remember in COVID time, the government had mandated that if you have an RT-PCR report, it should be from an NABL certified lab. But history is gone. People have forgotten that. into a hospital, the discipline, the processes have changed. But the other part is patient experience. And that is where we feel there is. We have Neelamji here, and this is a slide that we borrowed from all the data that you presented, and we questioned it. How can 1 in 10 people in hospitalization suffer? But then we harm, and then we started probing more and more, and I think we found it wasn't just about India, it was international. So that means that in spite of all the effort that's being done, sincere effort, good work done, there is still harm happening. So that's what prodded us. We created this foundation. Tahoe promoted us, saying, why don't you take care of the patient side of it and see what they're going to do? And I think that's what the movement is. So our only movement is not to tell healthcare providers what to do, but to tell patients about what they can do about safe health. And that's what I'm going to share with you all today. We mapped the journey of the patients all through, because this harm is too large. And we found that in spite of all the improvement, the gaps were there. Now, when we looked at the harm, and look at this slide, I'd like you to spend some time on this. That we're talking about, every suggestion or tip we're talking about is actionable. It's not motherhood statements. So, for example, these posters, preparation before visiting a doctor. Doctor has 7 minutes, clinical examination, look at your past records, ask questions, write a prescription. Hey, wait a minute. Am I prepared when I go to a doctor? Can you help me? Now, these are posters. We talk about accreditation. And I mentioned nobody knows accreditation. In fact, when we send out messages about this poster in the middle, a lot of our friends asked us, the people that we write to, saying, thank you so much for sending this. How do I find an accredited hospital? We said, this is a good question. So we went to the websites of accrediting bodies, and lo and behold, what? Long list of accredited hospitals. How do I find one in Noida, another one in Greater Kailash, or in Bomsundara in Bangalore? I can't. If today on my phone, as I step out, I can find a barista or a Starbucks, can't I find an accredited hospital? So I think there is need to change the way we are doing. By the way, all these charts that we send every week, similar information goes to 13 lakh individuals, and we just started a year and a half back. So it's a journey that's early, but I think we will make an impact on the patients that are there. I would again again urge the accrediting bodies that while they're doing a great job with the hospital, I think the eventual customer of yours is a patient. So I think the patient centricity should come in. I know that in the NABH 6, which is being worked out, again, the word patient is being used, but I think we need more. We talked about rights and responsibilities. We actually went, Nadra, my colleague, is here, we all went to some of the hospitals and said, where is the rights chart? NABH has a chart on rights, and we looked around, we found it difficult to find. Some cases we found it illegible, right? And if that is the case, but we can, we have to find ways of doing it. But more important than the letter of the accreditation is the spirit of it, conveying it, and I think you mentioned about the rights as well. But I think we have also responsibilities that we have to talk about. Right? So there are many, many areas that patients can help, and like I mentioned, which is an IPD as well. These posters, we spoke about falls. We have now developed posters in 16 languages so that people understand. Please give them these posters, put them up. By the way, in all hospitals, we have these video screens which are showing news in a silent. All the news today is depressing. Can you show posters or educational material to them? Doesn't cost you money anyway. We have many more posters like this about people going home. Adults need vaccination, keeping medicine safe, preventing falls at home. The simple tips people don't know. I know about how many friends of mine, after seeing the poster, have put grab bars in the toilets now. So in our foundation, we are trying to do, I think we're trying to move people from disease centricity to patient centricity. And I would say this is the mindset of the patients when they come in. They are depressed. I think if you can work with them, their expectations are very, very little. And I think we are offering to you a partnership of patients, not about complaints. Yes, you might have some complaints coming here and there, but at the end of it, thank you for serving us, but make us a partner in this journey. Thank you so much.
Thank you so much. So I think you can see the passion in Mr. Mittal, how he is representing the patients in our country. Thank you so much. So now we bring our expert, Dr. Neelam Dhingra. The name is Indian, but she is truly a global person, so actively engaged in WHO and now representing oldest accreditation body, JCI. Over to Dr. Neelam.
Good afternoon, and thank you very much for giving this opportunity for me to share the vision and the initiatives of the Joint Commission International. And I've been told I have only 6 minutes, so I'll see what I can do in terms of presenting to you what I have to say. And I would also like to express my deep gratitude and admiration, and also deeply inspired by the International Patient Safety Conference is going from strength to strength. I've attended 3 of them, first 2 as a WHO staff and this one from JCI, and I truly believe that it is really making a difference and spearheading a patient safety movement in countries, in India and also around India and other countries as well. I want to present on creating pathways for patient safety improvement, impact and excellence. While we are in the session of accreditation, the catalyst, it's very important to note for us that healthcare accreditation acts as a vital quality assurance mechanism for evaluating healthcare organizations against established standards, as we all recognize. Aims to improve patient safety and quality of care delivery for better health outcomes and also to move towards zero patient harm in healthcare. Healthcare accreditation demonstrates a commitment to continuous learning and improvement, to rigorous assessment by external reviewers, and promotes clinical excellence as well as enhanced satisfaction among service providers. So thereby, it actually enhances public trust in the healthcare institution. Joint Commission International and the Joint Commission Enterprise, the unparalleled global leader in setting standards for last more than 70 years. And with the gold seal, which is given to organizations who commit to rigorous standards and maintain policies and practices based on these standards. And we have more than 23,000 organizations and programs which we collaborate with, and in more than 70 countries. So in its transformation journey, the Joint Commission and the Joint Commission International is developing a further vision, which is a truly global vision based on the principles of universal access as well as equity. That is, all people across the world always experience safest, high quality, and the best value healthcare across all settings. So this is for organizations across the world. And over the years, I would say in the last 7 to 8 years, there's been a major global patient safety movement, which started with the Global Ministerial Summits from 2016 and has been building on to this political commitment and support from many countries around the world and healthcare leaders, which actually has led to a landmark resolution at the World Health Assembly, with global action on patient safety as the center point, establishing World Patient Safety Day, and also developing a global patient safety action plan towards eliminating avoidable harm in healthcare, first of its kind. And the first ever Global Patient Safety Report 2024 was released last year, which actually shows that although there are improvements in patient safety, significant gaps remain in implementation of the action plan. So, despite the decades of advancements in patient safety, significant gaps still remain in safety and quality, particularly public sector hospitals and healthcare, and particularly in developing countries. So healthcare organizations and countries actually are facing major challenges and also competing priorities. So patient safety is still seen as a priority rather than a fundamental human right. So it is actually put into that situation where the healthcare leaders and political leaders have to choose between patient safety and other priorities. So when it's going through that challenge of competing priorities, they are not able to invest in safety and quality of healthcare services. WHO efforts also, and working with JCI, we have actually reached out to many countries around the world so that we could improve healthcare services and the quality and safety of healthcare services. And taking forward the WHO's global vision on patient safety and the transformation vision of the Joint Commission, the JCI is launching a new initiative, Pathways Initiative. Patient Safety Pathways Initiative focuses on addressing patient safety needs of healthcare organizations, and by prioritizing their needs, also looking into where the gaps are so that we can create pathways for stepwise incremental improvements, which could also be leading to transformative changes. And in these efforts of healthcare organizations and countries, JCI will recognize the efforts of these organizations that achieve various patient safety and quality goals and milestones along their journey of improvement. Objective of the JCI Patient Safety Pathways Initiative is to take forward the vision by supporting capability building and development of patient safety and quality programs, particularly in the public sector, hospitals and healthcare system in low and middle income countries across the world. And this we are going to achieve in working in close cooperation and collaboration with national and subnational governments, of health and healthcare organizations, and international and national entities and patient organizations. So this slide shows us the strategic goals, how we are going to address the patient safety pathways through JCI, through leadership and convening, advocacy at high level and communication, fostering networks, and also creating collaborative mechanisms, developing resources, and cooperating with countries for improvement and resource mobilization, as well as generating evidence and measuring patient safety. The initiative of Pathways is aligning with the Global Patient Safety Action Plan as well as the JCI hospital standards. Some of the key lessons learned from the implementation of the Global Patient Safety Action Plan are going to be guiding us in the designing of the pathways, particularly looking at national commitment, leadership, safety, culture, local context, capacity building, and learning from adverse events, integrating patient safety initiatives to universal health coverage, and technological innovations and digital health and and several other lessons which have been learned. So just want to show that there are three key approaches which JCI is going to implement to take forward pathways through patient safety grand rounds, that is for engaging thought leaders, training of trainers to develop a cadre of trainers across countries, and also technical support to countries through customized and tailored technical support based on the needs assessment. And the important part of the technical support would have some prerequisite at the country level. Particularly, we would have a tool which we are developing which will be adapted to country needs for assessment of needs, and identify interested countries who are committed to patient safety quality, identify interested organizations, engage leadership and seek their ownership and commitment, establish mechanisms of formal collaboration as well as recognition. And once we have those prerequisites meeting the ground, then we actually lead to a pathway of improvement leading to impact and excellence. So conduct needs assessment and gap analysis, develop an action plan, mobilize resources, support implementation, monitor, evaluate, and reassess, and to show improvement, and also provide JCI recognition to these organizations. So a couple of takeaways from this brief presentation is the JCI Pathways is aimed at building capability and developing patient safety quality programs for creating safer healthcare systems worldwide. The Pathways initiative aligns with the WHO Global Patient Safety Action Plan and the JCI standards and incorporates the learnings from its implementation and JCI's leading global efforts for patient safety improvement, impact, and excellence, and working to realize its vision. And in conclusion, I would like to quote a Czech writer and novelist, Franz Kafka, which is paths are made by walking. So let us commit ourselves to creating these paths which will lead to patient safety improvement, impact, and excellence. Thank you very much indeed.
Thank you very much, Dr. Neelam, for bringing the international perspective. Thank you very much. So now we bring Dr. Rohini Sridhar from our own Apollo. And let me mention here that she has been part of the quality journey in India right from inception when we launched NABH. And of course, Apollo is a group which has got equal number of JCI accredited hospitals as well as NABH. Over to Dr. Rohini.
Thank you, Dr. Gyani. So I've been told I have just 5 minutes, and so I'll try to make it as brief as I can. I must say that we have a fantastic panel here, from a practicing clinician to an advocate of patients taking responsibility for their own health, to an international advocate for patient safety, and above all, our own father of accreditation in India, whom we all know. So I don't know if this is the right time for me to talk about reimagining accreditation. I just want to ask one question. How many people in this room have actually belonged to an accredited organization? The vast majority. And I'm sure all of you remember the day you got your first certificate, accreditation. It was a moment of great joy and probably a milestone in all of our careers. And that's the way we look at accreditation, as a trophy to be achieved at the end of a long and difficult path. So I would like to put to you today that we should look at accreditation as the first step in the quality journey. And my position has been made easier by all the things that were presented today. You heard Dr. Rakesh talk about new healthcare models. Please stop and think if our accreditation standards today cover those situations or scenarios. We had Mr. Som Mittal talk about how patients should be engaged and partners in care. Please stop and think if our accreditation today, our standards today, adequately cover or measure patient engagement. And let's look at what needs to be done for patient safety. And we will know that though we have climbed a mountain and we think we have reached the top, we still have a long way to go. So just one study, if I may be permitted to present it here, and this is an association between patient outcomes and accreditation in US hospitals. It's an observational study and we don't have time to go through it in detail. But what the study says is there is no perfect correlation between extraordinary or excellent patient outcomes and accreditation. So quality remains a goalpost that we may never achieve despite accreditation, and that is the mindset we need to take into our quality journeys, and that's the point that I wanted to make. So I'll skip this. So three ways that I think accreditation will change. One is context, the second is content, and the third is methodology. What do I mean by content? Now, all of us who've been through the accreditation journey think of accreditation as a compliance checklist, where you have a checklist, right? You can't do accreditation without checklists. The more accredited an organization, the more checklists. And the better the checklist, the better is your compliance. So we need to move this goalpost from compliance to a given standard to continuous quality improvement. And that is what accreditation will come to be in the future as more and more organizations get accredited. You have done the compliance stuff. I would say you have done the easy stuff. Now the battle begins, where you have to demonstrate that you will have excellent or extraordinary clinical outcomes. And here, you need to get to be organization specific. Organization specific means the context in which the organization is located, the country in which the organization is located, and in that country, the city in which the organization is located. It needs to be organization specific, and as we get forward and we get more dynamic standards, you will realize that they are organization specific. They look at you as you are, and they will suggest to you where you can be. So now accreditation becomes collaborative, because it helps the organization to go from where it is, that is Everest Base Camp, to the top of the mountain. So that's context. Content, I think I will not spend much time on, because much of it has been covered. We did talk about patient centricity, and I think Mr. Som was asking for a diagram or a picture which had the patient in the center, so I have that patient in the center of the diagram. And we all say we are patient-centric. But do we measure this patient centricity? So there are many components of patient centricity: personalized care, shared decision making, effective communication. But do we truly engage the patients? And do we truly measure the degree to which the patient is engaged? And here I have just one point to make. Particularly in the Indian context, we often think that the patient cannot be a partner in care, because so much of what we do as doctors, patients simply don't understand. We operate with that mindset, and therefore it's important that we look at metrics which tell us that the patient has understood what you said and has participated in what you're doing. So I'll have to skip this. Again, will our whatever standards that we use, will it allow us to be a sustainable partner? We know that the carbon emissions emanating from healthcare are almost 6% of the world's carbon emissions. And so the standards of the future will focus on sustainability, will focus on workplace safety and wellness. And last of all, the methodology will change. So it will not be a 5-day JCI audit or a 3-day NABH audit. It will be a combination of digital and online data. As we said, it is more organization specific. The spectrum or the span that the standards covers will go beyond what is happening in the hospital, because you're putting a well patient at the center of what you do, will extend out into the community, and therefore will focus on real life outcomes that matter to the people. Thank you.
Thank you so much. I think we started the session 10 minutes late, but we are still able to finish before 4. I think that is credit goes to my 4 panelists here. I think we have maybe 4 minutes left. So maybe 1 or 2 questions you can take to any of the panelists. Yes, please. Any observation? Not observation, question. Or is it fine that we close this session? Yeah, you have got it.
I can, as a patient, still have a little word. Yeah, I think, Rohini, what you mentioned was very important. And I think, I come from a corporate world, and one of the measures we had this was Net Promoter Score, right? I think it's a wrong measurement. It's a good measurement at one point, but it's a tick-based. I think we need real feedback. I'm a person. Ask me how I feel. And all of us know it pinches, because we've all been to hospitals and so on. Those minor things. I remember when my mother was getting discharged and I was running around to get her insurance claim and so on. There was a dietitian who came, the nurse who came, and they were giving us instructions after instructions. Neither she nor somebody else who had accompanied me could absorb all of it. But this can be actually handed over in a document form. I will not make... So these errors that you do a great job in the hospital, but do I make it happen at home? Not that you didn't tell me. So as far as accreditation is concerned, you did your job. Consent, I myself do not get briefed of the hundreds of consents that I sign. Though it says there I was briefed. So I think, don't worry about patients becoming aggressive. They are only one or two. Whatever you do, they will be. But 99% of us will not.
Thank you so much. I can only sum it up by saying that running a hospital today in India particularly is much more, rather the most difficult job, difficult than even running a space center. And I think accreditation is the only one which is making it a little simpler. So I think with that note, we close the session with thanking to my all panelists. Thank you very much. Oh, yeah, please.
Peter Drucker, global marketing guru, used to say, if it is not measured, you cannot control it. I think we need to dive deep into this metric of patient centricity in terms of seeing that how exactly the soft skills which are going for the patient caring, patient administration, all that, till the time it is not quantified from the so-called, it has to be quantified, in terms of coming out with the outcomes.
Yeah. So as I said, that it is a model on governance for quality governance accreditation. And I think we are moving very slowly in that very direction. And what Mr. Mittal brought, the concept of patient bringing into the center stage, is very much happening. And a time should come that patient should be driving the accreditation in our country. I think with that note, we close the session. Thank you very much.
May I please request the speakers to come forward for a photograph? That was a very insightful and thought-provoking session. We just had a huge thank you to our prominent speakers. A big round of applause to them. Thank you so much, speakers. Right, we would like to take a small moment of time to thank our partners. We have DOSI, our title partner, Pfizer and Fujifilm as our platinum partners. And of course, with the gold partner, we have 3M and BD India.
It's time now to play bingo again. I would request everybody to take their bingo cards out. We will be announcing few words again as we did last time. And please strike off those words on your bingo cards. Everybody, please take your bingo cards out. If you all are ready, so Lakshna, can we announce the words?
Right. The first word is infection control. The first word is infection control. Second word is cyber security. Second word is cyber security. And third is patient safety. I repeat the words again. It's infection control, cyber security, and patient safety. Right, I hope you must have struck out those words in case if you find them. And with that, we are moving forward with the next session, Leading Strategy with Impact, Driving Excellence in Healthcare. In an ever-evolving healthcare landscape, leaders must not only respond to challenges, but anticipate them. Leveraging technologies, patient-centered approaches, and operational efficiencies to create sustainable, high-quality healthcare systems. We come together now to discuss one of the most critical aspects of modern healthcare, that is strategic leadership of health excellence, which highlights the vital role in visionary leadership, which is data-driven, decision-making, and innovative strategies in shaping the future of healthcare. To set the stage for discussion, I'm honored to invite our illustrious moderators. We have two session chairs. First chair, Dr. Vijay Agarwal, President, Consortium of Accredited Healthcare Organization, CAHO. May we welcome you, sir. A big round of applause for him. Dr. Agarwal leads a consortium of accredited healthcare organizations dedicated to upholding the highest standards of quality, safety, and patient-centered care. His visionary leadership and tireless advocacy for patient safety have earned him widespread recognition and respect within the healthcare community. Welcome, sir. And the second chair, we do have Dr. Shishta Nadu Basu, Gynecology Infertility Specialist, Max Hospital, Delhi. May I please request you to join the stage? Dr. Shishta. Welcome, ma'am. That can be a stronger applaud for her. Right, thank you. Dr. S.N. Basu, with has 3 decades of experience, including more than a decade teaching in UK hospitals. She held prominent roles like Vice President of the Indian Fertility Society and Chairperson of the Department of Obstetrics, Gynecology and Infertility at Jaipur Golden Hospital. She is recognized with awards such as the International Woman of the Year by the Biographical Society, Cambridge, UK, and the Hamilton Bailey Prize.
May I also request the speakers to join our worthy session chairs. Our first speaker for the session is Dr. James I. Malino, Executive Vice President and Chief Innovative Officer, the Joint Commission. May I request you to join the stage, sir? Dr. James I. Malino, if you are available here, please join us here on the podium. Meanwhile, I'll take the second speaker's name. May I invite Mr. Prabdeep Singh, Founder and CEO, Red Health. May I please request you to join the stage, sir? Mr. Prabdeep Singh, if you are available here in this hall. Mr. Prabdeep Singh. We move to the third speaker, Dr. Parag Rindani, CEO, Wokat Hospital. If you're here around, please join us here on the stage. Dr. Parag Rindani. We have Dr. Parag Rindani. I welcome you, sir, on the stage. Dr. Parag is an experienced and a strong professional, skilled in hospital operations, medical administration, financial management, and quality and accreditation. Highly innovative in cost optimization and performance improvement initiatives. With this, I'll call my fourth and the last speaker for this session, Dr. Vishnu Panigre. If you're here, sir, please join us here on the stage. Dr. Vishnu, Group Head, Medical Strategy and Operations, Fortis Healthcare. Okay, so we do not have 3 speakers here today with us. With this, I hand over the forum to you, sir, to both the session chairs. I would please request you to take the session forward. Thank you.
Good afternoon, and I, along with my co-chair, Dr. Basu, I welcome you all to this session and also thank the organizers for giving us this opportunity to talk about this very, very important part. In fact, the last session, and in fact, if you have heard the closing remarks of Dr. Gyani, said that running a hospital is more complex than even running a space station. And also he said that probably accreditation is the key to run them very efficiently. Now I agree with the first part, where I can say that hospitals today of any size, be it a small, medium or large, I think they undergo tremendous challenges. Now those challenges, whether they are on account of financial sustainability or on account of manpower shortage or on account of overwork over-regulation or by the exceeding expectations of the patients. There are huge challenges. How do they survive with dignity and with ethics? But the larger issue is regarding the topic for which this entire conference is there, and that is of patient safety. And that's where the accreditation has been the backbone for the last many years, for last almost 20 years in our country, and I would say for last more than 80 years in a country like United States. But the question to be asked is that even after 80 years of existence of accreditation in United States, deaths due to preventable medical errors continue to be the third leading cause of death in that country. Why is it so? And I have a feeling that institutions have found the strategy to achieve accreditation. But there is no strategy to make patient harm as the primary aim to be monitored. And that's where is our major issue, even for the accreditation bodies. Getting the number of hospitals are being monitored. But ultimately, the reason for which the accreditation bodies came into existence was to eliminate or remove medical errors. Friends, unless or until we are going to keep an issue of also in mind that it is the good practices that we have to start focusing on not merely pass the exam. So again, as a strategy of the people in the hospitals, they find it very easy, just like what we used to find even during our exams, that there is a strategy to pass the exam. So there is a strategy to get the stamp of accreditation. But unless or until we will focus on good practices, best practices, then no matter whether it is NAB will come and evaluate me, or ACI will come and evaluate me, or QAI will come and evaluate me, I think the method of evaluation should be secondary. But that's an issue of, again, the strategy. What is it that we wish to achieve to fulfill the role? Because otherwise, I feel that this issue of patient safety, we are going to continue to talk about it. It is not possible for the quality managers in the hospitals to start implementing quality. Quality has to be practiced by cardiology, Department of Cardiology, by the orthopedics in the Department of Orthopedics. It's not merely by the administrators and by the quality managers. So I think to this very important issue, I would say that strategy, as we understand, is the smart way of trying to reach and achieve your goal. And how probably people can survive in this complex kind of an environment, make our hospitals, I say, sustain with dignity. And I feel that our speaker So, to start this session, with the permission of my co-chair, Dr. Basu, do you want to say anything at this moment, or maybe you would like to conclude? So let's call Dr. James Merlino, who is the Executive Vice President and Chief Innovation Officer of the Joint Commission. So Dr. Merlino, please, for your talk.
Good afternoon, and thank you very much for the honor of representing Joint Commission International at this illustrious conference to talk about safety. And I'd like to congratulate the Apollo Group and the Reddy family for putting on such an amazing gathering to bring people together for the common purpose of being healthcare delivery for the people that we serve. I want to start with a story about patient safety, and it occurred a long time ago when I was just beginning my career as a doctor, and I was helping to take care of a patient. And I had just left for the evening, and the patient was doing fine. and I go home and I get a call from one of my colleagues to tell me that the patient had just arrested and died in the hospital. And it was the middle of the night, and I drove back to the hospital, and for those of us that are in healthcare, you know what the scene of a code blue looks like. There's lots of nurses, there's a lot of messy things on the floor because of the crash cart, patient's body, patient's family. It was a very surreal moment for me. And it was also an incredible learning experience for me because the patient that I was helping to take care of that died that night was my father. And why was it a learning event for me is because I'd never been on the other side of healthcare before. I'd never been seriously ill. I had not had a family member that was seriously ill. But my father had been diagnosed with bladder cancer, and he came to the hospital for an ambulatory procedure where he would have a biopsy, go home the same day. And what happened was he suffered a serious preventable safety event, which caused him to stay in the hospital for 8 days. And at the end of 8 days, he had another preventable event that ultimately took his life, and he died. And that day taught me a lot about healthcare, particularly as a young surgeon just starting out in practice. But the most important lesson that I learned from that is that at the end of the day, healthcare is a complicated enterprise, and we're all in this together. And we're not just in this together because of the fact that we are healthcare professionals, but we are in this together because ourselves and our families are impacted by the care that we deliver just as much as the people that we serve. It's one of the few industries in the world where we are not only providing professional services to patients, but ourselves and our families are patients as well. And you all heard Dr. Sassadar this morning give the example of his personal serious safety event where he was taking care of a patient in the ICU that needed a chest tube. And the surgical team came and put the chest tube in the wrong patient because they had switched rooms. And 2 patients died that day, the one that needed the chest tube that didn't get it, and the one that got the chest tube that didn't need it. And these 2 cases, from a personal standpoint, represent the challenge that we have to improve safety across the world. And if you recognize where we are in healthcare today, and it is really incredible where we've come and the progress that we've made. I remember practicing as a resident many years ago, and the difficulty of treating advanced cancers, and today we have amazing treatments for advanced cancer. We have amazing treatments for other diseases. And we've made some progress on improving safety, but we still have a long way to go. In the United States alone, on average, there will be 3.2 million people affected by a serious safety event. Nearly 400,000 will die, and before COVID, it was the 3rd leading cause of death. Now, those numbers are controversial. Some people say they're less, some people say they're more. We probably don't know exactly what the numbers are, but the reality is it doesn't matter what they are, that they're still occurring. And that's our challenge, is to drive towards zero harm, where we're not harming people by accidents. Healthcare is a dangerous business, and if you ask anyone in healthcare, physicians or nurses, they'll tell you that it's dangerous. And every time their family members are treated in healthcare, they're always worried and they're always concerned. But if you ask patients, and surveys done in the United States have shown this, 80-90% of people will tell you they feel that patient care is safe. And there's this dichotomy between what we know to be true and what patients believe. And if you consider the fact that our responsibility is to take care of people in the most difficult time of their life, when they're coming to us because they need us, when they're coming to us because they're vulnerable, they're coming to us because they're sick, they're afraid, in some kinds terrified, the risk to them from healthcare is very serious, and we have a responsibility to protect them. But what do we do when we have a serious safety event? We study it, we do a root cause, we learn from it, Most of the time, we cascade that information. A lot of the times, events happen, as I said, we don't know, don't study them, we don't share information. So as you think about the future and where we are today in technology, particularly with the promise of new technologies like artificial intelligence and other things that can help us learn, that can help us prevent errors, do we really believe that those will be the solutions to improving safety? I would submit to you that they will help, certainly. But I think the evidence on what we know about AI as it's an emerging field tells us that it also brings risk. One of the biggest risks of AI clinical models is bias. We won't know unless we're thoughtful about auditing and monitoring if we're treating patients with an algorithm that's biased, that's incorrect. We could potentially treat hundreds of patients with an algorithm that's AI-driven before you knew that it was an error and there was a problem causing patient safety and misdiagnosis. So we have the promise of technology, but we also recognize that technology alone brings with it its own challenges and opportunities to improve safety. So people will say, what do we do? How do we think differently? How do we advance the conversation about improving safety? Some people will say, well, it's like the airlines. We should be more like the airlines. If we could just be as safe as the airlines are. As a surgeon, I can tell you personally that I always rejected that notion. I think taking care of people, complicated diseases, is very different than flying airplanes. And I think for those of you that take care of people, you would recognize the same, that it's not the same. Can we learn from other industries? Can we make ourselves better with some process engineering? Probably true. But the reality is that if we're truly going to move the bar on safety and work harder to drive towards zero harm, there's probably a couple elemental things that we need to do better. Number one, we need to make sure that we're collecting data. We need to foster the environment where people are not afraid to report errors. But it's not just errors, and you heard Dr. Sassadar talk this morning too about not just reacting to information, but being proactive to learn from information that doesn't yet touch the patient and cause an error. And these are called precursor events. So we need to collect more data on events that touch patients. We need to start collecting better data on events that happen that don't yet touch a patient, but yet we can learn from them to redesign things, to fix things, so that we can prevent errors from touching patients. We need to make sure that we're reporting them to our colleagues so that people understand what we're learning, not just in terms of root cause information, but in terms of the buckets of information around precursor events. And as Mark Harrison talked about this morning, we need to provide leadership. If we as leaders in healthcare organizations are not talking about safety as a top priority, then the people that we lead will not embrace it and believe that it's a top priority. We have to recognize that our responsibility as caregivers, that our responsibility to deliver care rests with first delivering safe care, delivering the highest quality care in an environment where we're delivering compassionate, equitable care. But it always starts with safety. And as leaders, we have to message that, and we have to message it consistently. We also have to recognize that there is no one fix to safety, that it's a complicated system dealing with incredible variability of patients, and that there's a variety of things that we have to address when we're improving safety around process, behaviors, technology, the structure of how we're organized, and how our leaders are leading and talking about it. The promise of technology and AI will help us to advance the work that we need to do. No question about it. It will bring challenges. We will overcome those challenges, and it will make us better. But at the end of the day, we have to lead this issue. and talk about it. We have to collect good data. We have to learn to go from reactive to proactive. And we have to recognize that there's a variety of things that we can impact to improve the delivery of safe care. Thank you very much again for the honor of participating today, and congratulations to the organizers for a successful conference.
Thank you very much, Dr. Marino, for your talk. And since this is the last session of the day, we won't be wasting a lot of time in that. We would like to have Dr. Parag Rindani, who's the Group CEO of Wockhardt Hospitals. And I've heard a lot of praise about him, so over to Dr. Parag Rindani.
A very good afternoon, ladies and gentlemen. Thank you very much, chairpersons, for the warm invitation. The topic which we have before us is definitely one of strategic intent, empowering all and pioneering inclusive and value-driven healthcare systems. Ladies and gentlemen, when I went to B school way back in 2005, I was the father of 2 kids, and I was studying evening school, and frankly, B school can be quite boring if you're not really tuned into business. And one of the things that we learned on day one was this whole concept of a triple bottom line. And the concept was that the strategy has to be the triple bottom line, which means that you're supposed to focus on people, you're supposed to focus on your planet, on our planet, and then the third bottom line is what is called profit. So the 3 P's. We subsequently went on to study a lot of other alphabet, 5 M's and 6 Q's and whatnot. B school is very confusing. The word B itself is not very great. But one of the things that we learned definitely is that you are supposed to focus on people in any business that we do. And we happen to be in the business of providing healthcare. Therefore, for us, the concept of value becomes very, very important, especially since whether we like it or not, we may like to be called whatever, but we are still a developing country in its best possible form. So how do we really pioneer inclusive and value-driven healthcare? Let me tell you about Sakshi, and this may not have been Sakshi, it could have been Salma, it could have been Shireen, it could have been Sarabjit, it could have been anybody. Sakshi was a one-year-old girl whom I happened to meet in the city of Nasik. Nasik, as you know, ladies and gentlemen, is one of the Char Dhams. It has Trambakeshwar and all of that. So I happened to meet this girl when we were doing a street play to promote the concept of pediatric cardiac surgery and pediatric cardiology. Now, the reason I remembered this girl is that we had this photograph of Sakshi in our archives. We were trying to get the concept of pediatric cardiology alive in the community so that people would bring their patients to us and we would be able to operate on them. Please try and understand that 50% of the money was coming from the government of Maharashtra. Another 40% was coming from Rotary International from a global grant, specially sanctioned to us under the Arch Clump members. There was a specific fund which was given to us, and the patient had to pay 10%, which was 20,000 rupees. You will not believe what Sakshi's parents told me. We got talking in Marathi, and Sakshi's parents said, we cannot get 20,000 rupees. We'd rather let Sakshi go. It's cheaper to produce another child. This, ladies and gentlemen, today is the value of life attached to some of the healthcare processes that we follow. Healthcare today, even under the so-called Pradhan Mantri Jan Arogya Yojana, the Ayushman Bharat scheme, is not available all the time. It's sometimes not accessible to the right beneficiaries, and then you have the people in BMWs with Mercedes and BMWs coming in, they've got diamonds on their hands, and then they are availing of the Pradhan Mantri Jan Arogya Yojana scheme. But the message that Sakshi has to drive home is not about building more corporate healthcare. The message that Sakshi is driving is that we need to make healthcare accessible. The strategy around healthcare has to not forget the triple P's. People, planet, profit. It has to be patient-centric, as Mr. Som said. It has to be planet-centric. It has to be sustainable. And yes, there will have to be a profit because we'll have to work and build newer processes and systems. So the big question is, how do we empower all the stakeholders to lead a sustainable and equitable healthcare system? We need to definitely empower people. be it nurses, be it doctors, be it administrators, be it patients. When we look at this, we've got to look at the following healthcare disparities. Today in our country, we not only do have socioeconomic and geographic disparities, people who live in the hills will not have access to the level of healthcare that a person in a city may have, village versus this thing. Often we speak about India versus Bharat. India is the corporatized so-called urban areas where you get healthcare. Bharat is still the place where you don't even get a paracetamol easily. Disability, gender, caste, community, religion, these are all barriers that we know exist. You may have a so-called quote-unquote ex-religion hospital run by ex-religious people or Y religion, and that's a problem. While we are getting trumped, quote-unquote, on DEI, I think our country needs to go a long way before we can claim to be DEI compatible or that much inclusive. When we talk about this gendered, this social economic disparities getting removed, Ayushman Bharat comes to mind because it is definitely helping tons of people who were earlier not getting healthcare. In Tamil Nadu, the Chief Minister's scheme, in Maharashtra, the Chief Minister's scheme, these are schemes that have helped a lot of people. One thing that we've realized that is excluding people from the ambit of healthcare definitely leads to worse outcomes and higher cost. And remember, in a country which is still developing, we need to have cost-effective, sustainable solutions. Therefore, we need to think out of the box. Our research needs to tell us whither we need to go. Value-based healthcare. When we talk about value, we don't have to talk about only what the patient is paying, but what about the other value, the social value, the loss of income, the loss of days that the patient has to stay in the hospital. What about improving our quality so that healthcare-associated infection doesn't take away the sole caregiver in the family? So better patient outcomes per unit cost is what is value. If we are able to send a patient without the gift of a fall or a healthcare-associated infection in a safer, more well-knit environment, a healthcare environment, I think we've done what we needed to do. So if I look at Narayana, for example, they've got this beautiful model of low-cost, high-end cardiac surgery, which has helped. It reduces readmissions, it improves adherence, there is a connect with the community. We ourselves within our government system have got this concept of Asha Didi, the antenatal care that is provided, the amount of institutional deliveries has also gone up. So we need to be focusing on these things also. Unfortunately, we, quote-unquote, in the private corporate world don't really know what the government is doing. We need to use technology, telemedicine. We just had a session time back on the use of artificial intelligence. Why can't we have Indian data? Why do we have to depend on the Centers for Disease Control and Prevention to tell us that there is a new virus? I think the country of the scale of India can definitely develop a CDC. What does it require? A few thousand square feet, a few gazillion dollars to put that up? We can do it. And I'm sure corporate India will rise to the occasion. Given the fact that 2% of all profitability is supposed to be spent on corporate social responsibility, I think healthcare strategy should dictate that we move in that direction. Empowering our patients. Mr. Mittal spoke about it some time back. We've been receiving, I'm one of those 13 lakh beneficiaries who receives that Patients for Patient Safety Foundation newsletter. Shared decision making, involving people. At some stage, we'll have to start telling people about the errors that we make. It's no good just reporting it on the incident reporting form and waiting for that third year or fourth year when Joint Commissioner on NABH comes. At some stage, we'll have to take our patients into confidence. Digital accessibility. We need to get our patients on mobile health apps. We need to get more wearables into the community. These have to be made more affordable, and this all falls in line with Mr. Modi's strategy of Make in India. Arvind Eye Care, they reverse engineered their entire program around cataract surgery to then now have in-house cataract lenses made. That is the sort of innovation that our country needs. That is the sort of strategy that we need to do. And finally, providers. We definitely need to train people in cross-cultural competencies. India can become the focus of medical tourism across the country because we have cheaper labor, we have cheaper medications, we have lesser costs attributed to potential healthcare litigation, and therefore we are in a very, very well-placed position to get medical tourism in. We also have certain models in India which can be replicated across the world. I know for a fact that SAARC countries are now picking up on some of our healthcare models. So as a strategy towards value-driven inclusive healthcare, we need to evolve these strategies further. For policymakers, already I think the ABHA and the National Digital Health Mission, these are huge initiatives. The e-Sanjeevani scheme, these are huge initiatives which are going to help us propel into a value-based inclusive healthcare delivery model. So the call to action has to be that we need to be more inclusive. We need to take care of the third gender. I think there are still hospitals that don't have it officially in their drop-down boxes when it comes to choice of gender. We need to shy away from getting into caste restrictions. We need to shy away from doctors saying, I will not touch so-and-so patient. Believe me, it happens in Bharat even today. How can we do it? We need to advocate. We need to implement. I think corporate hospitals, government hospitals, we have a lot of role to play to get traction from each other. There's a lot of learning one from the other. The government hospitals have the volume, corporate hospitals have the infrastructure. So why not share and grow together? And it's important, finally, ladies and gentlemen, for all stakeholders to unite. So Mahatma Gandhi had said, the true measure of any society can be found in how it treats its most vulnerable members. So if we truly are supposed to get into an inclusive, value-based healthcare system, ladies and gentlemen, today is the time to grow and act. Thank you very much, ladies and gentlemen, for your attention.
Thank you, Parag, for this wonderful talk. And if you must be wondering why did I move from there to there, that was my strategy to be able to listen to him carefully. So every time, every moment, you have to adopt some strategy to make your life better. I'll now request my friend, Dr. Vishnu Panigrahi, whom I have known for many, many years. He was with us as a cardiac anesthetist. Now he's the group head of operations and strategy and medical affairs and I think everything at Fortis Healthcare. I won't take much time in introducing him, otherwise I will spend time on that only. Over to you, Dr. Vishnu, please.
Hi, good afternoon, everyone. First of all, my apologies for coming late. I was in the other hall. And I'd like to thank Apollo for giving us the opportunity on behalf of Fortis Healthcare to thank them. And I started my corporate journey at Fortis from at Indraprastha Apollo way back in December 95. So a lot of the things that the governance part which we picked up have emanated from there, and then we have grown. And what I'd like to just mention is that if you look at the governance, it is a whole-reaching part that comes in, whether it's the process of decision-making and the process by which the decisions have to be implemented. So this is the whole framework of the governance that we are talking about. But our core area that we are talking about today is on the healthy governance. Like we are talking about the Vikshit Bharat coming up, how do we have a healthy workforce going forward? But the healthcare sector needs to have the healthy governance. So to keep that in mind, we have to have the processes, the structures in place. So all these, what have been highlighted, are whether the organization structure and accountability, that is important. It has to be a transparent decision making has to be there. We have to be responsive. Nothing is a one-way street. Unless we are interacting, hearing each other, and acting on it, we will be failing in the governance. And it has to be inclusive, equitable and inclusive, where all the members feel that they are part of it. No one feels that it is a one-way street coming from the top and we have to adhere to that. And the rule must be applicable for everyone, irrespective of senior, junior. So the rule of law is important, and very important part is the participatory part, which has to be there. And always try to imbibe a consensus-oriented approach. Because if you listen, there are a lot of things that come up. And you can keep on improving. Like I always say that I'm not perfect. But if I have the intent to see that I can correct myself and go up further, that is the way. So if this is there, that is the way the governance becomes structured and much more robust. So in healthcare, we look at the clinical governance is that encompasses everything. because healthcare governance is about seeing that we provide a safe environment to the doctors and nurses who are the front line taking care of the patient. So how do we do that? So for that, all the ecosystems that need to be put in place, the processes that need to be placed, have to be inbuilt, and you have to keep on working on them, monitoring that, and going forward. So these are the things that we look at it in any hospital that is there, whether it's the risk that is involved, the effectiveness of the clinical care. Are we open to information technology, which we, Parag and myself, we have in a session an hour or two back. This is important because data is now is the new money that is there on the table. That is the way we improve. And the AI that we are talking about, all this will come from there. And research and development. Why should we keep on looking at the Western world for getting new ideas? 1.4 billion population, whether it is the private sector, public sector. This is something that we should look at. And education and training, these are the things that we start looking at it and taking it forward. So these are the benefits which will come in from if you have a proper ecosystem, the processes in place of having, how do you benefit from the clinical governance is that you see that evidence-based medicine is practiced. So this is at every hospital level, this has to be sort of looked at. What are the best practices that are in place? Have a system and process improvements be open to it. And a process-based approach is most important. If you have a personality-driven approach, it is bound to fail. The personality is here today, he or she is there, tomorrow he or she is not there. Then things fall apart. So always see that the processes take precedence over the personality. If this is there, you are in the right space as far as clinical governance and healthy governance is concerned. And obviously, patient safety is the paramount thing that we are looking at. And cost is important, is that we have to be frugal without cutting down on patient safety. So look at what you are spending on. If that can be done at a lower cost, do it, but not at the expense of quality. So this is something that every clinician is aware of it. So that's the reason I'm saying is that the governance metrics should be taking feedback from the clinical team, the doctors and nurses, before they take a decision on cost. That's why I said that all the healthcare workers are the doctors and nurses. And one very important thing that I want to put across is that sometimes we say that we have adequate staff, the doctors or the nurses. But it's always important, do we have the right person at the right place? So this is where hiring is very important. So every hospital ecosystem, they must be looking at the credentialing, whether he or she has the right qualifications, to see that the privileging is intact, whatever privileges he or she is supposed to do, they confine themselves to that. So these are the oversights that you have at the hospital level. One important thing I would like to say that NABH, the National Accreditation Board of Healthcare, this is something that India has benefited immensely. Parag very nicely he joked that, I'll not mention the other part of it, but in 10 years, the way NABH has gone forward, it is huge. It has helped the healthcare system immensely. In fact, I was the examinee when one of the first hospitals got the NABH in 2006. Dr. Vijay Agrawal was my facility director. I was giving the presentation to the NABH assessors. So I've seen how the NABH has. So if you follow all the NABH processes, I think so in the right governance framework that needs to be there. Training and upskilling, this is something that we keep talking about. I think so we don't walk the talk. We talk the talk. I think the walk the talk is important. Whether you are training internally or you use external resources. There are various organizations, like for example, CAHO is there. CAHO, they are doing a lot of quality upskilling activities, whether it is on-site or online. So please avail that. So there's a lot of things there in the ecosystem which we need to look at. The clinical outcomes, again, is something that we have to keep looking at it. So because the value is equal to the outcomes divided by the cost. So if we keep focusing on that, that is where good governance comes into play, equipments and instruments to support the medical programs. You must know what medical programs are there, how do you support them. So it's not necessary that every medical equipment has to be the costliest. So based on the medical programs, you can configure the equipments, the instruments that need to be put in place. As they say, good medicine translates into, I'll not say good revenue, but good patient experience. I want to set the cat amongst the pigeons here. Is that this is something, a concern. I've lived 10 years as a lecturer in the medical college, last 30 years in the corporate world, working in all the 3 major corporates. But this is a concern is of the PE funds coming in. And that is where clinical governance may get a hit. So my humble request to everyone is that please be focused on what is the quality that we are delivering. Because otherwise what will happen, the main talk that will be happening is what is the top line, what is the bottom line, what is the EBITDA. Then a lot of things which impact quality at the shop floor level of the doctors, nurses taking care of the patients may get impacted. So I think so my humble request to everyone is that keep this focus in mind, because if we have to have a healthy governance, I think so we need to be very focused on seeing that our doctors and nurses have the right framework, right infrastructure, right ecosystem to function. Thank you.
So, we'll talk, Dr. Vishnu. Any questions, first of all? I must say that all the 3 talks have been very, very lucid, very clear-cut to illustrate how can we make our healthcare inclusive, affordable, and meaningful, effective, efficient. I can just add 2 minutes on what even Dr. Paningrai talked about. Let me say that, again, CAHO as a body which I represent, I bring you greetings from CAHO. And the idea was that how do we complement accreditation bodies? The accreditation bodies have done a tremendous job in sensitizing hospitals and everybody around the kind of a grammar, you can say. It's like a Bible that around which you can develop patient safety programs. However, our workforce, the entire workforce, whether it is clinicians or let's say people who are in the engineering services in the hospital, pharmacists, rehab specialists, dietitians, they don't get involved directly into this entire accreditation process, and they don't understand what is the problem or what are we talking about. So that's where, first of all, what CAHO started to think was that accreditation bodies have an army of people whom they call as assessors. But hospitals, where are the people whom we can call as quality implementers? And that's where we said that let's try to develop a pool of people whom we will call as quality implementers, and they should be present in every hospital. You should not be depending upon a particular consultant who will come and help your CEO and your quality manager to get you the stamp of accreditation. And that's where the disruption started to happen. And I say that just like any hospital which achieves accreditation, he must realize that is the beginning of his quality journey, not the end of his quality journey. Same way, anybody whom we certify as a quality professional is a beginning of his becoming a quality professional. He starts evolving himself as a quality professional. Nobody can make you a quality implementer in 3 days, 4 days, even in a 40 days time. You cannot be, that's not an end, this is a journey. And it is towards that. So it's like a strategy we had to start thinking. We started pulling up the resources of the entire country. We have great experts. For example, Parag is lying in Mumbai, Dr. Vishnu is there in Delhi, XYZ in Bangalore. We started roping in all these people to start talking and communicating to the rest of the country and the world. Today, we are being recognized not only within the country, we had requests from countries like Nepal, Sri Lanka, now it's in Abu Dhabi, Africa, and we are opening up this kind of a CAHO model to bring hospitals together, pool your resources, and start elevating your journey of quality and start implementing quality standards. I'll say again, this has been a strategy. The strategy was to say, how do I impact patient safety? So we have time just now, and I'll also request my co-chair, Dr. Basu, who is leading, I would say, an international body for communications. And I can tell you, communication is another one area where, of course, Kaho is also kind of very, very focused, but she's doing a tremendous amount of work in that field. Dr. Basu, you will please say, and any questions for the time being for any of our panelists or any one of us here? We still have some 5-7 minutes. Dr. Basu, you'd like to say something?
So see, what I said was I'm setting the cat among the pigeons in the sense that we keep reading about P funds coming in. See, because P funds, when they come in, they have a horizon, time horizon of, leave it to that. So where they make and then go out. But that should not impact, that's why I mentioned that as a word of caution, that the doctors and nurses must be properly provided for with, see that they are able to provide good care, quality, patient safety is the paramount. So keeping that in mind, so if that is there, we will not focus. If you want to be dictated by them, then we may lose the plot, and that is where the trust deficit will increase again. The COVID was a great example where the trust deficit between the public and especially the private healthcare, or in general, the healthcare in general, came down substantially. So this is could be a game changer. So that's why I'm saying I'm not a sort of fortune teller or anything, but it is something that you all need to take cognizance of. Wherever you all are working, keep this in mind, that healthy governance is important, and for the healthy governance, it is the doctors and nurses who have to be provided for the adequate care. And I gave the example of NABH. The NABH standards are fantastic. If you follow that, you are doing all the clinical governance, healthy governance that is there. Upskilling is there. You do the upskilling in the hospital. Internally, externally, you have a team like CAHO teams who can come in. The others are there. So that is what I was telling. I'm not against P funds. I just wanted to put a word of caution there.
I'd just like to add something here. I think the measurement of success in only tangible numbers is great. But when that value is only rupees, I think that's no longer acceptable. I think one must understand that excellence in governance, excellence in clinical results is also something that needs to be valued at some level. How we do it is something that PE funds and healthcare institutions need to jointly evolve. There has to be a grading matrix. If you're going to say that you get 30% profitability at, let's say, 35% mortality, and if that's acceptable, I think that's very bad mathematics. So I think we'll have to learn to get the clinical metrics as well as the financial metrics wedded to each other. Just to add, sir.
Thank you. Any more questions? Or any comments or anything from anyone? It has been a very interesting session, and with all the inputs and the ideas that have been put forward, we have the leaders of healthcare here, and to all of you all are doing a wonderful job, and all the people who are involved in whatever way you are involved in healthcare, whether it is as a leadership or whether it is, as the healthcare professionals, etc. I bring you greetings from Max Hospital and from the Society for Communication in Healthcare and the International Society for Communication in Healthcare, of which I am the chair of the advisory board now. So what we look at is two main things. I started talking about communication and quality way back, I think when I came back from the UK in '92. And the first talk I gave, I can never get over that. The moment I started talking about communication and there should be quality, most of the people walked out of it. auditorium. Because they say, what is this to talk about? And I'm so glad that we have come a long way where we have an international conference which is discussing this. Patient safety should be the cornerstone of all our healthcare facilities and healthcare in general. And amongst all those things, what you find, it's not only in healthcare, but in every aspect of your life. It's communication, which is the cornerstone and the basis of how any service is delivered. And at the same time, another background to it would be a feeling of empathy. So empathy and communication, which is right from the top leadership to the last man standing, that is when we think we will have a healthcare where we'll be able to satisfy, reduce the mistrust between the patients and the healthcare professionals. In fact, we held our first national conference, of which I know Dr. Vijay Agrawal has been a great, wonderful partner in all this endeavor, that we had a first conference, national conference on communication in healthcare, and the tagline was bridging the gap between healthcare professionals and the society. Because unless we get this trust deficit going, so whatever services we may offer, why are the quacks doing well? I'm not propagating or condoning what they are doing. But the only thing is they show so much of empathy. I know we had a person, a doctor, no names mentioned, who was very, very popular with his patients, albeit that many people questioned he was an allopathic doctor, modern medicine. Many people did question about, the type of treatment that he gave. But you see, what he had in plenty was empathy. If something went wrong with the patient before the relatives or anybody else could feel sorry, he was the first one to hug them and, give them all the consolation, etc. So the patients would turn around telling him, "Koi baat nahi, doctor sahab, aapne to bahut mehnat ki. Ab kya kare? Hamari jitni kismat thi utni hi hoti hai." So I think empathy, communication, starting from the top leadership, because they are the ones who are going to drive this. And that will lead to patient safety and the quality. Because you see, communication is what? A thought. Starts with a thought. Then you bring it into actions, and there are very processes involved. Then you have the processes. So the thought, the processes, the implementation, and the communication of all these systems that we generate are paramount, bringing about a healthcare system which only concentrates on patient safety and deliverance of good health care. And I think our speakers, they were all talking about those same things, and I think so, the quality, etc., must be a very important point. We really appreciate what all of you are doing. Thank you very much. Sometimes, people think, people are only considered about profitability. No, but I have worked in close quarters in the corporate, and I do find that there is an empathy, but they have to marry, find a balance somewhere. Thank you all very much. Thank you very much. Thank you.
May I request everybody to be there at the center of the stage for the photograph? A heartfelt thank you to our incredible speakers, session chairs, and all of you, our participants, to your commitment to healthcare excellence. Let's take these insights forward and continue to lead with purpose. As we wrap this discussion, one thing is clear: leadership in healthcare is not just about managing systems, it's about transforming them. Now again, it's time for the third session of announcing the bingo awards. I request everybody to take out their bingo cards as we announce few of the bingo words which are planned for this session. If everybody is ready with the bingo cards, I would request Sulakshna to please announce the words.
So the bingo words for this time is diagnostic safety. The first word is diagnostic safety. And second word is medical devices. Second word is medical devices. And the third is data analytics. So 3 words of this time is diagnostic safety, medical devices, and data analytics. Before we move on to the next session, we have a small short spotlight where we have Ognito ambient listening, where we would request Ms. Virushka Patel, leading global partnership and client solution Ognito, to please speak few words. Welcome, please. You would be.
Virushka Patel, please, over to you.
PowerPoint on. Good evening, everyone. My name is Virushka Patel, and I'm the Director of Client Solutions at Ognito. Ognito is one of the world's leading and most advanced voice AI solutions that is revolutionizing clinical documentation. With over 20 years of expertise in medical transcription, Ognito harnesses cutting-edge technologies such as natural language understanding, natural language processing, as well as AI to really transform how healthcare professionals are documenting. We are proud to be deployed at more than 500 enterprises across the country, including the likes of Apollo, Max, and Medanta.
Hi, Harjeet. So tell me, what brings you in today?
Hi, doctor. So I've been suffering from a really bad cold from last couple of days.
Okay. Do you have a cough as well? Can you tell me if you have a cough? Is it a dry cough? Is there any phlegm?
Yeah, there's a persistent cough with, mucus production and phlegm production.
अच्छा, और बुखार भी है या सिर्फ सर्दी खांसी?
बुखार आया था, 101 के आसपास फीवर था. I've been taking paracetamol to manage the fever.
Okay, and I know you do have asthma, so is the cough impacted by that or is it under control?
No, that's pretty much under control.
Okay, and tell me, Harjeet, have you been exposed to anyone sick? Have you been traveling?
Not really. I think probably it's more so of the pollution out here.
Yes, yeah, I know there's a lot of, pollution, bad air quality, so I've been getting a lot of patients, but, let's check you out, let's get a better look. So, it does look like your tonsils are inflamed and there's some mucus also in your lymph nodes, but your breathing seems clear, so I'm actually suspecting that this might be tonsillitis. So, what I'm going to do is, I'm going to order a CBC test for you, that should help us confirm. In the meantime, I'm also going to prescribe some medication for you. So take amoxicillin 250 milligrams twice a day for 7 days. You can also continue to take your paracetamol, whenever you have fever. And then, I'm recommending you do some saltwater gargles, drink hot liquids like teas and soups, and then also do some steam inhalation, maybe 2 to 3 times a day. That should help you.
Sure. And doctor, just to mention, I do have allergies from dust and pollen also.
Okay, so that's good to note. I don't think that should impact this right now based on what I'm seeing, but we'll take that into consideration as well. And then once you have your blood test results, come back and see me.
Sounds good, doctor. Thank you.
Okay, so now you can see that I've gone ahead and saved the recording and it has been submitted for processing. So the recording can take up to 30 seconds to process. So whether it's a 9 or 90-minute consultation, we ensure that you get the note within 20 to 30 seconds. Further, Ognito's USP also really lies in its flexibility to adapt to your workflow requirements. So we can also customize note output, fields, and templates as per your organization, documentation workflows, your use cases, or your EMR requirements. What you will shortly see is simply our default template. So I'm going to go back. You can see that the note is now ready for me, so I'm going to go ahead and open it. Alright, so you can see that it has accurately captured the details across all the fields discussed in the conversation, such as the chief complaints, the history of present illness as well. It has also captured the allergies we discussed, including the past medical history. Since we did not discuss anything on the social history or family history, that is blank. But further, I do want to call out that Ognito has taken into context the conversation and suggested a diagnosis for us here. It has also correctly captured the medication and orders from the visit, as you can see. Further, Ognito also does have advanced capabilities for code retrievals. So, for billing and coding purposes, we can actually ingest your custom organization databases for things such as allergies, ICD-10 codes for diagnosis, custom drug formularies and services databases as well. And then we can actually suggest coded values that you can see here, how we've actually suggested various closely matched options as from our default database. Further, the clinician can also go ahead and make any edits as they like. They can either type it out or they can even use a microphone here to dictate the same. Once they are ready, they can simply pull up their EMR and just with one click, effortlessly transfer all this information back into their EMR, as you can see here. Furthermore, you also do have the option to generate things such as a patient note as well as a referral note. So I'm going to go ahead and generate a patient note now. Here you can see how we have a patient-facing note that has been generated that the doctor can easily just download and print out for the patient. Further, we also can generate this in many different languages.
Oh, I hope this gave you a quick idea of how Ognito Omni is transforming healthcare documentation for thousands of clinicians worldwide. If you would like to know more, please come by and see us right after. Thank you so much for your time and have a great evening.
Thank you so much, the Ognito team. Right, moving on. Furthermore, we have the next session, that is Next Generation Patient-Centered Care. Next Generation Patient-Centered Care is more than just a concept, it's a movement that shifts healthcare from being provider-driven to patient-empowered, for reactive to proactive and personalized. That is exactly what our next discussion will explore onto. The future of healthcare is not just about treating illness. It's about predicting, it's about preventing and personalizing care for better health outcomes. To help us navigate this exciting evolution and lead the discussion, I'm honored to invite our moderators on the stage. We have the first moderator, Dr. Narottam Puri, Principal Advisor, Quality Council of India. May I please request you to join the stage, sir? Dr. Puri currently serves on the governing body of NABH and as an independent director on the board of Manipal Cigna Health Insurance Co. He is also the advisor for medical operations and chairman of the Fortis Medical Council. Dr. Puri is a co-founder of the Center for Design and Innovation. Welcome you, sir, onto the stage.
With this, I welcome the second session chair for this particular session, Dr. Preetham Kabinahitlu, Joint Director, Clinical Administration, Apollo Hospitals, BG Road. May I please request you to join the stage, sir? Dr. Preetham completed his MBBS, MBA in Health Management and Post-Graduation Diploma in Medico-Legal Systems. He played a key role in getting NABH and JCI accreditation in first attempt in a hospital. He also worked on the Greenfield project planning and commissioning of the 500-bedded hospital. May I now request our distinguished speakers for the session to also join the stage with our session chairs. The first speaker for the session, Mr. Sriram Iyer, Chief Executive Officer, Apollo Health Lifestyle Limited. May I please request you to join the stage, Mr. Sriram Iyer, CEO, Apollo Health Lifestyles Limited. Okay, we'll wait for him to join and we'll move to the next speaker, Ms. Louise Kaskili, Executive Director, ACH International and Consulting. May I please request you to join the stage, ma'am? Thank you. Ms. Louise consults to leaders around the world on healthcare quality and improvement, supporting organizations to achieve high performance through measurable improvement in quality patient outcomes, professional accountability, and safety cultures. I welcome you to the stage, ma'am.
We have been joined with Mr. Anand Surana, Director, CEO, and Founder of ICEGEN. May I please request you to join the stage, please, sir? Mr. Anand Surana is a dynamic entrepreneur and a driving force behind ICEGEN Computing Inc., a company at the forefront of leveraging cutting-edge technology to enhance patient safety and healthcare outcomes. And we also have the last speaker joining them is Mr. Mayank Ratela, Chief Human Resource Officer, Apollo Hospitals. Welcome you, sir. Mr. Ratela leads high-performing teams and cross-functional projects to drive business strategies, heading strategic HR function for India's largest healthcare organization. He has an international experience of heading HR in European emerging markets and Middle East. Welcome you all to the stage, sir. We request the session chair to please proceed the session.
Dr. Narottam Puri and Dr. Preetham Kabinahitlu, over to you, please.
Good afternoon, ladies and gentlemen. First of all, thanks for the organizing committee to invite me to chair this session. And I'd like to begin by saying that this is not the first time I've been a part of the International Patient Safety Conference organized by you. And I'd just like to start off by saying that at the fag end of the day, nobody is really interested in prolongation of the chair speaking and then the speaker speaking. It's best that the chair stays in the chair and the speaker speaks. So between me and Dr. Preetham, we've decided that I'll speak the least, he'll sum up, and we'll leave most of the talking to the three of you. Ladies and gentlemen, we keep talking of the future, but the future is here. From the 1950s, when Kurt Lewin first proposed the theory of change and transformation, it has been with us right throughout. And every generation needs to bring about change. So what's new? So what are we talking about? Were patients not there earlier? What is it that has changed so dramatically that we keep needing to talk about it? The fact is that healthcare is a science that changes roughly around every 5 years. This is faster than what atomic energy changes occur. Therefore, you need to keep on reinventing. The trouble is that people who create the problem also have to be the problem solvers. This is both good and bad. So from the perspective of transformation is required because of, I think, the technological leap. It's not necessarily that technology has improved only in healthcare. Healthcare has always benefited from technology which has been invented somewhere else. Let's take, for example, lasers. Laser was not invented for medical use. Or, for example, ultrasonics or echocardiography. This actually came up from the space program because Baylor Institute and NASA had to collaborate to find out how to measure the cardiac function of the astronauts in space. Who benefited? The healthcare and therefore the patient. So I think transformation requires a multidimensional approach which has been forthcoming from time to time. COVID changed a lot of it. Who would have imagined that the mRNA vaccine would come, and those of us, people like me who are 60 years plus in the medical profession, they know that the changes that occur every decade are really something that you never read about in your textbooks. Therefore, the need to meet and talk about these transformations. So our first speaker is not here. So lifestyle. Okay, right in time. So yeah, so from the perspective of change and transformation, what I have been saying, Sriram, is that it's something that has happened over eons and will continue to happen. But it's always going to remain relevant. From the perspective of what's going on today, which needs to be discussed, one is, of course, the talk about patient-centric care. Second is the use of advanced technology, which we hadn't talked about for decades because it wasn't there. For example, machine learning, AI, and design thinking. And the third is the using of wearable device. Many of you are probably wearing one. Then is the outcome-based models of payment. Everybody talks about value-based. Well, value is provided by outcome. What does the patient want ultimately after his visit to the hospital? He wants to get well. That's value for him. But value-based outcomes, we tend to be very much affected by what the United States does because they do the maximum amount of research. But for example, in India, one of the things that we face and that needs to be discussed is the death, I would say, of the family physician in the metros. Where are they? They used to be the link between people like us who were consultants in their respective fields and people who were delivering care of a specialized kind because we were niche providers. But the patient was being seen not as a whole, but purely as a whole, not W-H-O-L-E, but H-O-L-E. We were seeing the eye, the pupil, the ear, the heart valve. So from the perspective of future generations, is that a good thing? I don't think we have anybody on the panel who's going to talk about it. Perhaps that's something that's food for thought for the years to come. Last but not the least, I would say the role of preventive and predictive healthcare. So some of these will become important as we go along, but let me not stand between you, or rather sit between you and the speakers. And may I invite the first speaker, Mr. Sriram, to deliver his thoughts on this process.
Sure, sir. Thank you so much, sir, and a pleasure to meet all my colleagues in the panels here. So I have a small presentation. So I think I can stand and present that. It will be easier. So I'm going to be talking about from reactive to proactive, what are the next-gen strategies for transforming patient care. So I can take the podium there? Yeah, okay. So can we have the, there are about 4 to 5 slides, so I'll take about 8 to 10 minutes max. Okay, right. So can we have the first slide? Slide changer, sorry, okay. So what I'm going to be covering on is why is the need for transformation? Yeah. Then what are the next gen strategies for proactive care? How can technology be a catalyst? How can it be more data driven? Of course, that will play a big role of leadership in the transformation. And finally, what is the call to action for us? So quickly I'll run through each of the slides. Right. So obviously there have been, as you can see the slide, I'm not going to be reading out word and word, right? But there are, very serious advancements that are taken in the healthcare space, and we need to prevent it rather than them occurring it, right? That's a big thing, and that is what proactive care all is, right? So what we need to do differently is, why we must do it actually, because of the NCDs being a very big portion, as sir also pointed out right now. And we need to obviously transform our business to really enable early intervention. And even the patient's expectations are, really going up for a personalized care. So so the need to transform is clearly there. Now what are the next gen strategies? So basically these are the 3 pillars that you can see here. I'll use it here. One is on predictive analysis and AI. One is on patient engagement, and second is on integrated and preventive care. Now, there are already in Apollo Hospital today, we are already using a lot of AI-driven models even today, right? And they can have early detection of heart failure. I think we have a cardiovascular score, and this has been done over years. I think there's been data collection on EMR over 15 years, and with a fair amount of accuracy, we can predict an AI cardiovascular score even today. And the machine obviously keeps learning. The cohorts of data is there. Similarly, there's a pre-diabetes AI. So some of these models already exist. We need continuous refinement on these models. And the part very clearly is that proactive care or preventive care is absolutely essential today, right? And of course, 150 million pre-diabetics in India today, expected to cross 200 million by 2030. And then you add cardiac, thyroid, other deficiencies. It is a huge number, upwards of 200 million. Staggering number, and that is going to be the biggest reason for mortality. So it has to be detected at very early in the stage. Now, technology has to be a catalyst for this change. I think we have been hearing about this, right? I read somewhere, a very beautiful, just few days back, right? And it's true for all organizations, and I think even more relevant for healthcare. We always talk about IQ, right? And EQ. And these two are very important. All of us knows what IQ and EQ is, but nobody talks TQ. And I think technology quotient also becomes very important as individuals and organization, how we need to embrace technology and make it the catalyst for the change. And we have to move from a reactive to a proactive approach. I spoke about AI and ML learnings. We have remote monitoring and wearables, right from ultra-human rings to gadgets to watches to sleep cycles. We had one product today, Dozy, right? I mean, it can catch your pulse rate as well. And of course, all of this has to be available to the clinicians to make timely decisions. So all of this, how does it come into your medical records and really get embedded into all your EHRs and really help the decision take right time support, So technology is going to be the catalyst and not the decision maker. Decision maker still is the doctor. It's an enabler and not a driver. And that's why a hybrid model is essential. And I think today in the afternoon session, the minister had also alluded to that how it has to be a hybrid way of AI, and really that will be a win-win model. Second is on data-driven patient-centered care, right? Now we need personalized medicine. Now that is a newer thing that's coming out, especially with respect to genetics. Genetics, DNA-based testing, my gut testing, everything is becoming very, very more personalized and more specialized. And we also need to obviously ensure that monitoring health is a continuous journey and not one time. So we say you have to do your checkups at least twice a year, then there has to be continuous monitoring and see each of those body vitals over a longer period of time with a real health tracking. And patients are partners, so how do we really get them embedded? I mean, everybody keeps track of their wealth goals, travel goals, but health goals is something which we need to educate our patients as well. So the future is into patient-driven, consumer-driven, preventive healthcare, and and really driving the path to wellness, a path to well-being, and becoming more personalized. And whom we must do here is the leadership, right? And as leaders, in our individual capacity, as leadership that drive teams, as leadership that drive transformation, as leadership that drive strategy, we have to invest in AI. We have to invest in innovation. Please support some of these automations. It has to be foster collaboration. So there are multiple departments that need to work together on this. Data flows in, and then, of course, we need to work out a data lake and build some of these, these algorithms. And typically, like in any companies, and even in healthcare, we have to break the silos. Everybody will have to come together to build some of these models. And of course, some of these can be very exciting to do something new. So we have to foster a continuous improvement and show a lot of flexibility and agility as we work towards this. And that's why some of this transformation has to be led by critical decision makers in every organization who can drive this. So that's it. So we have to lead this change. Of course, there's a very powerful statement, lead the change or change will lead you. We have to redefine the patient safety, embrace AI, predictive analytics, empower the patients, personalization, and move to a continuum care of continuous safety and innovation. That's all. That's my point was. And I hope you found this useful. Thanks.
Thank you very much, Mr. Sriramaya. Thank you. May I now request Mr. Louis Kaskeli from ACHS. She's the executive director there. She's talking about the tailoring of accreditation to healthcare needs. That's a very important topic because these days accreditation in India is gaining momentum. We need to hear your views, Don.
Thank you and welcome. Thanks for staying late in the afternoon. So this topic, the future is personal tailoring accreditation to healthcare needs. We'll bring a little bit of the Australian perspective. We're here from Sydney for this conference and thank the organisers for the invitation. I guess the focus that we'll look at today is a little bit about just our background and where we're coming from so you understand our position in the landscape of accreditation. Look at some of the current challenges in healthcare accreditation, the global trends that are impacting accreditation and its future and how it's changing and evolving, as you mentioned, and that need for personalisation. And then I will talk a little bit about the beyond accreditation and our philosophy around quality improvement and some of the future models of health service accreditation. Sorry, I hope you can hear me. Cutting out a bit, I think. So just by background, is that too close? Just by background, Australian Council on Healthcare Standards is a not-for-profit body and we're the largest accreditation provider in Australia. We have our strong foundations, 50 years of clinicians who created our standards, and also we've been accrediting hospitals and healthcare organisations across Australia for over 50 years. We have also moved into the international space where for the last 20 years we've been working across about 25 countries in Asia Pacific and the Middle East, as well as in India. But we have a national standard of health service standards, and I also wanted to highlight that there's a Commonwealth Fund report, Mirror report, that was commissioned in the US, and it rates the top 11 high-income countries across about 70 criteria. And Australia, in the latest report in 2024, came out as number 1 overall for healthcare outcomes, access, administrative efficiency, and general care. So we're very proud of that, and we're pleased to be able to share this internationally, this great healthcare system that we're proud of. But what are some of the challenges that we face with healthcare accreditation? Everyone loves when they have to be accredited, of course, and we're trying to take that away from the healthcare space and not see it as, it's definitely not a one-size-fits-all. We work across, as I said, 25 different countries, very different regions, different maturity levels of quality improvement, and that can be different within groups of hospitals in the same group. So it's important that that's one of the considerations. Obviously, the diverse healthcare needs and settings is requiring a more tailored approach. The evolving patient expectations and also the technological advancements, which we've been talking a lot about today. So what do we say is the process for tailoring assessment and making it more personal to the healthcare organisations that we're working with? Obviously, we're governed by the International Society of Quality Improvement, and I say hello to Dr. Anu in the front row. ISQA does fantastic work internationally to keep organisations like ourselves. We are triple accredited through ISQA, and they introduce principles that govern the standards that we apply. So those principles are consistently changing, and new additions are coming out, which will address AI, environmental sustainability within the next round of principles, which then goes into bodies like our standards. But the way we approach it is we do come from a clinician-driven organisation where we believe it's important to move people through a process of a continuum rather than seeing that everyone may not be in a position to start at accreditation level. So therefore, we adopt a model where those organisations that may only be at the beginning part of the process of policies and procedures can start at that foundation piece. So when it comes to the accreditation process, we do need to see that organisations can produce outcomes and demonstrate those outcomes, and then we can move organisations to that beyond accreditation where they can demonstrate person-centred systems, advanced care. That's our philosophy, and that's been taken up by many organisations as the future of healthcare accreditation. But let's see some of the global trends that are influencing the change in accreditation and innovation in quality improvement assessment. Certainly patient-centred care, hot topic, very critical, and I think it was very interesting to hear that Apollo are addressing it as patients as the partner in care. That's exactly what we're talking about when we come to accredit. Healthcare organisations or assess organisations, the patient being at the design of and central to the care. Obviously, data-driven decision-making is making a big difference in terms of how accreditation's future is going to look. We've got smart technology and AI. We've got to consider that and how that is governed, the privacy around it, and also the regulations that are trying to keep up with the speed of this implementation of technology. We're moving, of course, from this episodic mindset of accreditation and assessment, where you come in to do an assessment and then everyone relaxes and 3 years later the accreditors come in again. That's just not the philosophy that certainly our organisation has ever had, but it just doesn't lead to good outcomes. We want to work towards continuous improvement. In Australia, that we've adopted it's compulsory now for healthcare organisations to do short notice assessment, which is unannounced. So you basically get 48 hours notice that the accreditation, the assessors are coming in. So many of those organisations have done mock assessments to get ready and prepare. That's something that is available to healthcare organisations even internationally, but it's just that one step in the process of moving towards more continuous monitoring. We've also got a lot of new models of care, hospital in the home. We talked about the data that we're monitoring from the home, and telemedicine, tailored approaches to assessments and evaluation, and obviously the other influences are the healthcare workforce and the budget. That's something that is also impacting the decisions around accreditation. The other thing, of course, is aligning quality to value-based care. So if we just take for a minute now, when we're talking about the future is personal, we have had a fair bit of conversation over the course of this conference around person-centred care and what does that mean. I think it's important to see that many organisations are adopting this. When we assess and evaluate healthcare organisations, we are looking at a principles framework, and you can see that this principles framework puts the person at the centre of the care, or the consumer at the centre of the care. And outside that, we look at basically 10 areas to evaluate how the organisation is taking into account the holistic care, the accessibility of care, the team-based approach to care, how personalised the care is, the co-design with the patient or the family, and it also considers the innovation and the consent around innovation. We look, of course, at the governance and leadership and the organisation's culture around patient-centred care. Thank you. As well as measuring reliability of care. It's the organisation's focus on continuous improvement. Are they assessing the patient-related proms and prems, and where is the patient in this decision-making is very important. Are they on some of the committees, boards? What sort of input does the patient have? We've extended from a healthcare accreditation provider, we've extended a service beyond accreditation where organisations can demonstrate a centre of excellence in a particular service specialty, and one of the foundation pieces of this is person-centred care. So we do have that. The other thing is the clinical indicators that those organisations need to put forward indicators to this data set for that particular service specialty. Other things that are happening for the future in accreditation, particularly with data-driven assessments, is in the future we will be not just going in every 3 years to accredit and making regular touch points, we will be looking at real-time data to notice deteriorations and improvements, to be able to be in contact with healthcare organisations more regularly. We're working on at the moment in Australia a multi-million-dollar project with a university and a major healthcare system to get actionable data to support the accreditation process, and provide digital dashboards. As you know, appreciate that's a very challenging. We're a federated state, federated country, with all different state hospitals. So collecting the data is always the challenge. So just to finish, I would like to highlight that the next generation of accreditation will be customised. It will be dynamic and more responsive model of accreditation, flexible and patient-centred, and it will be driven by technology and data analytics. It will certainly be outcome-focused, which is current focus, and it will provide a continuous feedback loop and real-time adjustments, as well as addressing sustainability. Thank you.
Thank you. So we have our next speaker, Mr. Anand Surana, who is Director, CEO and Founder, ICGen, and will be hearing more about value-based care with the digital mastery. So over to you, Dr. Surana.
Thank you very much. I understand we are fag end and we're about to put down a curtain, so I'll be really quick, I promise you, and I'll make sure that our next speaker gets ample more time. So what I'm going to talk about is smart hospitals, which is like we speak about smart hospitals, what they are, and we say that technology is not important, but the value-based technology is important. And what is the digital mastery all about? So I'll be really quick on my presentation, as I said. Sorry. So what I'm going to show you is more of the pictorial presentations. Thank you. It works? So what you're seeing right here is completely a hospital which is wired all through. And what it's talking about is that, as they were talking about the challenges, there are a lot of challenges, but in spite of that, it has to be networked and how we need to work together. So everybody spoke about AI. I'm going to talk about a few important stuff, how ChatGPT, how, we talk about the exam superstar. This is real data which says that, ChatGPT, which is GPT-4, beats 90% of humans in the world's toughest exams, which is pretty impressive. And in spite of all of those, we said, look at this. This data says how smart it, I'm not going to do too much of deep diving because of time constraint, but I'm going to be talking about people question about, will we be losing jobs with AI? Which is like, true or false is what exactly a study says right here. It says that 85 million workers replaced globally by, 2025, which is what World Economic Forum projects. And they also say the healthcare is where the highest number of people lost a job, and they're going to be losing jobs as well. But the flip side of it is that we said that generative AI is likely to influence and reshape, look at that, and not destroy jobs. That is the beauty. Where we said that there were 85 million jobs were gone, but they say this AI is going to create 95 million jobs globally. So the beauty of where we were to where we are right now in terms of evolution of the healthcare industry, if you see, which is healthcare 1.0 to today we are at 5.0. If you really see, we started from where and the journey is transformed, and where we're standing right now is that everything is now human-centered. Though we talk about wearables, which I'm going to show you, we're talking about AI, everything is fine. But what is the key is that we are human-centered, as someone rightly said. It's a patient safety, which is the key. That's exactly what we need today, the patient safety. Now, I'm sure the speaker spoke about how from reactive we went to proactive, and you will see that it used to be where one size fits it all, but then from there we moved to everything is personalized, democratized. And here we're talking about what is it we are facing right now in India is that persistent challenges are always there, which is access to, to the quality care, which is where all of us are working towards, and rising chronic diseases and the aging population in India as well. But what is happening with the definition of value-based care is that we're talking about how do we improve patient experiences? How do we actually reduce the per capita cost of health, of care? And what is it we could do to create the experience for clinicians? Now, data. Data is the key. All of us talk about it. Data is the key, and which is so true. They say once it's given a shape, and once we bring in, they say what you could measure, you could improve. That's data. And how could we actually coordinate this for a better care and better efficiency? And how can we leverage technology and this data together? Look at that. What happened today is that a doctor is replaced so well, and the AI has done this job pretty recently, when we say, if you get on the patient portal, there's a self-triage, and the beauty is that you really see how these wearable devices, doctors sitting remotely, be able to get these information wherever in the world you are. How can you prevent before you intervene? That's exactly what technology helps, as my colleague rightly said, Speaker. Technology is important, and the minister today, what he mentioned was so right. You try and talk about artificial intelligence, but if you're not intelligent enough, you cannot use artificial intelligence. And now, how is it that technology is helping in making decisions to all of these for a better and safer care? This data is beautiful in the way amount of reminders it could give in, the amount of technologies that happened today morning. The ex-CEO of Cleveland Clinic very rightly said that the radiologist made a mistake in life. Someone lost his life, his good friend lost his life. So how technology is actually helping you with these, enhancing your practices. How can you actually reduce your clinical variations? These are real-time data, what I'm showing you from the States. And the beauty of how is this, AI applications are helping you in a big way, right from, getting into healthcare-associated infections to surgical complications, pressures, you name it. And I'll show you some real-time data up here. How could you improve telehealth? And everybody's talking about it, so I will not touch this subject too much. I'll go. The idea of value-based is, I have an outcome which I'm actually going to head up to, saying how can you improve access to it? And these are the futuristic healthcare technologies coming up, right from pharmacy robotic automations, what you're seeing in, look at this is actually in use right now, to chatbots. It's actually replacing a lot of people, humans, and people who actually want to talk. And in the morning, very nicely said that he's putting up in his parliament where he said that he is having a chatbot where he actually is also involving a human and chatbot together, and when the patients come in, the chatbot actually responds well. It's pretty impressive to see where India is heading to. So getting back to it, also I'd like to bring in the NLP, which we're actually using at Apollo hospitals as well, wherein, we help NLP and our AI tools for resource optimization and making sure that there's a lot of resource burnout. We help using AI. And these are few of our realities we're talking about, bringing RTLS, house surgical robots, and mental health is the key. Now, this is something which is quite unique. AI-assisted retinopathy screening, India. Google invested with Shankar Netralaya, and this is quite impressive. When I was sitting right at the conference, when Google actually, Pichimuthu was mentioning about how well, Indian technologists and the doctors together came up with, Google invested millions of dollars to come up with this AI-assisted evaluation. Look at that, how AI is into vascular disease screening as well, and also with the wearable sensors, AI is playing a big role. These are few smart and identification technologies which we've been using daily, right from smart socks to smart alarms to biometric identifications, and the future is digital twin. I'm sure I'm going a little more deep diving, but the idea, the whole crux of the presentation is that PPP model is what we need. How much of a technology you use, whatever sort of, doctors and nurses we have, we need a model which is patient, technology, and doctor, where patient is the focus, is what we need to work on. So we say call to action is simple. It says continued collaborative efforts in the healthcare landscape is important, and we are talking about a very, very good anecdote, which actually was Emma said, coming together is beginning, or staying together is progress, and working together is the success. That's what I have to say. Thank you all.
Thank you, Mr. Surana. So we are moving on to our next speaker, Mr. Mayank Rautela. So we'll be speaking on workforce transformation to enable patient-centered care. Over to you, sir.
Another realization, you should have been 6 inches taller, but yeah, that's how life is. One of the things I learned today is that I think we need AI to manage crowds in conferences going forward, right? Very recently, we celebrated our Founders' Day, our chairman's birthday, 92nd birthday, and in one of the events, we planned for 10,000 people to come with families. About 14,000 came. In another event, we said there's too much crowd, so we said, okay, is it 2,000 people that can be accommodated in the auditorium? So we released 3,000 passes, but only 1,500 came. So maybe we need an AI intervention on how to manage crowds in such conferences. Having said that, I think we've all been attending various sessions through the day, and wherever I go, we've been talking about artificial intelligence, we've been talking about latest technology, robotics. It's great, and that's the future. But my job, and I think the job of many of us in this room, or future jobs, I see some youngsters sitting behind, would be to manage the people who are going to be impacted by this technology, right? Now, Apollo Hospitals is by far the largest employer in the healthcare space in the country. In our hospital division itself, we have about 50,000 employees, which includes 10,000 qualified MBBS and above doctors. If I were to include my other entities within Apollo, we have 120,000 employees. 125,000 employees into 4-5 people, so about 6 lakh lives probably are dependent, are looking forward to their employment in Apollo. How do we transform our workforce yet be at pace with these cutting edge technologies that are coming, but in the end continue to provide high-end care for our patients? That's the challenge that probably in the next 5 minutes I'll share some of my thoughts. And what better way to start by a quote by our dear chairman, Dr. Pratap Reddy. So it's not about treating illness, it's about giving care to the patients, and who gives cares? These 50,000 employees, these 15,000 nurses that we employ. So how do we take care of them? How do we prepare them for the future? You and I in this room probably are slightly more educated than my frontline workforce is. How do I prepare them? How do I ensure their livelihoods are protected as we bring about these changes in the workforce? So that's the challenge we have. And as you know, not just the largest, we are also the oldest healthcare ecosystem in the country. We recently celebrated our 41st anniversary. And because of that, we win various awards at various forums, and one of the awards that we recently won was that we were considered as one of the happy places or happy companies to work for. So from a HR or people management perspective, we are looking at a 3-pronged strategy to manage this transition or transformation that's taking place in the healthcare space. And I would say it's not just healthcare, across industries. These changes are happening, whether it is hospitality, whether it is IT, whether it is manufacturing. Everyone is going to get impacted. So we need to, and we would continue to be a human-centric organization. The core of Apollo Hospitals or any good organization is its people. We will continue to drive technology in our people processes. Right? That's very important because we are getting in a lot of technology for patient care, but what is it that we are doing for our employees? And of course, we are very proud to be a family-owned or family-driven company. A culture of ownership, culture of belongingness is something that we will continue to enhance in our organization. So some of the things that we do, we've recently launched a balanced scorecard format for goal setting of our employees. So almost every employee in the organization at the beginning of the year, we set up goals for them. They know what they need to do during the year and going forward. One of the things that we've recently done, we have redefined the career path for our nurses. And in the last 9 months, we have reduced nursing attrition by about 10%. So I think that's currently, Dr. Puri, I know you were a moderator in one of the sessions I presented a few years back also. And there also I mentioned that the focus remains on taking care of our frontline workers, so that's what we're continuing to do. As you would see in the slides, over 4,000 people were recognized in Apollo hospitals in the last year for completing 10 years and more service. So, we'll need to continuously support them in their growth and their employability. The latest initiative that Chairman Sir has launched is on global workforce mobility. Right? So what we are planning to do is train our junior doctors, train our nurses, and equip them to take on roles internationally, go to the Middle East, go to the UK, work there for 5, 10, 15 years, and they're most welcome to come back and join Apollo when they want to come back to the country. On the human-centric approach, we continue to do a lot of work on leadership and talent development. We have tie-ups with companies like Conferry and ISB to provide leadership development for our mid to senior level employees. Our kindness scores continue to be in the early to mid 80s, and we have continuous focus on training on empowerment, empathy, and so on. We are again one of the first healthcare companies where all our managers have a pay for performance model. All our employees are paid very aggressive retention and statutory bonuses. And we've recently also tied up with a company called Vantage Circle, where all our employee-related reward and recognition programs will be automated, centralized, and people can view them on the click of a button. On the technology side, very quickly, those of you who are interested in the HR technology part, we have the Oracle HRMS platform that runs the entire employee cycle for this 50,000 employees that I talked about, right from induction till compensation and exit. We do a lot of online programs. Most of our statutory programs like POSH training, NABH training are now on our learning management platform and can be done while you are coming to work or while you're at home also you can log in and do. And as AI comes in, we are also training our workforce for cross-skilling. For example, just a quick 30-second example, we are integrating our labs in Chennai. So we have 550 employees who work in these labs. When we integrate, we'll probably need only 300. So what do we do with the balance 250? There is a commitment from the senior leadership. Not a single employee will lose his or her job. We will put them in a learning academy. We'll train them in the next 6 months, and we will redeploy them across our hospitals that are coming up. And in the next 12 months, we are looking at adding 2,000 beds across various locations. So this is how we will retrain and redeploy using technology. And of course, as all of you would know, the unfortunate incident that happened in Calcutta, that triggered us to launch something called the Pink Book. This is the first book which we made in consultation with the Indian Medical Council on safety measures for our women employees in workplace. So that's a very pictorial depiction of what are the things that we need to do in order to keep our workforce safe. We do a lot of training programs. Like I said, we celebrate our Founders Day where more than 120,000 people come together and we rejoice and we celebrate that day. And of course, we have some very, very unique policies for our employees, not to go through the whole list, but being a hospital, we provide almost free care in terms of hospitalization, OPD, diagnostics, and so on. And very recently, we also launched a Mediclaim policy wherein an employee is covered under Mediclaim even after his or her retirement. So that's how we are extending this culture of family within the Apollo ecosystem. So that's it from my end. Thank you very much.
Thank you, Mr. Mayank. See, gone are the days where when my father studied and when I studied, there's hardly a difference when we were in the medical school, maybe some marginal differences. But as Dr. Puri said, the generation is changing every 5 years now. The technology is changing exponentially, especially post-COVID, as you see. There's a transformational changes that are taking place, the changes that is beyond our imagination that are going to come up. So it could be even generation changes maybe in the next 2 to 3 years. Every 2 to 3 years the generational changes might be different. So we need to keep the pace with the technological advances as well as the way the people are moving ahead on other aspects, keeping especially in healthcare, the kindness, the focus on a people in mind. So technology plays a major role. So just to sum it up, we have talked about proactive care with the 3 pillars of patient engagement, then predictive analysis, preventive care, which we all have been talking about. And one of the important things that was talked about, like coordination and continuity and transition of the care, which is most important, and continuity of care plays a major role when it comes to the home care point of view. Patient, it's not just been treated in the hospitals when the patient moves back to the home, and that's another area that's been being focused now, that how we can improvise the home care. Maybe 20% of the patient may be treated outside the hospital with the home care facility for better improvement of their ailments. So we also learned about data-driven care, the collaboration, and how collaboration would help from the various industries in terms of caring to the patients, and what is beyond accreditation. So we all we've been talking about accreditation. So we learned about beyond accreditation, what person-centered and COE, Center of Excellence focused, and international the perspective of how these things can be changed in the next few years that are going to come. So these are some of the things. Then also we have learned about the global trends and innovations, PCS principles, clinical indicators, data-driven assessments. So these are again focusing on outcome-based care, wherein it is not just that we are taking some data and doing something. It is focused on outcome and patient satisfaction. And now that we are moving from patient satisfaction to patient desire, so the satisfaction is not enough, to cater to the needs of the patients. So also, we have learned about patient it's not just destroying the jobs. Actually, the AI, which actually helps in helping giving a job, but in a new perspective, in a new format, and not taking the people's job. So, patient as partners, which is again an important factor which we have learned about, that patient have to be a partner in care. It is not just one-sided from the healthcare providers. So early detection of diseases, PPP model is also played a major role and is going to play a major role in future as well. So AI in every part of our healthcare will be part of our day-to-day life, as we have learned in our presentations. And a family culture is very important when it comes to a provider's point of view is concerned. It is not just the patient-centric, we also need to be employee-centric. So the employee health, employee care, and bringing that family culture within the employees plays a major role to retain these employees because they are highly resourceful and limited resources. So with all the aspects in mind, and we also learned about how we can retain employees with the support, like Mr. Mayank said that there's a pink book that has come up wherein it supports the employees in their workplaces to no harm policy even for the employees. So these are some of the things to sum up to our programs wherein now we have just come to a conclusion on the next generation patient-centered care, where how the future transformation changes that are going to take place. So anything would like to say, Dr. Puri?
I'd just like to thank the audience. I'd like to thank the speakers. I know it's the fag end of the day. For most of you, it might be sounding like a lullaby. But thank you for joining us today and this evening. And once again, thank you for the organizers for having me. The job of the chairman is to occupy the chair. It's the speakers who should speak.
Yes.
Thank you, ladies and gentlemen.
Thank you all. Thank you once again.
Thank you, dignitaries. May I please request you to stand there in the center of the stage for group photograph. A heartfelt thank you to all our incredible speakers, the moderators, and each one of you for being part of this important session. Let's take these insights forward and continue building a healthcare system that is inclusive and above all focused on well-being of every patient.
Excuse me, speakers, we have a question from the...
So my question is, everybody is focusing on improving patient care, these accreditation organizations. There are multiple. I have worked in an hospital in Saudi Arabia that was accredited by JCI. I work in a hospital now that's accredited by NABH, also NABL. CAHO, we undergo all those CAHO training programs. QCI, ISO, all this is there. But why so much? My question is, might have been asked before. Shouldn't all these organizations, these accreditation organizations, have one? There are various standards, various indicators, various objectives. Are they different? Or is it like, oh, I have NABH, if I have JCI, will I be providing an additional patient care? Will it be better? If I go to Australian, will it be better or even more? So my question is, can it all be put together?
Yeah, well, your question is very valid. Why should there be so many countries? There should only be one world. Why should there be so many airlines? There should be only one airline. I think historically, the accreditation movement has been, it's never been a mandatory one. I know of hardly 3 or 4 countries in which accreditation is mandatory by law. Everywhere you have a choice. So here too, you have a choice. Now in India, there are hospitals who have gone for NABH only, others who have NABH plus JCI or NABH plus ACHS. And therefore, you are getting an opportunity to choose what you want and what you can afford. It's also a question of whether they offer something new in addition to what one organization is offering you. That's a moot point. I think there will be certain differences, but the underlying principles remain unchanged. I think I would request you to add.
Yes, I would mirror what you've just said, and I will also mirror healthy competition is good, let's face it. And certainly when the principles from ISQA are laid down, each organisation interprets those in a different way. but it might be more the philosophy of the organisation. So as I mentioned, we have a very strong philosophy around quality improvement. In fact, we train our assessors not to go out being like the police. Sometimes we have to remind them of that because there can be cultural differences when you've got international assessors. So it's, look, you're right, like we all follow the principles of ISQA, but I think it's good that we're all developing and continually improving and changing and bringing in new products and services to support the end game, which is patient safety, having kinder, safer, more reliable care, which is what we're all here for. And how we support you is your decision as to whether you want to take that service from whichever organisation fits your needs. So that's the other thing. I often say that to some of the organisations that we work with. We sometimes choose the organisation as well because we want commitment. So if it's quality improvement, we want to see that there's commitment along the journey. Yeah.
Thank you. I had it in the back of my mind. I just wanted to put it out.
Yeah, just you know, that's a very valid question. I'd only like to re-emphasize the point she has made, and that is, please look for the sign of accreditation by an agency. So that's the point that we are trying to make. So there is a difference between an unaccredited and an accredited hospital. And accreditation, as she pointed out, there is a supreme body, the International Society for Quality Accreditation, ISQA. So look for which organization has ISQA accreditation. One is ISQA accredits your standards. Many organizations have their standards accredited, but ISQA also accredits the organization, like she mentioned about being good in administration. So if you have a combination of a country or country's system of accreditation, which is given that seal of approval by ISQA, that is the ultimate seal.
Great. Thank you.
Thank you.
Thank you very much. Thank you. Thank you very much.
Thanks again. Well done.
Thank you so much to all of you. Thank you.
Thank you to all the speakers.
The Apollo Enhanced Connected Care project
So
has
here is a
redefined
networking which we can
patient
see,
care by leveraging
some collaborations working out.
monitoring.
Meanwhile, this is happening. Can we announce the last set of bingo words for the day? Tomorrow again, we are going to announce 5 sets of words. But for today, we are going to close the session with the announcement of the last set of words, the bingo words. People who are there playing with us till now, I would please request you all to take out your bingo cards and strike off the name, what my colleague takes here now. Everybody, please take out your bingo cards and please pay attention to the words getting announced.
I hope everyone is ready with their bingo cards. The first word for today's session is hygiene. The first word is hygiene.
Same thinking has not been applied.
And second word is healthcare. The second word is healthcare. And the third is communication. The words for the last session of today is hygiene, healthcare, and communication. And with that, we will be proceeding to the paper presentation, but before we start the paper presentation, there's a kind note to all the delegates and guests that tea and refreshments are being served in Exhibition Hall 14A in the ground floor. Please help yourself with the refreshments. We are sure you will be witnessing a brand new innovations and groundbreaking projects at every stalls of our exhibitors, requesting all the guests to please adhere to the venue policies also. And I request all the delegates and the guests here, please visit all the exhibitors, which is in Exhibition Hall 14A, ground floor. And over to the paper presentation now.
Please note, we will be running the paper presentation session parallelly. So people can go out, have their refreshment, At the same time, we will be having the paper presentations running in this particular hall. So I would request all the presenters to be available here. As we announce the session chair to arrive here, they would be called upon to present their respective papers.
Before we call up the session chair, we would take a small moment to announce our sponsors and partners. We would like to have our silver partners, that is Roche Diagnostics, Potso, Boston Scientific, Crescentians Kabi India Private Limited, Red Health, J&J, Siemens, Stryker, Francium Medicals. And on the bronze partners, we do have Merrill Life Sciences, Niva Bupa, MedBlaze, Balt, Mankind Pharma, Viva, Life Science, Alden, and Mayland Pharmaceuticals.
Thank you to all our sponsors. May we begin with the paper presentation? In today's fast-paced world, ensuring the well-being of healthcare professionals and employees is not just a priority, it's a necessity. A healthy workforce translates to better productivity, improved patient care, and a safer healthcare environment. But how do we build a culture that prioritizes employees' wellness? To shed light on this crucial topic, we are delighted to present an insightful paper presentation that explores innovative strategies, challenges, and real-world solutions for fostering employee well-being. Let's together witness the groundbreaking work from the brilliant minds who are pushing the boundaries of knowledge, addressing key challenges, and presenting new solutions that have the potential to transform the industry. Let's applaud the esteemed chair for this evening for the paper presentation. Session Chair 1, Mr. Manoj Roy. May I please request you to join the stage, sir? Mr. Manoj Roy. Mr. Manoj is a seasoned healthcare executive with over 15 years of extensive experience in P&L management, hospital operations, and business development. As an Assistant General Manager of Operations, he successfully managed non-clinical operations at a flagship hospital in Hyderabad. With this, I would like to call upon our second session chair, Dr. Raju Vaishya. Dr. Raju Vaishya, Senior Consultant Orthopedician, Indraprastha Apollo Hospital. Sir, may I please request you to join the stage? Dr. Raju Vaishya, if you're available here around, may I please request you to join the stage for the paper presentation session? Without further delay, I would like to call upon our first presenter. But before that, let me set the expectation. Each of the presenters would be given 10 minutes of time to display their presentation and present on their topic. If everybody is here available, we will start with the paper presentation. So with this, I am honored to call upon the first presenter, Dr. Vinay Kumar Pathak. Dr. Vinay Kumar Pathak, Trauma Center, IMS BHU. He would be presenting on the topic, assessment of the correlation, if any, between knowledge, aptitude, and practices, and hepatitis B vaccination status among different strata of healthcare workers in a tertiary healthcare teaching institute in northern India, a cross-sectional study. Over to Dr. Vinay Kumar Pathak. I would request everybody to please abide by the time which is given to each of the presenter, 10 minutes, followed by the Q&A session from our esteemed chairperson. Thank you.
Thank you. Very good evening to respected judges, session chair. Greetings from the land of Kashi Vishwanath. I'm from Banaras. So my topic already has been informed by the lady. The topic basically, the topic, can slide changer, can I have slide changer? Slide changer. This one? So basically it have three components. First, we have to know about the knowledge assessment and practice of regarding the hepatitis B vaccination or hepatitis B. Second component is the vaccination status of the healthcare workers at the hospital. And third, is there any relationship between them? So overall, there are 40, globally, the stats says that 40% of the healthcare workers who are infected with the hepatitis B is all because of the occupational exposure, like needle stick injuries or other percutaneous injuries. So, but in the developing countries, these reports are somewhat higher. But in developed country, because of the post-exposure prophylaxis and vaccination, mandatory vaccination, it's very low. So there are, as I have said, there are two objectives. First is to know the KAP, knowledge, attitude, and practice. And second is to know the hepatitis B vaccination status of different strata of the healthcare workers, right from doctors to housekeeping workers, including nursing, untrained healthcare workers, and to find out is there any relationship between KAP. If we change the KAP, is there the vaccination status of the healthcare worker changes or not? So it's a descriptive cross-sectional studies. It was done at the SGPGI Lucknow between the October 2022 to March 2023, and the questionnaire we have taken from the pre-structured from Cesc Cabinet et al. That was already published paper, and we have taken the reference from there. So basically 8 questions were from social demographic, 15 from knowledge, 9 from 7 from practice, and 9 from attitudes. And different stats we have analyzed, tried to analyze is there any relationship with the use of cross-tabulation or linear regression analysis. But the main concept of you can say the crunch of the study was only this hypothesis or framework. So what we have discussed is, what we have planned is knowledge. There are 4 variables: knowledge, attitude, practice, and their relationship with among each other. And fourth one is hepatitis B vaccination status. So using the stats, we will search it out. Is there any relationship between them or not? So genders, like 64% were male and 35% were females. And these are socio-demographic parameters which come out from the study. We'll not go with this. These are some knowledge questions because of the, you can say the presentation slides should be in under 10. So I have given the representative part. Knowledge, we have that you can see. Do you think you are at the risk of hepatitis B vaccination? Yes, we are 855. Among like 70, 80%, 75% they said yes. Practice questions and attitudes questions. So vaccination status, so you can see that only 35% were fully vaccinated. Others, they were not vaccinated and either partial vaccinated. So the main, you can say outcome was 35% were only vaccinated. So among the doctors, you can say 63% of the doctors, they were fully vaccinated. And you can say housekeeping staffs, they are only 15% of housekeeping staffs were vaccinated. Patient helpers, they were 17%. So we have made it in a criteria like doctors, trained healthcare workers, untrained healthcare workers. So this is one of the cross tabulation that we have used. So there was in screening, there was a question that have you ever been screened? So that questions we have done with the cross tabulation with the vaccination status. So you can see yes part that 54% of the person were vaccinated. Like if the people were screened off, 50% of the people will be vaccinated. So there was a close relationship between the screening part and the vaccination status. So one outcome of the study was that there was a relationship. But this regression analysis, it is the landmark of the study. So you see knowledge the relationship between knowledge and attitude, 80% is the variability. If you increase the knowledge, 80%, that 0.804 R value, this regression value, 80% will increase the attitude. Knowledge and practice, they have 48% relationship. Knowledge and vaccination, if you increase the knowledge, the vaccination will increase by almost 20%. And if you increase the attitude, 21%. Practice, it will increase by 17%. So at last, like in the discussion part, I have already discussed this 35% were vaccinated, doctors were 63%, untrained staff and trained staff were 19%, and my findings were similar to the other studies like Baek 2015, Kaimel et al. 2020 and Chen et al. But the cross-tabulation already I have discussed that out of 54% of the healthcare workers were vaccinated. If you do screening, the summary of thing is, if you do the screening of your healthcare worker, it will transform in the vaccination status. That this part is also similar to the previous study of Bharat and Sennard. But the regression analysis, the crunch of this very less studies they have done the regression analysis for the KAP and vaccination status. So, but our study, you have seen 19%, 21%. There was a slight positive relationship between that. That is similar to the analysis of Sekan, Arbe, and Bharat others paper. But on the regression analysis, it's very less published article. Very less published article, which is similar to the outcome is very much similar to our studies. And this is the auxiliary finding, is not part of the study I have just given, because the day we have started our KP and all this study part, you see the vaccination status has been increased, drastically increased from October 2022 till 2022. That means if you work on the KP part, vaccination status will automatically shoot up. So on conclusion, the overall positive knowledge were 66% of the healthcare worker, they have a correct knowledge, 69% they have a positive attitudes, and 46% they have practiced, they have a good practice. But the percentage of immunized person were only 35%. So you can say that there is a significant gap in between the knowledge, attitude, and practice. So how we can increase how the ultimate focus is to increase the vaccination status of the healthcare workers. So we can have a central data like vaccination status central data, so that regular reminders can be given. Improve waste disposal trainings, because we have found out the healthcare workers, they used to get pricked with the needle stick injuries. They should have a strong hospital infection control mechanisms. Thank you, sir. Thank you, ma'am. Exactly, sir. Exactly is, yeah, they used to live. Yes, sir. Yes, sir. So what we have done after this, we have got the data, like only 35% of the people were vaccinated. So what we have done is, after this study, we have mandates, like we have started a campaign of 100% vaccination to all the healthcare workers. That has been mandatory. And free of cost, the hospital have provided the hepatitis B vaccines. And outcome of this other study was like that, if you provide a immunoglobulin to one patient, like it's very costly, immunoglobulin are very costly, needle stick if you are pricked with the hepatitis B positive patients. So the cost of injecting immunoglobulin to one person will be equivalent to 705 peoples or healthcare worker if you provide hepatitis B vaccine. Vaccine is only hardly, it's 80 rupees. So, and immunoglobulin, they are 25 to 35,000. So if you compare it financially also, is very, you can say is very cost effective to give mandatory hepatitis B vaccine to all the healthcare workers. NABH, all the accreditation centers, they say that all the healthcare workers should be vaccinated, but still some part of the people, they lack these things. They maybe out of the busy work, busy schedule, it doesn't come out. So what we should do that during the recruitment policy, we should mandate that every person, they should be either vaccinated or they should submit the anti-HBs titer value. So that we are, from hospital administration side, we are ensured that all the person or the healthcare workers working in our institutes are immunized. Because ultimately the cost of immunoglobulin will be, we can save. Thank you, sir. Thank you.
Any questions from the audience for the presenter? Okay. Now we move, yes please, we have a question.
Yes, sir. Sir, is very, it's very emotional question you have asked me. What's the trigger point? Actually, we were doing our masters in SGPGI Lucknow, and during our classes, we have received a call from Dean that one of the nursing students, he got pricked from hepatitis B positive patient, and she was a student of first year or second year, I think, second year. She was on the same day she was posted on the ward. And nobody was there. Like SGPGI is one of the NIF rank in NIF rank. It's 6th institute in India. But at that time we don't have any policy to help that girl. We don't have any institutional policy, nothing at all. So my HOD, he have instructed me, do one thing. Let's work on this part, occupational hazard part. And from that day, what we have, by step, it's a very extensive work. But we have started from that. I still remember that girl. She was a second year, and we don't have any policy to even provide that 80 rupees vaccine. So immunoglobulin part, it was very tough to get that immunoglobulin also, because then we have made a study. We have done a study, and based on this study, several policy now. Because of this study, there is a policy that all the nursing students, they will be in first year only they will be vaccinated, and after that only they will be posted in the clinical area. So yes, that girl was the trigger point. Thank you.
Sorry. All right, so here we call upon the next presenter, Ms. Rashmi Rekha. She is from Jai Prakash Narayan Apex Trauma Center, AIMS. Ms. Rashmi Rekha, over to you for the presentation of the topic.
Thanks, Chairperson. Good evening, everyone. Myself, Rashmi Rekha Deuri, Senior Nursing Officer, AIMS Trauma Center. My title of the study is a retrospective study for healthcare workers, last 6 years of duration, from 2019 January to 2024. And my objective of the study to elucidate the burden and incidence and types of exposure among healthcare workers, and to review and implement the preventive measures for the health and safety of the healthcare workers. So occupational injuries in healthcare workers are any contact with blood or body fluids, that is the risk of acquiring an infection. So needle stick injury are most common in nurses because of the first primary health worker, then doctors, then other paramedical staff. And 3 most common frequent devices causing injury is suture needle and disposable needle during recapping, and blood collection needle. And most body fluid exposure occurs in eyes and mouth, and mostly occurs in emergency department and operation theater, mostly common than other areas. And estimated risk of infection following needle stick injury is hepatitis B 30%, hepatitis C is 3%, and HIV is 0.3%. So this is the SOP which we made after this much of NSI which we recorded. This is the made by Hospital Administration Department, and we are following all our aims. That is, if needle stick injury occurs, after the injury, they wash the area properly with running water for 5 to 10 minutes. If mucosal exposure, they rinse the area. Then inform the area supervisor or in charges. Then inform the infection control nurse also. Then send the baseline sample of the recipient as well as the sources, and give reassure us and psychological support given to the staff. Then after getting the report, we fill the incident assessment form and assessment and management form, and after that we record in needle stick injury register, and after 1 month of record we assess the assessment form and disseminate the report with this format. And in my study, this 6 years, 59 cases were recorded, mostly common in needle stick injuries, then SARS, then splash, then unknown source. And prevalence of occupational injuries among healthcare workers, mostly my studies in doctors, that is 39.9%, nurses followed by 32.9%, then other sanitation staff 8.03%, technical staff 2.1%, then untraceable 15.9%. So after the exposure, the seropositive is 7.6% getting seropositive of the recipient, and seronegative 92.4%. So after the study, the discussion is identify the risk areas and develop targeted prevention strategies to customize safety protocols of the areas with the highest exposure risk, and invest the preventive measures which can reduce the number of injuries and long-term treatment costs, and streamline processes to minimize the risk of injury, and mandatory vaccination for all the healthcare workers, and promote awareness regarding the importance of vaccination, and continuous education and hands-on training for healthcare workers, focusing on the self-injury, safety, and waste management. Thank you.
Yeah. It is a good study. It's a retrospective study. Thanks for taking this topic. It's a very burning topic in terms of employee safety. And obviously, once you are well, we can take care of the patients. Now, as you intervene, as you done the retrospective study, what is the impact after this you observe?
We assess how much injury reported. Then, because of our trauma center is a floating population, 3 months residents are 3 months posting, then continuously floating population. So continuous education and hands-on training given all the staff, and this is the infection control unit. I am infection control nurse, and whichever is posted there, we all continuously education and hands-on training continuously given to the staff.
Okay, but what is the final outcome you see from the employees, and especially the staff nurse or those who are working?
Because trauma center is a very busy area in emergency. There is a pediatric population also and head injury patient also. Thank you, sir.
Ms. Rashmi. Now here we call upon the next presenter, Ms. Mukta Chaudhary, Narayana Multi-Speciality Hospital, Barasat, to present the topic. Ms. Mukta Chaudhary. To present her paper, ladies and gentlemen, we have Ms. Mukta Chaudhary here.
Good evening, respected delegates. Good evening, sir. On behalf of Ms. Mukta Chaudhary, myself, Rumi Roy, I'm quality nurse from NH Barashat. So we will be presenting our topic on screen. Our topic is to assess the knowledge, attitude, practice, and anxiety levels related to mental health awareness amongst healthcare professionals in a tertiary care hospital. So we are all healthcare professionals. We work under tremendous pressure day after day. So we have taken up this topic in our unit since this is triggered because we have seen certain healthcare professionals undergoing certain mental stress pressures due to their extended working hours. And most of them, they neglect actually their healthcare because they sometimes they take it as a stigma that if they are expressing their views, that can stigmatize them in the workplace. So we have taken this topic and we have used our GAT-7 tool, which evaluates the anxiety and depression level, and we have used 5-point Likert scale questionnaires, which is distributed via Google Forms with informed consents to the participants. And there we have put 7 questions from where we have tried to assess their knowledge, practice, and attitude based on the topic. So this is our objective, to assess the knowledge, attitude, practice, and anxiety levels related to mental health awareness among healthcare professionals. So inclusion criteria, we have put healthcare professionals actively working in our hospitals, individuals aged 21 years and above, those willing to provide informed consent for participation. And exclusion criteria are healthcare professionals on extended leave, individuals diagnosed with mental health disorders, outsourced and contractual staffs, participants who did not complete the questionnaires in full. The study design is basically based on prospective observational questionnaire-based study, and we have done it in our own hospital, and it's 1 month of duration, and we have included all the professionals, healthcare professionals working in our hospital, and from them we have extracted the participants who meets our inclusion criteria. So the sample population here we have got participants from doctors, nurses, pharmacists, allied health professionals, physiotherapists, lab technician, administrative staffs. And statistical analysis plan, we have mainly done descriptive statistical analysis, and it summarized with GAT-7 scores and 5-point Likert scale responses. The tools and instruments demographic section includes age, gender, professional roles, years of experience, and workplace settings. GAT-7 scale, a validated tool to measure the anxiety level with 7 questions scored from 0 to 4. Like not at all, several days, more than half the days, nearly every day. Likert questions we have divided in 3 sections: knowledge, attitude, and practice. Knowledge questions to assess the awareness of the mental health conditions and resources. Attitude questions to explore perceptions and stigma related to mental health. Practices questions to evaluate self-care and workplace behavior. It is basically a survey-based study. We have taken the consent survey completion that took 10 to 15 minutes to complete the full survey through a QR code. And we have also maintained the confidentiality and anonymity of the participants. So this is our graphical representation. Here totally we have 3 to 3 responses, and from there we have extracted 171 eligible participants who meets our criteria, and from them we have found 115 who are in the mild stage of their anxiety. That counts to 67% experience varying degree of anxiety, with highest prevalence among females 20 to 25 and 26 to 30. And nurses constitutes the majority of responses, showing significant levels of mild anxiety. This is what we have derived from the results. So here we have the knowledge-based questions. The slide, this is the knowledge-based questions where we have done the graphical representation. So here we can see, as the result says, 20 to 30, female, age group, female, that is 45, 26.31%, that's quite high. So it's our next phase, we will be seeing why it's so. Next slide. Next is our, based on the attitude. Here also we can see, in case of females, though they consider it as their strength to express, but still, as I have said, they feel that stigma on them if they express that. So sometimes they keep it dormant inside them. So that is also female, we are seeing is carrying the higher percentage. Next slide. This is practice. There is a typographical mistake. It has to be practice. We have written it attitude. Sorry for that. So here we can see, again, the dominant group is female. Next. So this is the discussion of the studies. This study found that 67%, that is n equal to 119, which comes under inclusion criteria of medical professionals, experience varying level of anxiety with higher incidence compared to pre-pandemic research. Anxiety was more prevalent among younger age group, 20 to 30 years, deviating from epidemiological trends, women exhibiting higher anxiety score than men. Aligning with previous studies on gender-based anxiety risk, additionally, knowledge, attitude, and practice about the mental health among healthcare professionals was found to be higher. So the targeted health promotion initiative should be developed for emergency healthcare workers, which we have concluded from the study. Regular screening for stress and anxiety symptoms is essential. Strategies to mitigate occupational stress and anxiety should be incorporated. Preventing stress from progressing to generalized anxiety disorder is a key objective. Early detection, enhancing the quality of life for affected healthcare professionals is crucial. Future research should focus on identifying specific stresses. Additional markers and tools should be integrated for more comprehensive anxiety assessment. Frequent mental health evaluations should be conducted for better monitoring, which is very, very essential for all of us, all the healthcare professionals who are working in this sector. So the preventive actions which we have thought of, employee engagement activities, which we are already doing, but we are in process of thinking more of it. Promoting a supportive work environment, training on mental health awareness, encouraging physical activity and healthy lifestyle, anonymous feedback reporting system, which we have already started collecting the feedbacks that why they are facing this kind of anxiety, depression while working in this medical sector. Empathetic leadership and involvement training program. Next slide. So these are the references that I have taken during conducting the study. Thank you.
Any question from the audience first?
Thank you, sir. Yes, sir. Good evening, sir. Hello. Thank you, sir.
Congratulations for your wonderful studies. I have one query. In your results, you have stated about the medical professionals.
Yes. Yes, sir.
And you have segregated the doctors, nurses, paramedical staffs. So in which area the stress level is more? In which professions?
Nursing. We have found dominantly it's nursing, sir.
Nursing only.
Yes.
So again, further nursing also, nurses may be in the ICU, maybe in the OT, maybe in the general ward. So the nurses who will work in the ICU, their stress level will be different from the general ward or economic or whatever the name we have given.
Yes, sir.
You have done it in that particular area also?
So we are thinking it to take in phase 2. We have already planned it, sir. It was a initially survey which we have done. We have extracted the data and now we are planning it to do. Yes, sir. That in which area they are more stressed, which area, what are the trigger points they find. And we are already in process, sir. We are doing it and we will be doing it in our future studies. We have already taken up that study, sir.
Second one, what is your implication of your study then? What is the implication of your study?
The main
Based
thing-
on, I'll just add it. Based on I think what Dr. Parasar is trying to understand
Yes, sir.
is that implications, you did a very good study, you got the
Yes.
findings now.
Yes, sir.
Now, in terms of preventive action, you have mentioned certain things, some of
Yes,
the
sir.
corrective actions you
Yes,
have
sir.
mentioned. But what
What
he
we
wants
have
to understand.
implemented.
Yeah, what you have implemented in.
So we have already implemented yoga sessions. Yoga sessions we have implemented. From our HR, we have taken up yoga sessions for the nurses.
After your study? Or?
Yeah, no. It was already there, but now we have done it weekly, which was maybe monthly twice we used to do. But now after the study, we have already started the yoga sessions for the nurses, certain recreational activities, brainstorming we have started, and furthermore we are trying to do it more rigorously for all the healthcare professionals, those who are facing this kind of anxiety disorder, sir.
Okay, thank you.
Thank you, sir.
Yeah. First of all, I would congratulate Ms. Mukta and your colleague for taking this topic. I think it's one of the topic we generally think, but we don't pursue it further and tend to delay for some reason. A couple of questions from my side. What he has asked, it is very much pertinent about the implementation, what you mentioned, especially the corrective actions, the preventive actions, and all these things. Second is that it is very prominent for the nurses,
Yes,
right?
sir.
Now, you find certain numbers in the doctors as well.
Yes, sir.
Now, I'm not very sure whether the doctors are, whether it is a resident doctors, whether it is a specialist, whether it is a super specialist. Now, that is number one. And the second is, I'm sure there must be certain challenges for correction of the doctors, nurses. Perhaps you will be able to take them some training or some of the implementation you can do. Now, what about the doctors? How do you motivate doctors for the corrective actions and implementation of?
So we have already started motivating our doctors through our medical superintendent. We have taken up certain policies to be made. We have already we are already working on it, sir. If it gets accepted, we will definitely try to motivate even more to the residents, to the RMOs, to the consultants to take up, because we do understand the anxiety level varies from profession to profession. So based on that, sir, we are working on it, and we are. I hope in near future we will be able to convince the consultants and the doctors.
Thank you.
Thank you, sir.
Thank you to the presenter. May we call upon the next presenter here on the stage, Mr. Rahul Anand. Mr. Rahul Anand, Government Kamraj Hospital, Chidambaram. Over to you for the presentation of the paper.
Good evening, judges. Good evening, everyone. I am Dr. Rahul, obstetrician from Government Hospital, Chidambaram, and my paper for today will be The Ripple After the Error, a study on second victim syndrome among India's rural clinicians. To begin with, I start with Albert Wu's quote, "For every patient harmed by a medical error, there is often a second victim. the healthcare provider involved in the error who is traumatized by the event. So this second victim is defined by Scott as a healthcare provider involved in an unanticipated adverse patient event, medical error, or a patient-related injury who has become victimized in the sense that the provider is traumatized by the event and feels personally responsible for the unexpected patient outcome and feels as though they have failed their patients, second-guessing their clinical skills and knowledge base. So what was the need for this study? When we did a literature search, globally only 67 articles were available for the past 25 years since this condition became a valid clinical entity. And there was no data available for Indian clinicians, especially from the rural sector. And there was no information on the baseline knowledge, attitude, and practices regarding this clinical entity among healthcare professionals. So the aim of our study was threefold. We wanted to estimate the impact of second victim syndrome on the various domains of the life of clinicians and to devise a standard operating protocol to incorporate in the grievance redressal committee of the institution and to assess the impact of this support program on the outcome measures. So we did a mixed method study for a period of 6 months in the last year, and we included clinicians working in the public hospitals of Cuddalore district. And the study tool that we used was the second victim experience and support tool questionnaire, or the SWEST questionnaire. This SWEST questionnaire is a validated study tool which contains 29 items divided into 9 domains and is scored based on Likert scale-based responses. Moving on to the results, there was a significant gap in the knowledge, attitude, and practices among the clinicians regarding this entity of second victim syndrome. Although most of them experienced patient safety incidents, 82% of the respondents were not aware of this second victim syndrome as a separate clinical entity. When we did a specialty-wise breakup of second victim syndrome, it was found that anesthetists were more prone for this condition, followed closely by obstetricians. A few salient results include 92% of the respondents had some form of psychological distress after a patient safety incident. 68% felt that a patient safety incident affected their professional self-efficacy in some way or the other. They began to question their clinical skills, they became less confident, they felt that it could potentially ruin their reputation, and also they were concerned about being blamed for the incident. 73% felt that their organizational support was inadequate. And from our study, it was found that peers were 4.8 times more likely to be supportive during a patient safety incident than supervisors. Despite perception of a very high level of support from family and friends, 79% of the respondents were reluctant to seek help outside their workplace environment. This is because majority of the symptoms may not be overtly expressed in a specific manner, as 59% of the respondents only felt a generalized state of feeling off. Just 9% had tangible and measurable clinical symptoms, such as very specific ones like headache or fatigue, which are directly related to the patient safety event. There was, unlike abroad, there was a lot of reluctance among our healthcare professionals to choose an alternate career path following this condition. Although 63% of the respondents wanted to change their current working station, only 4% felt that they want to quit the entire professional domain and go for an alternate career. So based on the following results, we included the following organizational support program into the standard operating protocol of the grievance redressal committee in the institution, which involved the following actions. We decided to offer an immediate timeout to the person involved in the patient safety incident directly so that he might recover. And we also decided to provide access to counseling services, which may be psychiatric counseling to tackle mental health issues and legal counseling to address any medico-legal issues that might follow. And the grievance redressal committee also took it upon itself to intervene during the crisis and to give support as a guidance to continue the professional duties after the particular event and to effectively communicate with the patient and relatives during an active follow-up of the patient safety incident. We also made sure that we have to provide a safe opportunity of the second victim to contribute valid insights to prevent similar events in the future. So, as a result of this organizational support program, which was included in our grievance redressal committee, a lot of the outcome measures showed a positive trend. The unauthorized absenteeism, which followed a patient safety incident, showed a dramatic drop, and the mean burnout levels of workplace-related stress was also showing a small but significantly important drop. And the practice of defensive medicine, like whenever a problem happens related to a patient safety incident, the incidence of of defensive medicine rises. Like we tend to develop a very low threshold for referring cases, and we will be reluctant to take up high-risk cases, and a lot of interventionism will happen just so that we are safeguarded against ourselves. So this defensive medicine is harmful for both the clinicians and for the patients as well. But because of this support program, even defensive medicine came down. And there was a significant increase in the mean job satisfaction score of the healthcare provider after this implementation of this organizational support program. Gynecologist based on Jaipur, and unfortunately she's no more. And the reason for her that she decided to tragically end her life was because she lost a patient due to postpartum hemorrhage through no fault of hers. And her last statement to the world was, "My death may prove my innocence." So the reaches of second victim syndrome can be devastating to the clinicians and to the society at large also. Next slide. So to conclude, in caring for others, we must not forget to care for those who bear the weight of the responsibility of healing. When we support our healers, we strengthen our capacity to heal as a whole. Healthcare organizations must gain a deeper understanding of the factors contributing to second victim syndrome and implement targeted interventions to address this condition. We must create a safe and supportive environment for healthcare professionals through organizational policies. This will ultimately enhance patient safety and well-being. Next slide. So these are the references which I chose for my study. Next. So to all the healthcare professionals out there who may be second victims, please reach out. They can't rescue you if they don't know that you need it. Ask for help to fight for another day. Thank you.
Yeah, any questions from the audience?
Probably the second department. So I just want to learn from you which are the incidents that actually caused the doctor to go in the second victim situation.
From a literature point of view, they have categorized it as patient safety related events, medication errors, and any injury which can happen at an unexpected time.
Yes.
But based on personal experience, I work in a rural maternity hospital, and we are obviously...
No. I was just asking which are the incidents that happened in the anesthesia domain,
yes, sir,
that led to the consultant from anesthesiologist, yes, to go to the second victim situation.
Yeah, we did. We were surprised because anesthetists don't directly get the patients.
Yes.
So they most of the time they see them at the assessment clinic or on the table. So they have very little time to interact. And when such a patient develops a complication, what we were thinking is it's quite unlikely that they should develop this second victim syndrome. But the most common problem which the anesthetist face is an intraoperative complication, like a non-table arrest or a non-table nervous dysfunction or a non-table death. So when that happens, it shakes their morality, and they become really affected. They go on long absenteeism, and we don't have the resources to actually combat this. So we do not give them leave. So we pressurize them into continue working, and seldom they have explanations for the event. Anything goes wrong in the table, they very rarely have answers to explain to themselves or to explain to the patients and attenders. So that puts them under a lot of stress, and they are more prone for developing this second victim syndrome.
Yes. Another question, since they are not the first-hand clinicians,
yes, sir,
especially the anesthesiologists, they will be seeing the patient just before operation. So it actually unfolds many other associated situations also, whether the PAC was done or not, whether the immediate PAC just before operation was done or not, or the surgical safety checklist was properly maintained just before operation or not. So these are the key situations probably you must have studied as a continuation of your study. So those are the things which are very, very important when like anesthesiologist or like the second clinician who are not directly into the patient care. Of course, anesthesiologist is the clinician who actually treat the patient for the operation side, but not like the first clinician who actually handles the patient. So those are the things probably you have to look into just to address those kind of situations.
Yes, sir, that was what we were also surprised because the global literature, the anesthetists were somewhere in the 6th or the 7th place only. The critical care physicians and the intensivists, they were ranking highest in almost all the studies which we studied.
And especially
and
the surgeons,
pediatricians also ranked
surgeons.
higher, and people who were geriatricians, oncologists, so these specialists were ranking higher among second victim syndromes because they get involved with the patients more. So that was what we were surprised to note, that anesthetists were facing this problem. This could be a local issue also, sir, because that particular specialist of anesthesiology is almost always vacant in our centers, and there is a lot of need for them. So they are already under a lot of stress, and anything which goes wrong, which they are not able to explain, it hits them more harder. So maybe that's why the relative proportion of anesthetists suffering from second victim syndrome is high in my study. But in the global literature, they are ranking quite behind.
Yes. So if the anesthesiologists are involved in the second victim situation, it actually talks many other things like PSC, immediate PSC, or the machines which are
multifactorial.
Yes, multifactorial. So that one thing I wanted to highlight. That second thing, how these issues to be taken in the grievance handling committee. Ideally, it is the grievance handling committee takes up those issues which are raised by somebody. Complaint is given to the committee, then committee will sit and decide and discuss. But in these type of situations, how to take up those issues which are not being reported or not being given as a complaint to the committee?
Sir, we wanted this to be part of the institution's protocol so that these incidents may be recognized. What usually happens is a lot of blaming and shaming happens when something goes wrong. So that already a traumatized clinician will have to face that also from the organizational side, and from the patient and relative side also they will be facing backlash. So to combat that, the organization had to do a massive transformational change in the way they handled these issues. So whenever a grievance was raised from the patient side or from the hospital side, or whenever an audit was being conducted, we tried to make sure that we were supportive and we were not assigning blame, and we were more into fact finding rather than fault finding, so that the organizational support will help them recover from the second victim entity faster and resume their clinical activities in a more efficient manner. And very rarely the second victim's inputs will be taken into account, sir. So we wanted that also to be changed. So since they were directly involved in the incident, their inputs will give us more insights to prevent similar events happening in the future. So we made sure that they are also part of the discussion in a healthy way. So all these changes we incorporated into the standard operating protocol of the hospital, and it has definitely shown results.
Thank you, doctor. I really appreciate you for taking up this issue.
Thank you, sir.
Thank you.
Just a couple of questions from my side. First of all, congratulations for taking this. It's really somebody needs a lot of courage to take up those
Even
issues.
we didn't know that this word second victim was there in medicine, because it was not there during our training years. It is not talked about in our society also. This was discussed in last year's IPSC. So that's when we realized, okay, so we can study about this. This was something new. So that's why we made it a point to do the study.
So I saw the impact. What you mentioned is almost like 32% to then I think there's a 54% I think post-intervention which you mentioned. If I talk about particularly the rural areas, this intervention from 32 to 54, it's a very big achievement, I would say. I'm sure the continuation of this work is already going on, and it is further working. Is there any reference to you in the urban areas for the similar?
Not in South India, sir. Not in India, in fact.
Okay.
Majority of the tertiary care hospitals and most of the studies were done in very niche hospitals like cardiac centers, trauma centers, oncology centers. And I couldn't find anything specifically for a maternity center. I'm a gynecologist. I work in a rural maternity hospital. Okay. So I couldn't find the study which was in the global literature for a maternity wing. And for a general hospital also, the study was not available because most of the studies which were done are based for super specialty wings, which are very niche wings like neurotrauma centers, cardiac ICU centers, like that centers only they have done the study.
Okay. So do you find any change in the kind of result that you got? For an example,
one major change which I found was in the rest of the world, especially in the Western literature, many of the clinicians opted for a change of profession. Many of the healthcare professionals decided to switch careers, but that was starkly absent in our setup. So, however stressed the healthcare provider was, they didn't want to change the profession. Right. They decided this is our life, we are stuck with this. 63% agreed that they will switch the workplace, but only 9% told they will even consider changing the career. So that was one major thing, the flexibility of entering into another profession, even early at the start of the career, was not available in our Indian context. So that was one major difference which I could find, sir.
Thank you. Thank you very much.
Thank you, sir.
Thank you. Thank you to the presenter. Here we call upon the next presenter, Dr. Lucky from Amity University, to present his paper, please. Dr. Lucky Sharma. Her paper, please. You're Dr. Lucky. So we have Dr. Lucky here. Over to you.
Good afternoon, everyone. Myself, Dr. Lucky Sharma, and I'm honored to present my study, the research cycle, feasibility, benefits, and challenges, mental health screening into AHC, a path forward. This result highlights the importance of integrating mental health assessment into routine health checkup to enhance patient safety or employee safety and overall patient well-being. The methodology which I use is a questionnaire-based study. The objective of my study, can you please change the slide?
May I please request? Thank you.
To evaluate the effect on patient safety of untreated mental health, to evaluate if patients are open to having their mental health screening, to look into how screening impact patient safety result, and to consider a cost-benefit analysis. Change the slide, please. Yes. The need of this study, the mental health significantly influences overall health safety. Undiagnosed mental health disorder can lead to adverse health outcome, compromise patient safety, and higher healthcare cost. The study addresses the issue by focusing on a critical patient safety concern, providing data-driven evidence, promoting patient-centered care, or demonstrating economic value. The benefits of integrating mental screening are in early identification and intervention, reduce stigma and improve health-seeking behavior, enhance patient-provider communication, improve overall health outcome, and reduce healthcare cost. The challenges and consideration. The challenges and consideration which I get, the provider training and resource allocation, standardization and implementation, privacy and confidentiality, addressing stigma and promoting acceptance. The key aspect, the mental health screening which I get my study was feasibility. Addressing mental health is a key factor in patient safety. Benefits, it's a early detection, reduce stigma and improve health outcomes. Challenges which I get, the training and privacy concern, finding strong patient support, emphasizing improved healthcare experiences, cost analyzing, long-term cost effectiveness, overall mental health screening in routine checkup can enhance patient well-being and safety concerns. They highlight the benefits of mental health screening are early identification to prevent complication while improve health outcome, enhance the effectiveness, reduce stigma by normalizing mental health discussion, and provide better provider communication, improve diagnosis. Additionally, lower healthcare costs result from early intervention, reducing long-term expenses. The challenges, which are privacy concern, cost, standardization, and stigma. The solution, which are insurance coverage support and training program for the provider and the patients, validated screening tool and campaign to normalize mental health screening. The conclusion of my study is incorporating mental health screening into annual health checkup is a crucial step toward holistic patient-centered care, early detection intervention, normalize mental health discussion, contribute to better patient outcome, reduce healthcare cost, and improve safety. Thank you.
Did this, first of all, once again another topic which is rare at this moment, and especially into where we are including or you want to include it in the annual health checkups. Obviously the privacy issues, the conscious, the awareness is definitely there will be some challenge. But do you find the resource allocation is available in terms of if you include this as a path screening, as you mentioned, as a path forward, do you think the resource allocations and availability of resources is adequate to take this forward?
Well, while I'm doing my questionnaire, then there is a resource which will be available. If we have to resource like insurance coverage and all that, there is available.
Any question from audience?
Doctor, my question is that can you highlight that how mental health screening reducing the healthcare cost?
Now I didn't get this study I did during my internship, that recently it is not implemented. I just, the recommendation I have just done. I didn't have that implementation data. I have provided to my hospital.
So what is, what guidance have you got for recommendation?
I have provided the recommendation which I have provided to provide a regular healthcare provider training. So which when there is a procedure of that the privacy concern which could be minimized, and awareness campaign which can be done for the employees or the patients which are coming to the hospital. Because mental health is a very stigma for all the people who are getting coming to the hospital. They didn't want to tell about they have any stress or any kind of mental problem. That's why the campaigning and the training which is needed.
Okay.
Here we call upon the last presenter of the day, Professor Saurav Singh, who has already presented a paper, has another paper to present. May I please request Professor Saurav Singh to be here on the stage from Trauma Center, IMS BHU. And this is the last paper for the day, ladies and gentlemen.
Professor Saurav Singh is my HOD, and because of obligation 2025, I'm able to hear. I will, on the behalf of him, I will present that.
So the study was seroprevalence study on anti-HBs antibodies among the healthcare workers, a cross-sectional studies. So as we know, anti-HBs titer is a very crucial serological indicator towards the hepatitis B vaccination. If you have done a hepatitis B vaccination, you should at least during the COVID also, we have done we have done the antibody test to know the titers of like how much immune we are towards the COVID. Same like in hepatitis B also, as different guidelines, they say that all the healthcare workers should be it should be immunized towards hepatitis B. So the data shows like 40 to 65% of hepatitis B vaccine amongst the healthcare workers are in developing countries, and only 10% towards 10% of the healthcare worker in developed country. So our study, we want to know what is the quantitative analysis or level of anti-HBs titer among the different strata of healthcare workers. So basic baseline we want to know. And is there any relationship in the time elapsed? So why we have done this study, need of the study, we have taken two studies in the reference in Mahawal et al. What they say that the productive antibody levels were in the first year and %. So there was a drastic decline in the antibody titer of the healthcare workers. In second study, Batra et al., they said that the level of anti-HBs that is below 10, where after 5 years it was 36%, and after more than 5 years were 36, and within 5 years were 24%. That means the time, if the time elapsed, the antibody titer goes down. So we have planned to do a study on this. It was done at the Thomas in the month of June 2024. Different healthcare workers were taken in the studies, and at least who have done 2 years of post-vaccination period were included. At least they should be vaccinated. No? And different stats we have used to know is there any relationship between the time elapsed and anti-HBs titer. So overall the participants were 436 healthcare workers were there in the study, and out of that 35% were female and 65% were male. This is the, you can say, the most important slide of the presentation. Among the 436 participants, 16% of the participants were their anti-HBs titer were less than 10. That was alarming. That they were not knowing that their vaccination is their anti-HBs titer is below 10. They are already working in the healthcare. They are thinking that they are fully immunized, and when that anti-HBs titer we have done, they came to know that 16%. That number is 69. 69 healthcare workers were under immunized, and you can see 49, 11% people, healthcare workers, they were in the borderline, 10 to 50. And second one is 50 to 100 international unit were around 7%. So there are, and you just see 230, 50% of the healthcare worker were fully immunized. But there is a you can say a trend towards going under 10. So if we see the slides, 2 years to 5 years. So total, the healthcare worker who were vaccinated 2 years to 5 years, they have vaccinated. So they were 181, and amongst that 90% the titer were more than 10, and 10% their titer was below 10. That is the border mark you can see. 5 to 10 years, you just see it's come down to 81. From 90%, it's come down to 81%. And the last one is more than 10 years. If you are vaccinated more than 10 years back, so around 32% were below the level of 10. So there was a close relationship, and in the ANOVA test also, it comes to be significantly reduced. So our study, we have in the comparison to Rao et al. Or Batra et al., it was similar that overall our sero protection rate was 80, because 16% were under immunized. So 84% were seroprotective. That is similar to the other studies like 89% and 70%. in our present study, 81% of the subject were protected 5 to 10. That I have already shown in the slide. And 68% were protected in the 10, if you are vaccinated 10 years back. So the study, our study's finding is similar to Mahabal et al. Also. That also shows that in different study also, that as the time elapsed, the anti-HBs titer comes down. When we have done the correlation, Pearson correlation, that shows there is a negative linear relationship. There was a negative relation. As the time passes, the anti-HBs titer comes down. So the value is minus 0.23. Significantly, that was we have found. It's also this decline of the anti-HBs were also similar to the Iran studies and study of Jafar Day and Montez Jafar. So the outcome, you can say that outcome of the study is like we should do a periodically monitoring of the anti-HBs titer. Whether it's a very it's not so it's a very cost effective, you can say. Anti-HBs titer is the cost of anti-HBs test is around 600 rupees per test. No? So, but these 16 people who were thinking that they were fully immunized. And after that, after this study, these 16 people were given a booster dose, and they were now we can ensure that from hospital administration side that our healthcare workers, they are fully safe in their work culture. So limitation of our study was like that we have not compared with the immune system or any risk factors like smoking, nutritional status or chronic infections or the site of administration. We have just taken the data for time elapsing and the level of anti-HBs titer. We can work on this part also. We should think about the immunological response of the people also. So the conclusion of the study will be the proportion of the subjects who were unprotected 5 to 10 years and more than 10 years after the vaccination was 19 and 32%. That means during the 5 to 10 years, the unprotected people, healthcare worker, were 19%. It raises to 32%. That directly shows that as the time passes, the anti-HBs titer comes down. So this study offers a thorough evaluation towards the anti-HBs seroprevalence among the healthcare workers at the trauma center IMS BHU and presents an opportunity to enhance the hospital preventive strategies against the hepatitis B infection. So basically what we think is like every study, it should have an outcome, so outcome to the society. So immediate our response, or you can say immediate our response of our study was like that the 16 people who are they were unknowingly, they are working hard and they were not known about their immune system. They were cast, and this near people also, like the level, the anti-HBs titer that was between 15 to 100, 10 to 15, they are also some alarming. So we can say that after 1 year or 2 years, either you can have your immune response antibody test, or you can take it directly a booster dose. Thank you. Thank you, sir.
Yeah. Audience, any questions? Okay. The present study, if I saw correctly, the study, the sample size was 166.
Sir, no, sample was 436, sir.
436. And the present sample size, what was the sample size? One of the slides.
That is need of the study. We have taken reference. Like in that study, 112 people were there, okay. And the trend was there. Like how we came to why we want to assess the anti-HBs titer level. The question for that was we have first assessed what literature says. So in two studies, see that in two studies
Sample size was 112 and something like 146 was there. But our studies, the sample size was 436, total 430. Out of that, 35% was female.
Okay. Roughly, suppose from the trauma center, I think most of the sample size is the trauma center.
Yes, sir.
How do you find the equation? Equation in the sense, how many from the doctors? I mean, just a rough,
Yes, sir.
rough guess from the sample. How many doctors, nurses, and the rest?
Yes, sir. So that's division of the profession one, division of the profession, we have not included in this part. We have, because that was a very, you can say, we have organized a camp and we have not taken the designation one overall. So in our studies, maximum part was from nursing professions. You can say, like I can't quote the exact percentage, but mostly the healthcare workers were from nursing professions.
Okay, because one of the slides you have shown the age ratio, I mean the sex ratio that you have shown from the male and
yes, sir,
female. I think the male percentage, it was 60%.
60%.
So if the sample size is more on a nursing side, I think that percent also,
yes, sir,
should say the similar sort of.
So we have our nursing profession, mostly we have males. Yes, sir.
So much. A sincere thank you to all our presenters for their dedication and hard work, and to our moderator for your engagement and thoughtful questions, Mr. Manoj Roy. I really thank you. Let's take these ideas forward, challenge the status quo, and continue shaping the healthcare of tomorrow, a future where innovation truly serves humanity. With that, we conclude the session for today. Enjoy the rest of the evening as we host award ceremony. Thank you and have a memorable evening. Thank you. May I request all the presenters to be here on the stage for a group picture? Quickly, we'll take a group picture. The session chair and all the presenters.